Thank you for joining us for the 13th Annual Alzheimer's Awareness Conference. My name is Jaime Constable, and I'm the CEO of the Alzheimer Society of PEI, and I am delighted that we can be here together during Alzheimer Awareness. We can't do the work we do here in PEI without the generosity of our sponsors. So I just want to take a very quick moment to thank our title sponsor and courtyard sponsor, Bayshore Home Health, our gold sponsors, the Provincial Home-Based Care Program, ASPEI, and PEI Hearing Consultants, as well as Bronze and Winslow Room sponsor, Harding Medical. I would also like to thank Folks Productions. You can visit the booth at the back, as well as Andrews Senior Care. We appreciate deeply your partnership and support of these events. I'd also like to thank our media partners, Saltwire, as well as Eastlink Community TV for being here today and for sharing the conference on Podium TV. So these sessions will be televised on Eastlink Podium TV. So opening our conference today is an illustrious island storyteller from the famed former Four Tellers and this summer's sensational Two Tellers hosted by the King's Playhouse. Has anybody here been? It was great. What a good time. If you haven't been to the show, I took my mom recently and we had a lovely time. So this man, he grew up in Morel. He now lives in Stratford and he's a lawyer with the Federal Department of Justice. And he's also the new president of the board at the Alzheimer Society of PEI. Please join me in welcoming Gary Evans.
I'm going to assume volume's not going to be an issue for me. Illustrious island storyteller is so much more pleasant to hear than bald-headed lawyer. So I'm going to start on a positive note. So good morning, and thank you all for coming here today. A special welcome to the families and to persons who are living with changes to thinking and memory, and to the healthcare providers that are with us. As Jaime pointed out, I've been a board member of the Alzheimer Society for 2 years and just recently been appointed as president. Like many members on the board, my journey to the Alzheimer Society was the consequence of a 10-year journey with my mother, who passed away 5 years ago, well, 5 years ago this Halloween, with Alzheimer's. Now, when I was driving out here today, I was going to tell one story. And then I thought about something while I was on the Hillsborough Bridge for 45 minutes. I'm going to tell another story instead, and I'm going to talk about the journey, just a brief overview of our journey. But I have to go back to the fact that I was a lawyer and very quickly became interested in personal injury. And personal injury, for those of you who don't know, you know the commercials in the United States, let me be your SLB, I'll get them for you. That's what personal injury is, right? But it's soft tissue, whiplash, car accidents, injuries on work sites, things like that. I quite enjoyed it. And as a young lawyer, I was taught how to do this. And one of the things they told us to do was you get your client to keep a pain journal. Now, a pain journal is where you record things that you can't do. My kids wanted to go play ball, but my neck was so stiff I couldn't do it. But jot that down, put a date on it. And then you take that back after doing this for 2 years or 3 years, because these things take time to settle. You take it back to your lawyer, and then your lawyer uses it as part of his evidence to do your claim. So after I started doing a number of these claims, I realized that that was one of the most damaging things I could do to one of my clients, is make them think for 2 to 3 years about what they can't do. So I turned it upside down. I said, okay, if a person came in with an injury, I'd say, you have to agree to go to the gym. I have a deal set up with 2 gyms. I'll get the insurance company to pay a 6-month membership, and you're going to see a personal trainer once every 2 weeks for the duration of that 6 months. If you agree to that, I'll take your case. Well, the word quickly spread through the adjusters and through the doctors that that's what I was doing. And then all of a sudden, my practice took off because all the adjusters wanted to deal with me, and doctors' reports were coming into me very, very quickly because I wasn't asking for this big, I wasn't trying to make things what they weren't. I just simply wanted the doctor to tell us what the facts were. So his reports to me would be 3 or 4 paragraphs, not 25 pages. So when my mom was diagnosed, and as she started her decline, we spent a lot of time at the hospital. I did, my sister and I did. I was there 3 times a day. My sister was there for 2 or 3 hours every day. And what I kind of noticed was when she was there, everybody was kind of asking her questions that she didn't know the answers to, right? What time is it, Anita? And she had the standard answer. I've been retired for 15 years. Every day is Saturday, right? That was just, she didn't even know what that Saturday was, but at that point, but at least she knew that much. So I saw that it was discouraging for her to constantly be asked questions she didn't know the answers to. So when we would sit down with mom, we would guide her through to happier times. I'd ask her if she remembers her horse, Big Jim, the Wonder Horse. The only horse in PEI that lived primarily on apple pie, as far as I could figure out. She had a great big Newfoundland dog called Alice, and Alice was just saliva all over the place, but she loved Alice. And so when you talked about that, she would engage in the conversation and she would tell you things. And she would tell us stuff about her youth. She grew up in London, England, that we never knew about. I found out that her grandfather, her paternal grandfather, his first name was Valbraith. So I did a fact check on that one, and she was true. My great-grandmother held this infant and said, I think we'll call this baby Valbraith. Anyway, I say all of this to say, and I think the good Dr. Stultz here is going to support this in storytelling. We told some stories, so she told some stories, and you could see it in her face. Her eyes would dance when she would remember the things that she remembered. That's what I'm going to remember about my mom. So I guess I should keep quiet now. But anyway, the question for us here today and for everyone else is, how do we change the current storyline? What we need here is additional treatments. And to be honest, we need a cure. We need the earlier diagnosis, and we need a cure. Now, there is hope. And that's the positive. I wanted to talk about a positive side about dealing with mom, because Dr. Vitali is coming up here, and there is hope. As we learn more and more about this from his presentation, I can assure you that the board, and as an organization, we're committed to doing all we can to support persons and families impacted by dementia. We've grown a great deal in the last few years, and will continue to expand and adapt to meet the needs of Islanders. Thank you all very much for coming today. I hope you have a great day.
So as we shared at our last conference in January, if you were here, the first disease-modifying treatments are coming onto the markets around the world. Right now, both medications, lecanemab and donanemab, are currently being reviewed by Health Canada. And while they're not available in Canada yet, these disease-modifying therapies are on their way, as well as others. But there are a number of issues that we need to solve so that if people choose to take these medications, that they are in fact able to access them. There are several puzzles that we need to solve, and one of them is the need to move the needle towards an earlier diagnosis. The new treatments that are coming are really only effective in the early stages of illness of Alzheimer's. And there are numerous reasons why people are not being diagnosed until towards the middle stage. Sometimes it's a lack of awareness of the early warning signs, how to recognize what's normal aging versus dementia. In some cases, there's quite a bit of fear and stigma of the illness, and so people will be in denial, or they'll want to delay as long as possible. And of course, we know that there can be issues accessing clinicians and specialists in terms of waiting times, or just even those clinicians feeling like they have the expertise to diagnose and manage dementia. But we also need new tools, resources, and technologies to help us to get there. And here to talk about this and advancements in these areas is Dr. Paolo Vitali. He is an assistant professor at McGill University, the Department of Neurology and Neurosurgery, the Faculty of Medicine. He's a board-certified neurologist and a registered neuropsychologist. He is staff neurologist at McGill University Research Center for Studies in Aging and at the Douglas Mental Health University Institute. His clinical and research focus is on acquired language disorders, or aphasia, due to neurodegenerative diseases. And he is using biomarkers to better characterize neurodegenerative diseases and establish an early diagnosis. He's involved in different clinical trials, running tests, different trials that are running that are currently testing anti-amyloid and anti-tau drugs against sporadic, late onset, and early onset autosomal dominant Alzheimer's disease, which means the genetic forms. He is also implicated in academic and public initiatives devoted to increasing dementia awareness, knowledge transfer regarding healthy and pathological aging to the general elderly population, and provides support to caregivers. So please join me in welcoming Dr. Vitali here today.
Good morning. Bonjour. Thank you very much for inviting me here, Jean. Thank you very much to Alzheimer Association. So I'm going some potential conflicts of interest here. I'm running clinical trials and devoted to developing therapies in Alzheimer's disease individuals. So I'm going to discuss about biomarkers here today with you. I know that some of the topic I'm going to discuss will be quite far from the reality that you are living here on the island. But I think it's important with this presentation maybe to try to improve and develop further the possibility that you could eventually use in the future to take care of people living with dementia. The Alzheimer's disease has been defined as the disease of the last century, but probably will be also the disease of this century. And as you probably know, we are going to listen to this data many times today. So we are now more than 700,000 people living with dementia in Canada, and this number is expected to double, maybe more in the next 20-25 years. Most of them are women for still unknown reason, probably a combination of social, demographic, economic, hormonal, and probably also genetic components. We don't have to forget people with early onset dementia, meaning dementia which starts at age 65 and early. They represent a unique population with specific needs. And we can't forget also that a significant increase in people living with dementia number, especially in people with indigenous, Asian, African, and Latin ancestry. Alzheimer's disease is among the major killers, is the only one actually mortality is increasing over time. So it's representing a real issue. It's been defined as a major killer. You probably know that dementia is a non-specific term, and most of the cases of major neurocognitive disorder are attributed to Alzheimer. More than 60-70% combined mixed pathology in Alzheimer as well. So the importance here is trying to distinguish this pathology, specific pathology, Alzheimer's disease, from the other pathologies which can affect the cognition in our patient. So I want to introduce a short clinical scenario here before going further. I'm going to present a classic case that I usually see in my clinic almost every week or every day. So a 62-year-old right-handed man, quite good scholarity, high functioning, high level of functioning, without no significant past medical history, but with a strong family history of dementia and mental health issues. He was good at school, no learning disability. Oops, sorry about that. But over the past few years and probably the past couple of years, he experienced some decline in some issues, more than decline, some issues in memory, in the executive function. He also experiencing some difficulty with day-to-day tasks, and some also some maybe some depressive symptoms linked to a restructuring of his company. He lost his job, so a little bit more anxious, irritable, aggressive in report to his wife, and judgment seems a little bit diminished with some impulsive behaviors. He's still very autonomous in activity of daily living. He has some difficulty with words, proper names, not anticipated or inappropriate, no addiction, no symptoms for frontotemporal degeneration. The cognitive screening is still pretty good with some, he lost 2 items on delayed recall. But overall, the screening test is very fast. The neurological examination and the basic workup, including the CT scan, is normal. MRI shows some microvascular changes, possible the lacunar stroke. So this is classic case. Is a neurodegenerative, is beginning of a neurodegenerative disease such as Alzheimer, the classic amnestic form. This is kind of depression, adjustment disorder because he lost his job, some microvascular component, the wood stroke, or a decompensated attention deficit disorder as indicated by, I think, the primary GP. So this is a clear classic examples, and this is going to use further during my presentation to highlight the importance of biomarkers in order to early diagnosis and manage this example of case, especially in this fantastic era where we are living, in which disease-modifying treatment would be possible soon be available for our patients. So biomarkers. So what is a biomarker? So in medicine, we define a biomarker as a substance present naturally or introduced into an environment like the organism, which we can detect and track over time in order to make a diagnosis or to study a phenomenon. So it's clear definition. Why we need a biomarker? Because dementia or major neurocognitive disorders, now this diagnosis is an umbrella term. Okay, so there are many etiologies, including Alzheimer, which can contribute to the major neurocognitive disorder. We have Alzheimer, mixed dementia, vascular dementia, frontotemporal lobar degeneration, Parkinsonian dementia, late diagnosis, Huntington disease, normal pressure adolescence, alcohol-related dementia like Wernicke-Korsakoff, Creutzfeldt-Jakob. So we need something that we can use easily to detect in a single individual the right pathology underlying. Because as you for sure you know, Alzheimer's disease is a specific neuropathological condition characterized by the accumulation in the brain of amyloid plaques and neurofibrillary tangles. Alzheimer's is a protein movement, as we usually calls the combination, the accumulation of normal proteins, which became abnormal over time. And the amyloid plaque are extra neuronal, contrary neurofibrillary tangles, which is a combination of accumulation of phosphorylated tau protein and accumulates inside the neurons. And over time, the combination of these two pathological elements will lead to neural damage and atrophy and neural death. We now know there is an additional component to the pathophysiological cascade underlying the pathophysiology, which is the neuroinflammation. We probably know that the neuroinflammation it's an early phenomenon, probably associated with the initial accumulation of amyloid pathology. and can the accumulation of amyloid can trigger astrocyte and microglia activation, and ultimately be associated with the phosphorylation of tau protein. So the traditional definition of Alzheimer's disease was based on the impairment in at least two cognitive domains, like memory, language, judgment, reasoning, with associated impairment in functional activity, which progress over time. Okay? And this is give us the definition, the diagnosis of possible or probable dementia due to Alzheimer's disease. It was a clinical pathological definition. So it was based on the clinical exam, on the questionnaire, the neuro exam, and some basic blood and imaging like MRI. But the definitive diagnosis was only possible post-mortem, the autopsy, when you cut your brain slices and you analyze specifically for amyloid and tau pathology. Which is the limit of this methodology. We know now for sure that we are not good in identify Alzheimer's in our patients. Even the specialists like me, we see patients every day with Alzheimer's. In our clinic, we have at least 30% of errors, mistakes when we try to say that this is for sure an Alzheimer's disease. We were wrong. The pathology is not confirmed. So the clinical presentation of classical amnestics or memory presentation of neurocognitive disorder, which progress over time, you're pretty much sure this is Alzheimer's disease. Finally, it's not Alzheimer's disease. So this syndromic approach is non-specific and non-sensitive. We can also have a different presentation of Alzheimer's disease, for example, the language, the visuospatial, the frontal variant, as we call it, characterized by lack of judgment, profound executive functioning. So all of this could be ultimately Alzheimer's disease as well. So we are not good at all in identifying only from the clinical profile the right pathology at the end. So we need some tools, okay? And over the last probably 20 years, there's been an amount time in research spent to try to isolate the biomarkers, which can now detect in vivo the typical pathology of Alzheimer's disease, like the plaques, the amyloid plaques, and the phosphorylated tau proteins. We can detect this in the we call this specific to AD pathophysiological biomarkers, or non-specific, meaning that it can contribute to the cognitive impairment, but they are not specific to AD pathophysiology. We are going to see these biomarkers more in detail. We start from the non-specific biomarker to AD pathological changes. First of all, is the brain atrophy. When you look at the scan, whether an MRI, you look at the atrophy of the brains, the losing volume, the neural death, the cellular death. All of this is underlying the all kind of neurodegenerative disease, including dementia, but not only dementia. We have some visual rating system. We can able to identify specific region of the brain which are supposed to be more involved in pathology, like the hippocampal structures, which are the regions deep in the brain, which are responsible for encoding and storage, most the new learning. So the structure is definitely affected by, specifically affected by AD pathology. So we are now able to detect it, but it's not specific to Alzheimer's disease. We can have also look at small vessel disease, the white spots that you see on this slice of brain MRI. You can easily see this in many neurodegenerative diseases, including Alzheimer's disease. You can also have a recent stroke, in old lacunar stroke. You can have no specific white matter hyperintensive, meaning some inflammation or underlying inflammation eliminating the disease, some perivascular space, so associated with Alzheimer's disease, some microbleed, some minor bleeding in the fragile vessels, which can observe in Alzheimer's disease. So all of these are no specific features underlying IPT pathology. For sure, we can also ask for a FDG PET scan, which is an imaging technique which measures the metabolism of the brain in accord to the pattern of high metabolism we observe. We can somehow be able to say, this is more similar to AD pattern, or this is more similar to vascular pattern, or frontotemporal lobar degeneration. So we can have a appreciation of the way of the brain is functioning based on the metabolism of the glucose, seen by this important technique. PET scan, I don't know if it's available here, the island, but it's quite costly. There is a significant amount of irradiation. The sensitivity is quite good, also in the early stages. Specificity is not fantastic, so we can be wrong. On this exam, it happens often, but we have discordant results with specific biomarkers and PET scan. But we ask this test in complex cases when we are not sure about the neurodegenerative etiology of the clinical presentation, and try to orient also the differential diagnosis. So we move on to the specific biomarkers to AD pathological changes. And for sure, you are aware about the technique of lumbar puncture, lumbar tap. We are going to analyze the CSF, the cerebrospinal fluid, which surrounds the brain and the spinal cord, and we can gain a lot of information on the CSF surrounding the brain. You can analyze for inflammation, for virus, pathological organisms, but also for specific AD proteins like amyloid and total tau and phospho-tau proteins, which tend to accumulate in the cerebrospinal fluid. So to be honest, I do this, I like this procedure a lot. I do it regularly, many times a week in my practice. Most of the time, by far, not painful. I would say a little bit with some discomfort sometimes. Sometimes people can also sleep during the procedure, but it's quite easy and pretty much safe. Okay, so we are going to analyze in the CSF specific proteins to the Alzheimer, the amyloid beta 42. The total tau, which is non-specific measure, and the more specific protein, the tau phosphorylated. Okay, and the normal, the classic pattern associated with Alzheimer's disease is that decrease in A beta 42. Why there is a decrease in amyloid beta in the CSF? Because the amyloid beta tend to accumulate in the brain, in the plaques, so the release into CSF is reduced. On the contrary, when we have a lot of neural damage, the neuron tend to release in the circulation and ultimately in the CSF a lot of tau and phosphotau. So the classic pattern is a decrease in A beta 42 and an increase in tau, and more specifically in phosphotau in the CSF. So this pattern, when we see this, is by far most consistent with an AD etiology underlying the cognitive deficit in our patients. You can combine the different patterns. You can do a ratio AB42 on tau on AB42 on other form of amyloid beta, but ultimately these are the components which characterize the beat pathophysiology. There are also some guidelines when to ask for this specific test. Usually, it's not indicating asymptomatic. It's indicated for people who present symptoms. Could be subjective cognitive decline, mild cognitive decline, or early Alzheimer's disease, early stage Alzheimer's disease. When we want to differentiate, for example, between a frontotemporal dementia or an Alzheimer's disease with some overlapping clinical features, it's a good candidate this way as well. Yeah, but it's not recommended for asymptomatic individual, at least they are not involved in some clinical trials. Okay? Amyloid, so imaging is a very good technique to highlight pathology related to Alzheimer's disease. So we are not able to image the amyloid plaques. Okay? You can see on the my left side the red color in this screen. The red is more on the cortical, so the regions of the brain. When the amyloid tend to accumulate in this cortical regions, we call this positive amyloid PET scan. On the contrary, when there is no amyloid accumulation, or the amyloid is just locating deeper in the white matter regions of the brain, we call this a negative PET scan. So you can have a dichotomized results, positive or negative. In research, you can also quantify the accumulation of the amyloid pathology. Usually, it's not when you have the accumulation, it can still be asymptomatic. There are many individuals getting old, we tend to accumulate amyloid pathology in the brain without any cognitive symptoms. Okay, however, we know that that this is a significant risk factor for developing Alzheimer's disease and cognitive symptoms. So amyloid PET scan, but more important, not more important, complementary, I'd say the tau PET scan. Tau PET scan is the modality, the imaging modality, which is able to represent on the brain the accumulation, the progressive accumulation of tau pathology in the brain. Usually tau pathology progress in accord to the pathological stages from the inner regions in the temporal region, the hippocampal, throughout the limbic region, and ultimately to the cortical regions. And the accumulation, progressive accumulation of tau pathology, differently from amyloid, is associated to clinical symptoms. So the more tau you have in the brain, the more spread of tau pathology you have in the brain, the more symptomatic you are. Amyloid PET scan is available clinically in Quebec, for example, but on the contrary, tau imaging is only available in research settings. We know that pathology increases over time, usually, and they tend to accumulate even decades before the onset of symptoms. Give us a very good opportunity to diagnose and treat earlier patients during the Alzheimer continuum spectrum. And the measures of Alzheimer pathology, amyloid and phospho-tau, as measured by fluid, for example, CSF, but also blood biomarker. We are going to discuss a little bit later about this, tend to accumulate earlier compared to imaging techniques. So the CSF and the blood biomarker could be more sensitive at the beginning compared to imaging like a PET. This is also very important. When we have to choose between a lumbar puncture or amyloid PET scan, for sure we have to, there are some many issues, and usually depends on the availability of the cyclotron and PET imaging across the country. There's a lot of differences. I know we are quite lucky in Quebec. We have access to clinically to the PET scan, but it's not the same for our provinces like Ontario or BC. The clinical approval for PET scan, I don't think it's possible. It's only research that was very limited. So the accumulation of evidence, the importance about biomarkers led finally to a change in the definition of traditional definition of Alzheimer's disease. Starting from 2011, was recognized a preclinical stage of it. So the accumulation of based on biomarkers. Okay, so a preclinical asymptomatic stage only characterized by positivity in biomarker. At that time, it was only the amyloid biomarker which was available, but there's also the classic clinical probable and possible definition of AD. But on top of that, we have been now starting having the pathological evidence of AD based on biomarker. More recently, in 2018, there's been a major change in the definition of Alzheimer's disease based on research criteria at the time. The ATN model, I don't know if you are familiar with this model, something that now we are using a lot in the research, but also clinical practice. The ATN model, you can define each individual based on the presence of A for amyloid, T for tau, and N for neurodegeneration based on the presence or absence of specific biomarkers. So for amyloid, the amyloid PET scan or low level of amyloid in the CSF. T for neurofibrillary tangles based on the CSF increased level of phospho-tau and the PET tau imaging. And neurodegeneration, there's no specific evidence of neurodegeneration in the brain based on volumetric measure of MRI or FDG PET scan. And there is when you are amyloid A positive, this is the signature of the Alzheimer's disease, meaning that there is a increasing rate of progression of atrophy, hypermetabolism, and cognitive decline in demented people. It's also the first biomarker which came positive in the familial form of Alzheimer's disease. We have the mutation, the family mutation, tend to develop first the amyloid pathology before initiating the cognitive decline. Okay, so you can have different profile for each individual. You can add, it could be A positive, tau positive, N positive, or A positive, tau negative. And for sure, the Alzheimer continuum starts when you begin to be A positive. There are also the cases where you are A negative, so amyloid negative, but tau positive. And this is called the SNAP individual, suspected non-Alzheimer pathology, which probably is some vascular or frontotemporal degeneration patients or other conditions. It's very important to define the biomarker profile in each individual to provide the right treatment and the right consultation. So new biomarkers now, over the past only 5 years, maybe a little bit more, but becoming more and more consistent and helpful, plasma biomarkers. So what I told you just now it's possible to add this just with a single blood workup. So you can have the peptide, the amyloid beta 42 peptide, phospho-tau, in your directly in your blood. Okay, it's a really something amazing. There's been a very recent, a few months ago, a couple of months ago, publication, JAMA, company, not a company, group of researchers tested a company to validate in clinically, okay, the importance of biomarkers, the blood biomarkers, and they found a significant correlation between the plasma biomarkers and the CSF and imaging technique. So having just a simple blood could give us the same result, sometimes even better compared to CSF, for example, in the study. Compared to just CSF images, would be potentially a great advancement in science for early diagnosis. You can test, as I said, a combination of amyloid and phospho-tau. There is a specific phospho-tau proteins, just for letting you aware about this, somehow specific, but the p-tau 217 is a specific form of phospho-tau, which very much sensible and specificity is very high for pathophysiology. So, as I say, the blood biomarkers are comparable, even better to CSF, detecting green accumulation of amyloid. Give us the possibility of future mass screening by family doctor, for example, as same for diabetes or thyroid issue or even cancer issues. The cost could be potentially very limited compared to more expensive technique like imaging and CSF. For the physician that perform the procedure, the results are easily interpretable. But again, today this procedure is not indicated in asymptomatic individuals. So patients should have at least some cognitive impression of decline to possible have access to this testing. However, the approval from Health Canada is still pending. Honestly, I started to ask a few patients of mine clinically, not in research. My lab, chief lab at McGill, authorized a specific test in blood. So we will see what's going on with this. I tried to compare CSF and blood results. At McGill, we are trying to validate clinically, crossing over the Quebec, the blood biomarker. We're going to compare CSF. So there is a need of validation and the diffusion of this result, but the pathway is straight, and we now almost have this clinically approved. The introduction and the availability of plasma biomarker led to a last change in the definition of Alzheimer's disease. This is the last one published in June, July, if I'm not wrong. Is based on core criteria 1 and core criteria 2 for AD pathophysiological evidence. The core criteria 1 is sufficient to give us a diagnosis of Alzheimer's, even in asymptomatic individuals. Core criteria 1 is based on evidence of A-beta proteinopathy, so amyloid, and phospho-tau pathology. Core criteria 2 is more, it means more the staging of the disease. So if you are in the early, middle, or later stage of the disease, and it's based on the tau imaging, as I explained you before, the tau imaging let us see specific individual, the progression of the tau pathology from the inner regions to the cortical regions of the brain. So give us sense the accumulation, the load of tau pathology in the brain. So give us a stage. There is a minimum tau accumulation, middle tau accumulation, or profound tau accumulation at each individual. So we can now able with this definition to stage patients at different level of severity of the disease. And this is very important for clinical trials, because there are one drug that select individual based specifically on the tau accumulation in each specific individual. Again, the core criteria are based on CSF, amyloid imaging, and also blood biomarkers. So this is a recognition of the importance of the blood biomarkers in the future management and the early diagnosis of the disease. For sure, there are also non-specific biomarkers like neurodegeneration and inflammation, which is a significant component of the pathophysiology of Alzheimer, and also vascular and synucleinopathy for the compatibility. So just coming back to the clinical case, the CSF biological profile was not suggested in that individual I presented to earlier. So the diagnosis for me at the point was my neurocognitive NCI, disease type, in the context of some vascular issues. I treated him with aspirin and a lot of education on prevention of decline in the next years. So the importance of biomarkers in clinical trials in the last 5 minutes. We know that the individuals have now selected in clinical trials based on biomarker. The individual have to be proven to be amyloid positive at least to be enrolled in clinical trials for this possible disease-modifying therapies. This is the first study done at aducanumab, has been the first approved DMT in the US, which completely cleared the amyloid in the brain. So this drug was able to remove all the amyloid from the brain. It was also associated, at least in one phase 3 clinical trial, to some less decline in functional impairment in treated patients compared to placebo. Unfortunately, now this drug is no more commercialized in the US because there are some conflicting results. We have now new medication, the lecanemab, which has been received full approval in the US. It's a monoclonal antibody against some form in the brain. The study was in early individuals suffering with NCI or early 18. Again, the patients were identified based on biomarkers. We have pathology, AD pathology in the brain as measured by CSF or amyloid PET scan. And the drug was intravenous every 2 weeks. This has been associated to some decline in combination of functional and cognitive status compared to placebo over 18 months, which is the first time we have a positive phase 3 clinical trial in AD. And as well, biomarker decline a lot in treated patients. So the amyloid charge in a treated patient decline a lot significantly compared to placebo over the 18 period. So the biomarker here are very useful in selecting the right patient with AD pathology and to track the drug's biological effect on AD pathophysiology. A last drug which has been received full approval in the US against Alzheimer's disease is donanemab, another form or anti-amyloid antibody. Importance here, as I said, the individual was selected based on the charge of tau amyloid, not just amyloid, but tau accumulation in the brain. The trial dividing individual with medium or severe high tau accumulation and did some differential analysis on both groups. And again, there's been some less significant, less decline in the treated group over the 18 months period of treatment. This resulted in 6 month improvement, 6 month less decline in functional state and reduction of biomarkers. Again, important point here, biomarker for selection of the right patient and for staging the disease. So, I think I go to the last slide because it's probably the most important here and matter of time. What I worked a lot on this is my future of the next 5 years, how we can deal with cognitive issues starting in people probably 55, 6 years old, 66 years old. We want them to be screened regularly, also by some new digital tools like the Express MoCA we are developing in Montreal, self-monitor cognition over time. And for people who we assist some decline, they can be referred to the GP to have the classic workup and probably a first screening with the blood biomarkers, okay? And only for individuals positive in the blood biomarkers, those individuals can be sent to a tertiary specialized memory screening to the workup, CSF imaging, and to enroll them in clinical trials or receiving the potentially next approved disease-modifying treatment. So this is my vision for the next 5 years. I think we are almost there. All of this has been based on the tremendous amount of knowledge that we have now in 5 years. Thank you very much.
This is very exciting. The notion that we might have a blood test in the near future that can be used as a screening tool, the same as we get assessed for, like you say, diabetes, as we get blood tests periodically in your life. We can look for the presence of the beta amyloid and the tau in the blood. Now, I know that study came out in 2024, just this year in JAMA, that was showing a validity for a plasma or blood test. How long does it take for a practice like that to become clinically available and approved by Health Canada? That would be my first question. And please raise your hand. And Hannah is going to go around if you do have a question. And I will ask Dr. Vitali if there's a question from the room. Could you repeat the question to the folks at home before you give your answer?
Sure.
Thank you.
Yeah, thank you for the question. Honestly, I don't know the exact time to take for approval by Health Canada. I know that you are talking about blood biomarker for at least 5 years, for the past 5 years. And each year we say, yes, we are there. I know and I realize, I feel that each year we are a little bit closer to the goal. I started asking them to my lab clinically, not through search, and I started having authorization from my lab, so this is good. I think it takes also a little bit more of validation in clinical validation. This is the first study has been done in different cohorts of patients. Honestly, I think reasonably we can expect 2 years to have our form of validations in each province probably. So we start from the specialized clinic and then through the years through the general patient practice.
So if we're looking at a 1 to 2 year clinical process, that will hopefully maybe align, like we're still waiting for approval of these medications in Canada. But the blood markers, they're not just important for diagnosing. early for disease modifying therapies, but also because of everything else that we can do if when we know that we might be at risk. You know, there are, is it 14 different risk factors, modifiable risk factors for dementia that we can actually reduce our risk by things like taking care of our heart, reducing hypertension, not smoking, reducing rates of obesity. If you need hearing aids, then you should wear them. So there are all kinds of things that we can do to promote brain health in advance, and that might even become more important if we know we have higher levels of tau and amyloid in blood. So we do another question over here. Go ahead. On the Alzheimer Society of Canada website, I believe there's a list of all clinical trials that are currently active and how to participate. And then I will mention, as Dr. Vitali shared, lecanemab and donanemab are both available and in the US. So currently, until it's approved by Health Canada, there's no way to access it other than a clinical trial here or by going to another country where these medications have been approved.
Yeah, the question is which kind of medication we can use at the early stages of Alzheimer's disease as the classic medication that we are using for more than 25 years, the excellent patch or the oral form, which is indicated, and people tend to say that it's not working at all. I think in my clinical practice, I find it useful. And they can stabilize, they can help in selected individual, probably not in all, but they can be really useful in contributing to give us sort of stability over time, at least a limited amount of time. We have to be aware that it's not a disease modifying treatment. That doesn't act on pathology, just act on symptoms. More alertness, more attention, more language, more engagement, less loss of autonomy for a limited amount of time. That could be a very good strategy and prevention. And you're going to, I didn't have time to talk about this, but it's fundamental. Prevent further decline, addressing vascular risk factor, good life hygiene, like sleeping, eating well, Mediterranean, physical activity is fundamental, regular physical activity, socialization, and new projects is very, very, very important to stabilize the individuals, even at the symptomatic status.
So that last question and comment from Dr. Stultz was very important. There's a lot of work for us to do in terms of research to find treatments and cure. There's a lot of work to do in the system to be ready when they come. And early diagnosis was something that we wanted to prioritize, not just because of disease modifying therapy, but because when you know early, there's really an opportunity for so many different things, including supporting the brain health, but also planning for the future and having the individual remain involved in decisions that are going to affect them as their disease progresses. There are just so many reasons why it's going to be beneficial for us to know earlier when there is cognitive impairment present. So thank you so much. I really appreciate that presentation today. We get asked a lot when we do these conferences as people say, I wish we knew more about you and your team, because we often focus on bringing in experts from the community. So I'm going to take a quick 5 minutes to introduce you to what we do here at the Alzheimer Society, including individual and family supportive counseling. So we actually follow people from as early as possible after being diagnosed, right through to late stage, end of life. And often we're supporting people actually beyond. We also have support groups across the island for caregivers, as well as persons who are living with MCI or dementia. We have a special group for those who are caring for someone with young onset dementia. We provide education for families, social activities, and walking groups for seniors as well that are dementia friendly, so they're an inclusive group. We also have the Volunteer Companion Program, which is a visiting program for persons living with dementia. And we provide a lot of information and resources, both at our office as well as through our website. In addition, we have the Dementia Care Training Program, which is for healthcare providers. We provide certification in You First, as well as we teach positive approach to care, and some of that's happening downstairs this afternoon. So in a nutshell, these are some of the local programs and services that we're offering, and I'm proud to say we're now offering them across the island. So let's introduce you to some of the team really quickly. We have Laura McWilliam, who is our registered social worker and the manager of programs and services. And I'm going to get the team to come stand here so you can actually see their faces. Laura works at head office in Charlottetown, and she has been working for the Alzheimer Society family for over 10 years. She manages our team of support services coordinators. So this is Laura. We have Jacqueline Gallant starting, we're going to go west to east at this point. Jacqueline's our support services coordinator in Prince County. She provides a lot of support in O'Leary and Alberton. She runs support groups as well as the Group Crew, which is a group for persons in the early stage out in Alberton. She is an excellent family support person. So she loves doing the one-on-one and family support. We have Shelley King. She is an LPN. She's working out of Summerside, East Prince, and West Queens. She's a very experienced nurse, and she provides all our support and programs. You can also catch her at the Prince County Hospital. Is it once a week now? Every Friday. She is working on site at the PCH, working with families who are caring for someone who might be in hospital for whatever reason. Some folks end up waiting for long-term care for a good amount of time, so she's providing some support there. We have Maria MacLean, and Maria is the support services coordinator for Kings County. She also leads the Montague support group, and she's the co-lead for our dementia care training program for healthcare providers. I forgot, Shelley is the other co-lead for the DCT program. Han Fong is our support services coordinator in Queens County. She's providing support to clients in Charlottetown and surrounding areas, and she leads the evening caregiver support group that happens Tuesdays. Yes, once a month. We have so many new programs, it's very difficult for me to keep track. I'd like to introduce Kristen Sherman. She's been with us for 5 years in a variety of roles. After completing her master's in counseling, she switched over to doing individual and family support. And she has been this year developing a new program, which will be launching in October. You'll hear more about that this afternoon, which is a counseling therapy program, psychoeducation, and skills-based education for caregivers. So we've been working hard on that this year. It will launch. Caregivers will be able to access formal therapy, 8 to 10 sessions and more if needed for free with the society. Kristen will be the answer. And we have 2 more folks to go. Bronwyn Spenceley is our operations and special projects coordinator. She is the friendly voice you probably hear when you phone. But in addition to admin, she also oversees our marketing and communications, so social media. The admin department, she coordinates volunteers and social programs in Charlottetown, and she also supports fundraising activities. We affectionately call her special ops because she basically can do anything. And Kelly Redmond. Kelly has been working with us as a consultant in fundraising, media, and partnerships. She supported us at this year's IG Wealth Management Walk for Alzheimer's, and as well as the conference. She's been giving us a lot of help. She's very passionate about raising the profile of important issues related to dementia. So she's been a really good advocate for us with the media to get word out and raise awareness. We appreciate that. So thank you so much. Oh, you know me. I'm sorry, we're almost done. You know me. I've been working in this field for 14 years. I started with the Alzheimer Society here in 2010, and then I did a couple of tours in Ontario, and then I came home like all good daughters do. And I'm very passionate about programs and services. That's kind of my main focus. Lastly, I just want to thank the board. Do we have any board members in the room right now? I know there's a couple online, and Gary was here earlier. I wasn't sure if anybody could make it in person today. We have some new, our new executive, I'll mention Gary Evans, President Matthew McKenna, VP, Nelson is past president. Val McLean is our treasurer, and Carol Reed is our secretary. She'll be presenting here later this afternoon. So again, thank you so much to the board of directors. This is our office in downtown Charlottetown. It is generously provided by the Parkdale Sherwood Lions Club and has been for the past 34 years, I think. I gave them a check. So I paid rent for the first time, and I gave them a check for $34. So, which everyone got a kick out of. So, yes. So please join me in welcoming Dr. Jessica Strong. Dr. Strong is a licensed and board certified clinical geropsychologist, and she has been an assistant professor of psychology at UPEI since 2019. She received her Ph.D. in clinical psychology from the University of Louisville, specializing in aging and neuropsychology, and completed her clinical psychology residency and clinical postdoctoral fellowship at the Boston VA healthcare system affiliated with Harvard Medical School. I always love saying that. So impressive. Dr. Strong's current research program focuses broadly on aging and cognition, in particular, how experiences impact the cognitive aging process, program evaluation of late life interventions for mental health and well-being, and what factors influence students' likelihood to pursue a career working with older adults, which is something we really need to better understand. She is heavily involved in clinical training and supervision at UPEI within the Doctor of Clinical Psychology program, currently serving as the Director of Clinical Training. She supervises graduate students on research projects with older adults and in clinical work doing dementia assessments and providing mental health interventions to older adults, including care partners of people with dementia. Please give Jessica, Dr. Strong, a warm welcome today.
Thank you, Jamie. I am very excited to be here. It's wonderful to see lots of familiar faces, colleagues, and folks that I have worked with over the years. This is something, so exploring this intersection between dementia and mental health, that I am very excited to talk to you all about. This has been what I've spent the last 15 years of my professional life, spending a lot of energy doing that. And in the last couple of years, it's taken a little bit more of a personal note for me. As many people in this room, I now have a father-in-law with dementia, with Lewy body dementia. He was diagnosed about 3 years ago. And so it takes a different flavor when you've been doing it as a professional for a number of years, and then there is suddenly a very personal aspect to it. And so one thing that I talk about very often with the folks that I work with clinically and the different caregiver support programs and such, is a quote from Rosalind Carter, the former First Lady in the States. And she said that there are only 4 types of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. And I keep that very front of mind. And I think oftentimes not only do we fall into one of those categories, but we might fall into multiple. So, excited to be here, excited to talk about dementia and mental health. And with that, I'm going to outline a couple of objectives for us. I know that there is a mix of healthcare providers and family care partners in here. And so I want you all to be able to describe some different mental health concerns that are common in dementia. I'm going to focus on a few that are the most common, because it would be impossible to talk about all of mental health and dementia. I'm hoping that you can come away recognizing at least one, hopefully more, overlapping symptoms of dementia and mental health. And particularly for the healthcare providers in the room, I want to leave you with a tool or two that you can use to screen for anxiety or depression in dementia. So I thought I would first start by just chatting a bit with you about what is mental health. We know, dementia is a very broad category. We have different types of dementia. They all have different trajectories. There's mild cognitive impairment, right? It's a very complicated and broad word, as is mental health. And so as a clinical psychologist, as a clinical geropsychologist, I think of mental health on a spectrum or on a continuum. So there are certainly people who struggle with mental health and who have mental health concerns, but I also lean into and like to point out, think about how mental health can be a strength. It can be a personal strength for people who are going through this, either as a care partner or as someone living with dementia. It isn't that mental health is always a concern. It can be a strength that we lean into. As a clinical psychologist, when I'm looking diagnostically at those mental health concerns, I'm really interested in how that is impacting functioning. And that's one of my diagnostic criteria if I'm looking at depression or anxiety or any mental health concern, is really how is that mental health concern or that poor mental health, how is it impacting someone's ability to go about doing what they need or want to do on a day-by-day basis? So the common concerns that I'm going to focus on today in terms of mental health, having poorer mental health, are depression, anxiety, and PTSD. Again, I could spend days, I could spend months probably talking about the intersection, but to keep us a little bit more focused, I'm just going to concentrate on those three issues that come up quite frequently. I'm also going to get a little bit later on to personality and how personality might be impacted by dementia later throughout the disease. So, we talked a little bit earlier this morning, there were questions and talk about modifiable risk factors. And so I wanted to just sort of lay out some of these aspects of mental health that intersect with dementia and that are related risk factors. So folks who have depression, particularly in early to midlife, this is a modifiable risk factor, and that I hope that you can get the treatment and manage depression, as depression in those life stages can more than double the risk of dementia later on. Folks who haven't had any struggles with depression in early to midlife, but do have late life depression, there's sort of a relationship that can go bidirectionally. So having dementia later in life can increase risk of having late life depression, but also developing late life depression for the first time can increase the risk that someone has dementia or that someone will develop dementia. A similar in anxiety, so particularly for folks who are in very later life, so over 80 years old, having anxiety and anxiety symptoms can increase the risk of dementia. And there's quite a range of prevalence rates of anxiety and dementia, ranging depending on the study from 8% to 72%. Complicating this further is that we can see all three of these things going on at the same time. So 3/4 of people who have dementia and anxiety also have depression. When I think about chronic stress, life stress, trauma, there's been mixed evidence about just this life stress that we all have, or chronic stress influencing or impacting risk of dementia. It's not really consistent evidence. Some studies say, yep, having a lot of stress in your life might increase your risk. Some studies say, no, you're fine. But for folks who do have post-traumatic stress disorder, who develop PTSD after experiencing a really significant trauma, that can double risk of dementia later in life. And I will say, that most people do not have depression, anxiety, and PTSD, right? Human beings are inherently resilient. This isn't something that you experience a trauma and bam, you get PTSD. But also there isn't anything wrong with people who do develop these things, right? We want to make sure, again, thinking about modifiable risk factors for folks who do struggle with some of these mental health concerns, if we can treat these earlier in the life course, that could then prevent or reduce the risk of someone developing a dementia later on. So one of the things that makes this intersection really complicated for me as a clinical psychologist working with folks with dementia and their families, I know this also makes it really complicated for care partners, is that these symptoms that can be a part of the normal disease of dementia can also be a symptom of a mental health issue. So some of the overlap that we see are in things like apathy, right? Not really being able to or finding pleasure or wanting to engage in things that someone used to find really enjoyable. We might see an increase in irritability, a little bit of a shorter fuse. We can see changes in sleep and appetite, increase in tearfulness or agitation. And again, these might be part of the disease process of dementia, but they might indicate another mental health concern. And, you might say, well, why does it matter? We just treat the symptoms, but we are going to treat those symptoms differently if we can link it more closely to the dementia progression versus if I'm going to link that to a mental health concern. And some of those treatments might overlap a bit, but some of them don't. And so if we can really identify apathy or irritability as being in the course of dementia versus irritability related to someone going through a major depressive episode, and they also have dementia, we're going to treat that depression a little bit differently, right? Or that apathy a little bit differently, or irritability. So moving on to a couple of the detection pieces here. There have been a number of tools that have been developed for providers to help assess mood, anxiety, etc. in people who have dementia. And we can't just use the same questions and the same tools that we use with other populations of adults or even populations of older adults who don't have dementia. Right, so anytime a new tool is being developed for providers, we need to make sure that it's really asking the questions and that someone with dementia, it's going to give us that valid answer, right? So that we can do this detective work to figure it out. So these are a couple of tools that I have used and use in my own clinical practice that can help screen for some of these depression and anxiety issues in people who have dementia, and they've been validated and tested specifically to do that. So this one that I have up here now is just a little screenshot from the Cornell scale for depression in dementia. And it asks questions across sort of the mood-related aspects of depression. And I don't know if you can see this very well, but the very #1 item in this mood-related section is actually asking about anxiety. So again, we can see this overlap, this sort of complication in trying to assess this. So it asks about mood-related signs, it asks about behavioral disturbances. What you can't see, it also has sections asking questions about appetite and sleep. And then, providers will score this based on whether, we have a little A option, which is that I can't actually assess that. And then how frequently or how severe is it? These tools that we use, we often really rely on not only what the person might say. So there are a number of questions in this Cornell scale for depression and dementia at the end that ask about, how is someone talking about themselves, right? Are they talking about themselves in a way that really shows low self-esteem? Like, oh, I'm so stupid, I can't remember that. Or, those sorts of phrases that we might hear from our loved ones at times. Or talking about suicide, right? And wishing that I weren't around anymore, or wanting to die, or wishing I was dead because this is awful. And so, as providers, we are collecting the information that we can from the person, but we also really rely on the collateral report, that is the care partners and what you all, across providers and across family members might be observing in someone's behavior. Because I often say to folks, like, I have this expertise in dementia that I have developed through reading a lot of things and spending a lot of time with people with dementia, and more recently having a close family member who is going through the disease. But each one who is living with this is doing it in a very different way. So you have the expertise in yourself, in your loved one, that I can't have because I don't know them, right? So a lot of these tools we're relying on you and the person with dementia, you care partners and people with dementia, to give this information. So, I will use the Cornell scale. Often if I'm looking for depression in someone who I know has dementia, the other tool that I use here is the geriatric depression scale, which I know a lot of care partners in here are familiar with. So when I'm finished doing this scale, I sort of, I can score it up and it gives me cutoffs to say, yep, this person maybe is having a major depressive episode. But it also says, oh, this person probably is struggling with major depression, right? So that can give me more information. And this is for the person who, again, already has dementia, but I want to know this extra layer. So similarly, for detecting anxiety, I use the rating of anxiety and dementia. I was trying to find a little article for it and I searched for RAID and I got all of the ant killing things, which was not what I was looking for. But I found it. And anxiety and dementia is again, I can't say enough how complicated all of this is. And I loved this quote from an article that I pulled in sort of preparing for this, that until recently, there's a considerable mess regarding the nature of anxiety and dementia. I would say there probably still is a fair amount of mess, but hopefully we've made a little bit of progress in the last 7 or 8 years. So this rating of anxiety and dementia, again, this is probably a little bit small, but it has questions asking about apprehension and vigilance, motor tension. There are other sections asking about worry or hypersensitivity. And I, again, in a very similar way to the Cornell, I score this in an I can't evaluate it to is it absent, is it severe, how often is it happening? And again, it gives me kind of a cutoff of, yep, this person's having clinically significant anxiety within dementia, right? A separate thing going on here. But, you know, the complicating piece is that items that we just saw again on the Cornell, where we're asking about, you know, appetite or sleep disturbance, I see here again on, you know, item 8, sleep disturbance, trouble falling or staying asleep. So there is overlap in some of these questions that then I'm not relying purely on this in order to make my assessment and come up with a treatment plan. So there are a few, you know, another thing I'm clinically I think about is who might be at a higher risk of having anxiety, because that's going to paint a picture for me. And anxiety rates in dementia are higher in individuals who identify as Hispanic or Asian compared to folks who identify as white or Black. And anxiety is more common in some types of dementia than others. So people who have vascular frontotemporal or Parkinson's disease dementia might be at a little bit of a higher risk, are at a higher risk for having anxiety in addition to their dementia than someone who has an Alzheimer's disease dementia. And so, you know, the field has really, there's been a lot of argument and discussion and conversation about, well, you know, aren't these anxiety symptoms just a part of dementia? Is it, you know, is it actually a standalone thing or not? And this is that quote just on the last slide, that there's a considerable mess in all of this. So there might be some symptoms of anxiety that are part of the dementia process and they look the same, but we can attribute them to dementia. But also there are certainly folks who have dementia who are experiencing anxiety. And this, for me, this has come up a lot in my personal life as well. So and this is a very common thing that I hear from care partners who I work with as well, that, you know, as the disease progresses, someone with dementia can be more confused, right? The world can become a much scarier place when you don't remember something, or you don't recognize something like a room or a face or right? It can become scarier. And that fear can be, I think, a separate from the disease of dementia itself. And it can be really distressing for the person, obviously, with dementia to be experiencing this fear or this anxiety because the world is confusing and a little bit scarier. But it also can increase the burden. It can increase the stress for the care partner. As you know, the primary care partner tends to be the safe person that, you know, the person living with dementia will go to. So my in-laws are going through this right now, right? That my father-in-law is feeling a lot more anxious about you know, he's in a long-term care facility, about not having my mother-in-law around because she is safe emotionally. He knows that he knows her face. He knows that she's a safe person and that, you know, all of those things. So that tick up in anxiety that I experience, I think, professionally and personally, as being separate from the disease itself. So the big question, right, in this like complicated intersection between dementia and mental health is like, what do we do? How do we manage these things? So there are options, right? And again, this is why we want to know the root cause of this and why we try to do the detective work to figure out if these symptoms that someone is experiencing is related to that disease or is related to a separate mental health concern. So there are I am not a prescriber. I am not a medical physician, so I will not give recommendations on prescription medications, but I do know, working with B prescribers who I do work with closely, that there are a number of different medications that are not the same medications that we use to treat dementia, right? So there are classes of medications that are safe for older adults and that are safe for older adults with dementia to be prescribed to help manage some of these symptoms of anxiety and depression. There also is, I think, a big myth. I know that there is a myth in the field of clinical psychology for folks who don't have the exposure or the experience working with older adults, that people with dementia can't do psychotherapy, right? Or that they can't participate or that it won't be beneficial. And this is, you know, this is 100% lies. It's all lies. There are a number of different therapeutics, evidence-based psychotherapies that have been shown to be effective for people with dementia. And certainly sometimes we, the providers, have to make modifications to that to make sure that the person living with dementia is getting the most benefit. Sometimes it might involve bringing care partners into the psychotherapy with us. It depends at what stage in the disease process the person is. But there are a number of approaches, evidence-based psychotherapies that I have done with folks living with dementia with good effectiveness. For example, cognitive behavioral therapy is an approach that many people have heard of. And although, you know, I might not be able to lean into the cognitive piece as much, behavioral interventions can work beautifully with people with dementia. And so I've done a lot of work, for example, doing behavioral activation, particularly for people who are living in long-term care, to help reduce symptoms of depression. And there's sort of growing evidence that this is a really effective way to help manage that. So in a lot of research with mental health, the kind of best approach is that combination of medication and psychotherapy, right? The medication can help manage some of the symptoms, and the therapy helps put in place ways to maintain those positive gains, even if then the medication is discontinued later. So I want to spend just a minute on trauma as well. So this was something that I spent a lot of time. I worked at the Veterans Administration Hospital in Boston before moving up here, and we had, as one can imagine, working with veterans, a lot of folks who had PTSD or had a history of trauma, but that isn't exclusive to the veteran population. And so PTSD is interesting in that we've identified a few different trajectories of PTSD across the lifespan. So there are folks who have chronic PTSD, right? They've had a trauma in their childhood, adolescence, early adulthood, midlife that they develop PTSD symptoms from, and they sort of carry those symptoms with them through their life, right? We also have folks who have a reactivation of PTSD. So they had that trauma happen, they go into remission, their trauma symptoms are managed, right? They aren't experiencing active symptoms of trauma. And then it's reactivated with a trigger later in life, right? So the loss of a spouse, a transition into retirement, right? With a loss of sort of social network or the structure that provides, having to go into hospital themselves, right? So there can be a trigger often related to loss of control then those PTSD symptoms might start again later in life. But the thing I want to chat a bit here is a delayed onset PTSD, or a concept that I call later, which is late adulthood trauma re-engagement. And these are folks who had a trauma, and like the majority of people, they recovered from that trauma without any sort of major issue, right? They maybe had counseling or therapy, or maybe they didn't, but they moved on from the trauma as life happens, right? They got engaged in raising families and having work and hobbies and all the things we do in life. And then as the disease pathology builds up in the brain and dementia, that experience of trauma might come out, and those PTSD symptoms might emerge for the first time. Late adulthood trauma re-engagement, or later, is the concept of someone starting to think a little bit more about their traumas later in life, or the traumatic experiences. We can say, pretty guaranteed by the time you're in your 60s, 70s, 80s, even like 40s, right? Most people have experienced a loss that could be labeled as traumatic, right? So this is a common human experience. And again, most of us sort of go on with our lives. And as we get into later life, we're sort of starting to think about, make sense of our lives a little bit more, right? This sort of legacy and meaning making. And sometimes someone can re-engage with those traumatic memories without developing PTSD, right? So I might just be thinking about those times a little bit more. But if I have that extra layer of dementia pathology in my brain, I might not be able to stop those memories from coming up, right? I might not be able to manage the emotions, the sort of overwhelming sadness or fear or whatever I felt in the moment of that trauma, like I would have been able to do had all of my, my brain been not atrophying and low disease load and all those sorts of things. So again, PTSD can be a risk factor for developing dementia, right? We see a twofold risk factor in developing dementia later on. That's particularly in these folks with chronic PTSD. But we can see this delayed onset PTSD as well. And folks who have Alzheimer's disease and vascular dementias are at a higher risk of having this delayed onset PTSD. There aren't a lot of good tools for clinicians to detect PTSD symptoms in dementia. We can do interviews and there are scales that we can use for that, but they're a lot less common than the symptoms for anxiety and depression, which is kind of a bummer. And maybe we should all in the research world be thinking about, you know, the better development and validation of some of those tools that would be able to do that. The symptoms are often treated as a part of the disease process, right? Rather than, again, a standalone piece of it. And so with the management of PTSD, that is some of the same things, right? So there are medications that can help manage this. Again, not a prescriber, but working with someone who does prescribe to figure out what that might look like. And psychotherapy, again, depending on the person, depending on the disease stage, there are some of the same. So acceptance and commitment therapy being one that was mentioned in depression and anxiety can work with treating PTSD as well, in addition to a few other types of psychotherapies. And so I'll say again, it is a myth that people who have dementia cannot benefit from an evidence-based psychotherapy. It's my job to figure out how to modify that intervention so that it works for the person based on their strengths, right? And their cognitive vulnerabilities or other vulnerabilities. Okay, so I'm going to spend just about 5 minutes here once I get through this, and I want to make sure I leave some time for questions. So I hope what you have gotten so far is that this is very complicated. And I will also say it's one of my favorite things that I do. I feel a little bit like a detective when I am trying to figure out, you know, where might this symptom be playing in and how am I going to figure out, you know, most efficiently how these pieces are, I find it very intellectually, I like playing detective. It doesn't take away from the fact that this is a person in front of me who might really be suffering, right? And so it's holding both of those spaces that, you know, I want to get excited and figure it out, but I also want to make sure that I'm doing right by this person or this family in front of me. And so again, I'm going to be getting information on timelines and history, and that's again where care partners and the person themselves come into play. Is this person, have they been a lifelong worrier, right? Did they have a trauma in their childhood or early adolescence that we know about? Sometimes we don't even know about these things, right? Even in our spouses, you know, you don't tell your spouse everything, right? And so one of the tools that is sort of generally used to understand these symptoms is the neuropsychiatric inventory that is similar to some of the others I've shown, asks questions about severity and distress across a number of symptoms that we might see in dementia, but might be a standalone. So I do have 5 minutes to talk about personality. I'm gonna put you all back into Psych 101. I just came from teaching my advanced stats class over at the university and into the concept of personality, right, which we teach in Psych 101. That personality, we all have a personality. It is this combination of characteristics and qualities that form my person, right? And the Big Five or the 5-factor model is one that we use very frequently to understand who each individual is, right? We're higher or lower on different levels of these things, which are openness, conscientiousness, extroversion, agreeableness, and neuroticism. There's been some research into personality characteristics and what might be predictive or a protective factor against dementia. People who tend to be higher on neuroticism tend to be at an increased risk of dementia. And we might also, some studies show that being higher in conscientiousness may be protective, but there hasn't really been any evidence that there's a relationship with some of these other Big 5 factors. Interestingly, changes in personality might be some of the earliest signs of dementia that we don't often, maybe we don't put that together, right, until later. But in studies, there has been some evidence that specifically 1 in 4 people do experience changes in terms of becoming more rigid, becoming more apathetic, and about 1 in 5 show changes in increase in egocentricity or decrease in emotional, right? Changes in emotional control. And oftentimes we don't put that together until later, right? When maybe there are memory symptoms or issues with planning or language or some of those other pieces. And then we might think back to, you know, 5 or 7 years ago and like, well, actually, you know, they did start being treated for depression, right? 8 years ago. And, you know, we talked a bit this morning about that early diagnosis, right? Often when we see these personality changes, those can be misdiagnosed as a mental health concern, right? So not only do we have these mental health concerns coming up in dementia, but sometimes these personality or mental health pieces might be these early signs to the person or to the care partner that there are some sort of warning signs that, you know, dementia might be looming. But really, personality tends to stay pretty stable in the course of the disease. And I think this is something that can be really frustrating and also potentially triggering for care partners. You know, as the disease sort of progresses, as many of you know in here, as providers or as family members, as people living with the disease, as the disease progresses, you know, you might see those little pieces that come out all the time, like, oh yes, that person is in there, right? Or like, yeah, feeling like yourself or looking like yourself. But that can be really confusing. And again, I say triggering when many other parts of the person aren't the same that they were, right? So there's this conflict with personality where, you know, the person seems to be a totally different person, but then you see these little pieces of personality that have remained stable, right? Throughout the course. And I think that's something that is really challenging for care partners in particular. Okay, so the last couple things I wanted to say here is that, you know, we think about personality in that sort of big five model, you know, or sort of ocean model. But we also have people who have personality disorders who get dementia. And personality disorders, the most common ones you probably have heard of are borderline personality disorder, antisocial personality disorder, maybe narcissistic personality disorder. There's a lot of personality disorders, there's like 9 or 10 now. But those are some of the more common ones. And people with those personality disorders will also get dementia, right? And so personality disorders, the nature of them is that, you know, that person has had maybe more estrangement from relationships in their life. They might be a little bit more isolated from relationships, or their relationships with their children or their spouse might be more volatile. So they maybe have had periods where they were estranged, but then they've reconnected and now they're very close again, or that sort of thing, right? So personality disorders impact those relationships, which therefore then impact the care that can be provided, or that the person might want or not want, right? So if you have a parent who had borderline personality disorder and your childhood was a little bit difficult, right? Your parent gets dementia and you're now asked to provide care for them, right? In sometimes very intimate ways. That can be really challenging both for the child and for the parent, right? Adult child sort of providing care for a parent. It can also be complicating things in a long-term care facility, right? A lot of staff in long-term care aren't necessarily trained on recognizing personality disorders or on how that might impact care when the person is in a long-term care facility. And so it can be really challenging to navigate managing the dementia symptoms with a mental health disorder or diagnosis that the nature of that means that person has difficulties with interpersonal relationships, right? Particularly when they're in this situation where they need those relationships in order to survive and to thrive. Okay, so I want to leave time for questions. So the last thing, I want to end on sort of a positive space. That mental health is, again, it's a continuum, right? And so I hope that everyone in this room knows deeply that people with dementia can and do live very full and happy lives. And so part of our role as providers, as care partners, is to promote that, right? Is to turn this mental health concern into a strength. So how do we do that? And I know a lot of people in here have experience and do work with reminiscence and social interaction. We'll be hearing about reminiscence, I think, in a little bit from a good colleague of mine, Dr. Stultz. Finding ways to keep people engaged in the things that they love, right? And something that, you know, I spend a lot of time doing when I'm working with people trying to continue those hobbies are identifying what are the aspects of this hobby that this person loved that I can kind of take and maybe turn into something else, right? So if someone can't manage their full garden anymore, I might ask, okay, what are the things about gardening that make it so pleasurable for you, right? And we might identify having my hands in the dirt, listening to the birds, right? Those are the two big things, or watching something grow. We take those pieces out and then we can modify that activity to say, okay, well, let's get a bucket of dirt and put a plant in it on the porch, right? And we can go sit out on the porch and listen to the birds, right? Or if someone has been a woodworker their whole lives, but they can't use all of these big tools anymore, let's find what is it about that woodworking that was so pleasurable for you? What are the pieces of that? Was it the creating of something new? Was it the touch or the feel of the wood? What was it? And how can I replicate that to make sure that they can still maintain a connection with that hobby? If there are more serious mental health concerns that you as a care partner or you as a care provider can't solve on your own, get your team involved, right? So the Alzheimer Society is a fantastic place to go when you do have more serious mental health concerns, or you're worried that there might be a more serious mental health concern, right? So my partner, my spouse, you know, they've been really a lot more tearful, and, you know, maybe this is the dementia, but I'm worried that there might be some other kind of depression going on, right? Reach out and ask for help. So nobody going through this, as Rosalind Carter said, everybody in this room, right, falls into one of those 4 categories. And I don't want anyone to feel like they can't go through this alone. There are professionals who know, you know, who can help. So reach out to the Alzheimer Society, reach out to the other folks on your team who are helping you go through this journey, to see what other supports might be able to be put in place in terms of psychotherapy, medication, and others. So I'm going to end there, and I left myself 7 minutes for questions, which is right in between where I was hoping to be. That's an excellent question. And I think I had it in my notes and I forgot to say it. So it depends on the personality disorder, and there is not a ton of research on personality disorders in dementia. So some personality, the 3 that I mentioned, you know, borderline, antisocial, narcissistic, those are some of the personality disorders that we know the most about. And we do know that in folks who don't develop dementia, borderline, for example, the symptoms of borderline personality do tend to mellow over time. But we don't necessarily know how borderline personality disorder exists in someone who has dementia. And we also know that there's sort of a new diagnostic category called complex post-traumatic stress disorder, right? Relatively new, that there's a large overlap with borderline, right? And so I think that there's not enough research, and that there would be a difference in some of those. And for example, we depend on the personality disorder and whether you're talking about the aging process or dementia. And I think there isn't enough research in that sort of personality disorders with dementia to say how it might change.
Thank you.
Absolutely does, right? And that's on top of the complexities that are probably inherent to that relationship, because the care partner has been living with this person with a personality disorder for most of their life, right? Either as a spouse or, oh, sorry, I was just told to repeat the question. So personality disorders and how when you're treating, you know, or treating someone with, or providing care for someone with dementia, how that might actually feed into some of the symptoms of personality disorder. And yes, it is a massively complicated thing that there isn't enough research in, that then is more complicated because of the nature of the relationship. Yeah. The question was, how do you access my services as a clinical geropsychologist? And I am not working in clinical practice myself. I do training of the doctoral students who are at UPEI who are training to be clinical psychologists. And so a few folks who do send referrals to me occasionally are the Alzheimer Society and the Provincial Geriatrics Program. So I do clinical work through UPEI through kind of those 2 avenues. I also occasionally, the folks at Seniors Mental Health Resource Team will send me a referral. And again, I'm not doing the clinical work, but I'm supervising, I'm in the room with students who are learning how to do it. So the question was from someone who works with people who have dementia, mental illness, and addictions. And that's so challenging. Right. There is often, particularly with, you know, if you take the mental illness piece out of it, just looking at dementia and substance use, right? I know in a lot of cases, folks might be in remission or they might not be abusing substances, but then they don't remember that they've had a single drink or they don't remember that they're sober, right? And so I would say that is probably one of the most complicated situations to be in, and very often would require that sort of full team, right? Which I hope you have, to help manage, to keep the person safe, but also living well, right? As best that we can. I just would like to thank you all again for the invitation. I love having the opportunity to talk about this, to see all of the faces in here learning. And this is just such an important issue, that aspect of mental health. So thank you for the invitation. Thank you for the reception, and I'll be around for if folks have questions throughout the day.
As we build these conferences every year, a lot of the choices we make about who to bring in and what to cover, it actually comes from the evaluations. And I love this, like the first thing I do. I'll be reading them tonight to see what was your experience like, what was valuable to you, and what do you want to see next. And so from Dr. Strong's presentation in particular, there were so many topics that she just got to sort of ride along the surface. So we want to hear from you. You know, is it next year or even in the winter, do you want us to do one where we're diving more deeply into addictions? You tell us what you need and we'll see what we can do to meet those needs. So there's so much to cover. Really appreciated your presentation, Dr. Strong. And what really stuck out for me at the end was talking about what it means to live well with dementia, or to live as well as we can. And then there are things that we can do to continue to support not only the brain health, but the mental health and well-being of persons who are living with dementia. And a big part of that is keeping persons engaged in the community, engaged in everyday life and in relationships, to make a society and a community that is more dementia friendly and more welcoming of persons with dementia, so that families as well as people can feel comfortable to stay engaged in life.
Good morning, everyone, and welcome to the Family Caregiver stream of our annual Alzheimer's Awareness Conference. I'm Laura McWilliam, the Manager of Programs and Services, and I'm honored to be kicking off the presentations in this stream. Caregivers are truly the unsung heroes in the lives of those they care for. The work you do is often challenging, deeply personal, and at times emotionally and physically exhausting. But through it all, caregivers demonstrate incredible strength, compassion, and resilience. And that's what we're all about. That's what we're here today talking all about, building upon those strengths and learning new ways to foster resilience, both for yourself and for the person living with dementia that you're supporting. In today's sessions, you'll hear practical techniques, tools, and strategies to help you navigate the complexities of caregiving. Our aim is to equip you with the skills and knowledge to thrive in your caregiving role. So with that, we'll dive into the pieces of the puzzle, a framework for understanding changes in behavior. So this presentation aims to help you develop skills to understand changes in behavior and to hopefully then inform the way you will respond. By gaining knowledge and tools to manage these behaviors, caregivers can become more resilient, confident, less overwhelmed, which reduces stress and can prevent burnout. Understanding behavior changes that they are a form of communication really fosters empathy, patience, and improves the relationship and helps to reduce conflict that you'll have with the person that you're supporting. Practical strategies like the PIECES model provides a structured approach to handle situations, helping caregivers stay calm, problem solve, and create a more compassionate environment for both you and the person living with dementia. In this session, we'll discuss how dementia affects behavior, and I'll introduce the concept of responsive behaviors using examples to illustrate. We're going to look at potential causes behind these behaviors and the factors that influence them. We'll then look at the impact of the behavior both on the person living with dementia as well as you as caregivers. And then I'm going to introduce the PIECES framework as a tool to help you understand and respond to changed behavior. Lastly, we'll apply the framework to a case study and explore additional techniques for supporting behavioral changes. Dementia is caused by underlying pathology that is causing deterioration in the brain. Changes in a person's behavior can signal damage to the brain caused by the disease. Dementia affects everyone differently, and changes in communication and behavior will manifest variably. Symptoms associated with dementia will change over time as the disease progresses, and they can fluctuate from day to day and even within the same day. While dementia does affect everyone differently, it does commonly impact these abilities: language, recognition, memory, including the knowledge and insight of the disease, purposeful movement, sensory perception, and reasoning. Over time, a person living with dementia will require more help to ensure their needs are being met. So due to physiological changes in the brain as a result of dementia, a person will have changes in how they communicate, how they behave, and how they process sensory information and emotions. These changes are not only upsetting and frustrating to the person living with dementia, but potentially you as a caregiver. People with dementia, they're like the rest of us. Each has a unique story and personality, and this includes life experiences, their interests, and preferences. Like the rest of us, they need caring people to help them stay relaxed, feel safe, and maintain their dignity. Their perception of reality, however, can differ from ours due to their dementia. So for example, somebody living with dementia might believe that a family member or friend who has passed away is still alive and present today. They may ask repeatedly where the individual is, and they may even set a place at the table for them. This altered perception stems from memory loss, confusion, and the brain's difficulty processing information correctly. At the Alzheimer Society, we believe in the importance of a person-centered approach to understanding changes in behavior. And this means that communication is possible at any and all stages of the disease. We want to focus on the remaining skills and abilities of the person that's living with dementia. We want to maintain kindness, compassion, reassurance, and positivity when we're supporting the individual. And as caregivers, we need to meet the individual with dementia where they are and accept their reality because we have the ability to do so. All expressions have meaning, and it's important to connect with the person behind the behavior to understand. And we always want to remember that the person is still there. Between 80 to 97% of people living with dementia will experience a behavioral and psychological symptom along their journey of dementia. Pharmaceutical management of behavior or psychological symptoms of dementia should be secondary and only when behaviors pose safety risks because there is limited evidence of their benefit. Medications do have side effects, and especially antipsychotics, they're associated with a higher risk. It is important to remember that while behaviors are very common across Alzheimer's disease and dementia, not everyone will experience them. And if they do experience them, how they experience the behavior is very specific to the individual. Responsive behaviors is a term used to describe changes in behavior that a person living with dementia may be experiencing. The term shows how the actions, words, and gestures of the people with dementia are a response to their current environment. When trying to understand, we must keep in mind that all words, gestures, and actions communicate meaning, need, and concern. The actions, words, or gestures presented by an individual with dementia can be a way of them responding to something negative, frustrating, or confusing in their social and physical environment. And the goal is to understand the behavior being presented. When the emphasis is on the person, behavior is not seen as a problem to be managed, but rather actions and expressions that need to be understood. We often react physically and emotionally to what is said both to us and about us, and language can affect us as powerfully as physical actions. Therefore, it's so important that we're mindful of how we are communicating with and about people living with dementia. This slide represents language that is commonly used to describe an individual who is demonstrating responsive behavior. The issue with this is that the language suggests that the behavior is a result of a problem with the individual. The focus is on the problem and not the person. And this is not in keeping with a person-centered approach or person-centered language. What you want to do is describe the responsive behavior in detail and be specific about what you are seeing. So the person is not acting out or agitated. They are pacing and appear upset after a family member has left because maybe they don't feel comfortable within the environment. It's important to look at the individual as a whole and understand how their backstory is influencing why a behavior may be emerging. So what do you think are some reasons or causes of behavior? So for those joining online, my colleague Bronwyn will be launching a poll momentarily, and you'll be able to share your thoughts. For those here in the room, please feel free to share your thoughts on what is causing or what are the reasons behind a behavior. So if you want, you can raise your hand and I can call upon you. Fear?
Detachment.
Attachment?
Detachment.
Detachment? Okay. Change in routine?
Change in environment.
Change in environment, change in routine.
Confusion.
Confusion. I heard pain over here.
Loud noises like more than confusion.
Yeah, loud noises within the environment.
Hunger, sleep.
Absolutely. Yes?
Sadness.
Sadness, yeah. Frustration. What are some of our online folks saying, Bronwyn? All of the above. Okay, so behaviors, they can be influenced by life experiences. So a former teacher might continue to exhibit instructive behavior, trying to teach others around them, or maybe they're organizing objects in a classroom. A retired doctor or a nurse may attempt to care for others by offering medical advice or checking in on those nearby. The state of one's physical health can also impact behavior. For example, physical conditions like dehydration, which can lead to increased confusion or irritability. Personality, so whether someone is an introvert or extrovert, will have an impact on how one behaves. Pre-existing mental health and addiction issues, so a person who maybe was previously depressed can become less communicative or may reduce or refuse to participate in their care routines. Other medical conditions, so for example, if somebody had diabetes, they may suddenly become disoriented or irritable if their blood sugar drops. Medications can also have an impact on how somebody behaves. So antipsychotics, as I mentioned earlier, can result in an individual becoming more confused and potentially sedated. And pain and discomfort. An individual in pain may refuse to shower, move, or participate in what we call activities of daily living because the pain is too unbearable, and they may not be able to understand the need or be able to communicate that they are in pain. Physiology. So a person with untreated hyperthyroid issues might experience more confusion, be lethargic or irritable, worsening their cognitive and behavioral symptoms. And finally, dementia pathology and progression. Behaviors can have a significant emotional, psychological, and physical impact of both on the caregivers and the individual living with the disease. For people with dementia, there can be emotional distress. So individuals with dementia often feel misunderstood or frustrated because they cannot express their needs or emotions. And this frustration can lead to feelings of fear, anxiety, or sadness. Social isolation. Repeated responsive behaviors can lead to a withdrawal of social interactions as people may avoid the individual, contributing to loneliness and depression. And quality of life. Such behaviors often result in interventions that can potentially reduce autonomy. The impact on the caregiver can include emotional and psychological strain. Caregivers often experience high levels of stress and anxiety when managing changes in behavior, and this can lead to caregiver burnout, depression, and feelings of hopelessness or guilt. We can see relationship strain. Responsive behaviors can lead to tension and emotional distancing between the caregiver and the person with dementia. And physical health. Caregivers may experience fatigue, back pain, or other conditions due to the physical demands of caregiving and the stress that responsive behaviors can cause. According to the Alzheimer Society of Canada, up to 90% of people living with dementia will exhibit some form of responsive behavior during the course of their condition. In Canada, about 61% of family caregivers, people living with dementia, experience significant stress. And this intensifies, this intensity is often intensified by responsive behaviors. A study from the Canadian Institute for Health Information noted that nearly 45% of caregivers reported their health worsening as a direct result of caregiving, and over 40% reported moderate to high levels of distress. In Canada, the high prevalence of these behaviors contribute to the significant emotional, physical, and social impacts, both for the individual with dementia and their caregiver, often leading to health problems and, as I mentioned, relationship strain. Because we know responsive behaviors to dementia can significantly impact both those experiencing them and their caregivers, the PECES framework was developed as a way to respond and understand. PECES offers a practical approach that helps families understand and respond to behavior changes. Recognizing the underlying causes of these behaviors is essential in order to minimize or prevent them when possible. This framework provides various non-pharmaceutical strategies to identify triggers and contributing factors, allowing caregivers to address the root cause. Since its creation in 1997, PECES has been utilized by healthcare providers and families alike to gain a deeper insight and understanding into behavioral management. PECES Canada emphasizes the knowledge, skilled teams are at the core of high-quality, person-centered care. Today, PECES Canada remains dedicated to developing educational programs on proven principles of adult learning, and the framework plays a vital role in enhancing the capacity of those supporting individuals with dementia, equipping them with the skills needed for effective care. PECES is an acronym that stands for physical, intellectual, emotional, capabilities, environment, and social and cultural factors. So you want to consider the person you're supporting as a whole and look at these pieces to see what might be contributing to the change in behavior. Once we have identified possible causes, we can then develop strategies to respond. So we're now going to work through the PECES framework piece by piece. Pain and physical conditions can cause changes in behavior such as resisting care, agitation, restlessness, anxiety, crying, and defensive behavior. Physical changes are often not obvious and they can be overlooked. The 5 Ds represent a simple way for us to think about physical factors. As we look at each of these 5 Ds, think about how they can affect a person with dementia. Our first D is disease. Any illness can cause changes in behavior, including dementia, urinary tract infections, constipation, pneumonia, influenza, etc. 75% of older adults have 1 or more chronic conditions. Dementia causes physical changes to the brain through the death of neurons. Although we may notice changes in a person's intellectual functioning, these changes in functioning are due to physical changes in the brain. Our next D is discomfort or pain. So ask yourself, does the person have pain or discomfort or a condition that might be causing pain? There are many sources of physical discomfort, whether it's a full bladder, constipation, being too warm or cold, hunger, sleep deprivation, or lack of a comfortable position. A person's physical surroundings can also cause discomfort, such as seating that's uncomfortable, soiled clothing, poorly fitted clothing, and eyeglasses that aren't to the current prescription. There are nonverbal indicators of discomfort to look for, which include clenched fists, moaning, being rigid, or holding and rubbing the area of the body. So if possible, we want to schedule personal care at a time when pain medications are working their best so the individual does have a minimum amount of pain. Unrelieved pain can cause depression, reduced activities of daily living, resulting in isolation and reduced quality of life. Drugs and alcohol is our next D. All drugs can trigger cognitive, mood, and behavioral changes. Taking multiple drugs can also increase the risk of side effects that require medical treatment. Even drugs used to help treat the symptoms of dementia can have side effects. So for example, GI issues. During our assessments, consider new drugs the person has started, possible drug interactions, and/or a drug withdrawal. And also keep in mind that medication adjustments can cause changes in behavior. Disability is next. A disability may be caused by communication changes, mobility or gait disturbances, or sensory impairment. Not having the appropriate assistive devices, such as our glasses, hearing aids, or a walker, can also affect somebody's behavior. So think, what changes do I see in the person's physical condition? If there are a change in alertness, energy level, eating, face grimacing, we want to be mindful of that. And delirium. Delirium is a sudden, significant change in a person's behavior caused by underlying medical conditions, including infection, trauma, medication interaction, dehydration, chronic illness, or drug and alcohol abuse. The symptoms include a sudden onset, confusion, changes in cognition, decreased focus, visual hallucinations, and a change in a cognitive status. Older adults with dementia are at a higher risk of delirium, and sometimes we might contribute the confusion to the progression of the disease. However, any sudden change in cognitive functioning should be looked at. We also want to consider any physical unmet needs when looking at the causes of change in behavior, including intake. So are they hungry? Are they thirsty? Are they dehydrated? How about nourishment? We also want to look at energy level. So the sleep-wake cycle, are they tired or are they kind of revved up? Output, so getting rid of waste or waste products. So think urine, feces, sweat, saliva, mucus. Environment, liking or not liking sensations, surfaces, social situations, or settings. And pain, body pain, joint, soft tissue, skin, emotional pain, spiritual pain. And don't forget to look in the mirror. Sometimes we are the ones with an unmet need as a caregiver. The next section of the PIECES framework is intellectual. Intellectual causes of behavior stem from changes in the brain. One way we like to think about the symptoms of dementia is using the 7 A's. So memory loss, loss of language, loss of ability to recognize objects, loss of purposeful movement, loss of awareness, misinterpretation, and loss of motivation. There can be many emotional causes of behavior. Everyone experiences a wide variety of emotions, but dementia can prevent a person from being able to recognize and communicate their emotions. We can never assume how an individual feels. Asking and actively listening can go a long way. Things we want to consider when thinking about an individual's emotional well-being include their losses. So it's important to know what losses your family member or friend might have experienced in their life, especially if there have been any recent or reoccurring losses. Adjustment. Change can be hard for anybody, but it's especially difficult for individuals who are living with dementia. So moving to a new space can be quite overwhelming, and then we can see behavior start. Fear. Memory loss can cause people, places, and things to become unfamiliar. And when fear sets in, some people feel the need to defend themselves, while others feel the need to avoid. So think of our fight, fright, flight, or fawn. We want to pay special attention to their surroundings. Do they feel safe? Are they being reminded of a negative experience? It's important to acknowledge the fear and do what we can to make the individual feel comfortable. Anxiety and depression can really affect everyone's relationship and their ability to think and cope with everyday situations. Trauma, so it's important to know what caused trauma recently or even in the past, as triggers will impact one's behavior. Delusions and hallucinations, so believing something is there or they hear something, it can be quite fearful. It can also be sad, but it can also be exciting. So think maybe if they're seeing a new baby. Boredom and loneliness are two of the biggest plagues many older adults face, and behaviors can be a way to relieve boredom or seek attention. And spirituality. So it is more than just religion. So taking time to appreciate the way one sees themselves in relation to the rest of the world is very important. So as mentioned, emotional needs can be easily overlooked and can be masked as something else. So for instance, what manifests as anger could really be frustration or a complete loss of purpose. So consider these emotional expressions of unmet needs when looking at the causes of change in behavior, including anger, sadness, loneliness, fear, and boredom. Capabilities is our next piece. Knowing what a person can and can't do can help us use their strengths and abilities without making tasks too challenging. So 7 important questions to ask yourself include, what does the person do? What does the person enjoy? What can the person do and how does the person do it? Which part of the task is the person not able to do and why are they not able to do them? Where does the person do best? When does the person do best? And who does the person do best with? So it really all boils down to what do I know about the person and what can you do to utilize their strengths? Next, we look at environment. Maintaining a supportive environment is incredibly important. The characteristics of a supportive environment include helping the person feel safe and comfortable, being flexible, respecting the need for privacy, and providing cues and be familiar. The things to avoid to maintain a supportive environment include noise and overstimulation, as this can cause anxiety or confusion. Understimulation. So on the other hand, if there's too little happening, boredom can kick in. Relocation, changes in environment and routine can cause anxiety, confusion, or fear. And environmental demands, expectations that are different from a person's belief or experience. And lighting. Poor lighting can lead to misinterpretation. So maybe shadows in a dark room. Contrasting colors can really help to identify changes in flooring, like steps going into carpet or carpet into tile. So you want to ask yourself, is the space friendly, familiar, functioning, and forgiving? Is it filled with people or objects that a person enjoys? Are there people or objects that tie your person to the whole world even before dementia was present? Does the space work with them and their current abilities? And what happens if the person makes a mistake? Ask yourself, what sensations and surfaces can the individual feel? What space do they have? What social opportunities are there? Could they be wearing clothing that is itchy or uncomfortable? Is there a surface that they are touching that isn't pleasant? If they are an extrovert, do they have the opportunity to be social with others? Or if they are an introvert, are there too many people around? So look at the space and see if it's cluttered or if they feel someone is in their space. The last piece is social and cultural. Each person has unique social and cultural needs. Things we should consider include their life story, including past experiences, their likes and dislikes, past routines, coping strategies, values, and beliefs. We want to look at their relationships, including the kind of relationships and how supportive they are, and others' understanding of their behavior. And look at their interaction with others, including how much contact they have with others and how well they get along. So PIECES recognizes all factors influence well-being, independence, and quality of life, and it provides a practical way to address changes in behavior. Remember, we look at the person with dementia as a whole and all the pieces to understand causes of behavior changes. So we look at the physical, the intellectual, the capabilities, environment, and social and cultural factors. And once we've developed our list of potential causes for behavior, we then need to develop strategies to respond. So for example, if under physical, we've identified pain, our response would be to ensure that we're managing pain. So now that we've learned the theory of PIECES, we're now going to apply it using a case study. For folks online, my colleague Bronwyn will send a link momentarily with a handout that contains the case study and can also be found on the screen. There's also the PIECES template. So for my online folks, please read the case study and then apply the PIECES framework to identify one possible cause for the behavior within each PIECE category. and remember to think of the whole person. I encourage you to utilize the chat to work through the framework with your other online participants. And you can use the table on the reverse side of the handout as a guide to organize your thoughts. The blank column is available for you to list possible causes under each category in the PECES framework. For my in-person participants, at your table, you will find 2 to 3 copies of the handout that contains the case study, which is also on the screen right now, and the PECES template. At your table, I want you to work in groups of 4 and read the case study and then apply the PECES framework to identify one possible cause for the behavior within each piece. Identify one person in your group to be note taker and use the table on the other side of the handout as a guide to organize your thoughts. Again, the blank column is available for you to list possible causes under each category. I'm going to give you about 5 to 10 minutes to work through this, and then we'll come back together. Okay, so I'm going to bring everyone back. So for Benita, these are the potential factors that may be contributing to her behavior. Once we've identified this list, again, our next steps would be to develop strategies for responding. So for example, consider whether Benita is in pain, which might explain why she's moaning, pointing to her hip. Then we want to consider, when was her last pain assessment? Has she received pain medication recently? Does the moaning stop after regular pain assessment and administering pain medication? So by working through the PECES framework, you now have a structured approach to understanding and addressing changes in behavior. And this method promotes problem solving, which will hopefully reduce the emotional strain on caregivers and help you remain calm under pressure. So I'm mindful of time, so I'm just going to skip some of these here. So in conclusion, it's important to recognize that all behavior has meaning, especially in individuals with dementia. Behavior is often a response to something, and it's not about an individual being difficult. When faced with changes in behavior, we should first ask ourselves if the behavior is posing a risk or if it's causing distress. If it doesn't, is an intervention necessary? Behaviors can be complex, so our goal should be to understand the message behind the behavior. By making the connection between the behavior and what the person might be expressing, we can better find solutions and truly address the underlying cause. Understanding must come first, and only then can effective responses follow. So that concludes our PECES presentation. I really do want to thank everyone for your attention and your participation during this session. I do hope that you found the information both helpful and engaging.
Our next sessions in this room, we're going to be hearing from Dr. Tim Stultz, MD, and actually, apparently I gave him a Ph.D. that he has not yet earned. You're welcome. His initials should be COE, which I understand stands for Care of the Elderly. So he's a doctor, so I just gave him a PhD. Dr. Stultz has been on this podium for us many times over the years. Today, he's going to be discussing In Our Stories Lies Our Strength, narrative care as a vital component of serving our seniors. So Dr. Stultz received his medical degree from Dalhousie in 1992, and he worked as a family physician in rural New Brunswick for 5 years before entering the field of geriatrics as a consultant geriatrician at the Moncton Hospital. He moved to PEI in 2004 as a geriatrician with the Provincial Geriatric Program and received his diploma in care of the elderly from Dalhousie University in 2005. He is a passionate advocate for older adults and their caregivers. In 2015, he took part in the development of a program that's probably familiar to most of you called COACH, which is caring for older adults in community and at home. He also became the medical director of COACH, as well as the primary geriatrician collaborator for the geriatric nurse practitioners at that time. Dr. Stultz and his wife Candace have 4 sons. They have recently become empty nesters, I understand, and they live with their poodle Pepper in St. Catharines, PEI. So pleased to welcome you back here, Dr. Stultz.
Well, good morning. Morning, everyone. Thank you very much. I'd like to really thank the Alzheimer Society for this opportunity. I also like to thank the sponsors. I don't know if it's important or significant or not, but I forgot to put my hearing aids in this morning because they weren't in the usual spot. We are creatures of habit. I like to, to quote one of my mentors and I think the smartest person I ever knew, Dr. Stultz from Halifax. When the Alzheimer Society asks, you say yes. So when they ask you to speak, you agree to it. I also want to recognize those who are watching from home, and thank you for your interest in that. Hopefully things will go well. I've been in your position many times since the advent of COVID. We had many conferences where we were sitting on the couch with the dog, watching on a computer. So this title of the talk, In Our Stories Lies Our Strength. I have to acknowledge Dr. William Randall, who was a gerontologist at St. Thomas University. He is the one from whom I have shamelessly stolen his slides and used many of the concepts that you'll hear about today. Many years ago, I'm not even sure when it was, I was asked to do a presentation at a senior strategy planning day. There were healthcare people and government people, and I was asked to talk a little bit about what do we need? What's the state of geriatric care or seniors care in PEI? And I cannot tell you anything about what I said other than one thing. And that was one little comment on the what do we need, and that is caregivers who get it. I was thinking at that time of an example of a lady. I was at that time working along with my geriatric responsibilities. I was also the house doctor at the Prince Edward Home. And there was a very wise LPN who got it. And what she did impressed me so much, because what she did was she realized this is Prince Edward Island. She realized that working at the PE home, almost everybody she was working with was a senior. Does anybody here know what do seniors do on Saturday nights in PEI? You listen to the hoedown. And so all these people were just in their rooms, doing nothing, interacting with no one. And she said, why don't we have a hoedown party? So she gathered up all kinds of people, took them to the living room of their unit, and got a radio that was good. Asked the kitchen for some snacks, but not in the budget, sorry. So she went and got her own, and she had a hoedown party on Saturday nights, and she had all kinds of seniors sitting around, people who didn't always interact or talk. And you heard Gary this morning talk about when he was speaking with his mother about the horse and the dog, that her eyes lit up. Well, that's what happened, right? That's what happened. These people got together and they were talking, they were laughing, they were enjoying themselves because somebody who got it took the time and effort and ingenuity to say, let's have a hoedown party on Saturday nights. And because of my lack of eloquence, all I could come up with, we need people who get it. Well, thanks to Dr. Randall, I now know what I meant by that. And he really put substance to that idea. And so I'm quite indebted to him. And as I say, I've shamelessly stolen most of his slides. So we're going to talk about narrative care, and we're going to talk a little bit about what that is and what we mean by that. So this was a quote that he started with, and it's a favorite quote of mine. Every time an old person dies, it's like a library burns down, right? What do you have in a library? books and books, and stories and information, context. You know, we talk about the people who work for years and years in a corporation and then they retire and that corporate memory is gone, right? Well, why is that important? Because you know the story, you know the history, you know what was, you know what how things reacted, how we changed, how we moved, how we pivoted. And so this is what the people who we as caregivers, as geriatricians, as nurses, family doctors, you know, personal caregivers, these are the people we're working with. The people all have stories. And when that person dies, those stories are gone. It's like the library burns down. Now, I think we've all seen this picture before. I guess it sort of shows up there. I think this picture is the one picture that really explains what we're talking about, right? When we look at this man, we see a man, he's elderly, he's bent over, he's frail, he clearly, you know, he needs a cane. But when we look at his shadow, his story, who he is, he's a young, healthy soldier. And he has that story. And I have many, many, many patients who have that story. Several patients who two actually that I can think of in particular, who were Air Force pilots in the very first supersonic squadron Canada had. They lived on PEI, imagine that. One of them was also a pilot in the precision team, flying team that predated the snowbirds, right? But if you don't ask, you don't know, right? And so this picture, I think, epitomizes what we're talking about. So our view of aging, often we tend to default to the bad news of aging. It's a story of deficits. It's a story of disabilities, of diseases, right? That's what we talk about, especially when we talk about healthcare people, right? That's our world. And aging does tend to be viewed as this narrative, this story of decline, right? I mean, what do they say when you pass 40 now? Oh, you're over the hill. Okay. Well, what's that mean? It means everything's downhill from there. That's our narrative. It's a narrative of decline. And I want this third bullet, I want you to try to keep in mind, because doctors in particularly, I think, we fall victim to this. We think of our patients in terms of pathology. They're a set of symptoms, their cases, their diseases. Now, you can't not think about those things. That's how we do our job. We have to figure out what's going on. But we have to be on guard all the time that isn't what our patient becomes. This set of pathologies, this set of illnesses and diseases. And this is one of the things that narrative care helps to protect against. So this narrative approach, humans we're meaning makers, we're story makers. We all have a story, and those stories are central to who we are. They're not just something we can, tell people. That our story and the model of narrative care, narrative approach is that the biographical aspect of our nature is just as important as the biological aspect of our nature. And we both age and our story changes over time. And this narrative approach looks at or envisions this idea of the positive potential of aging, where we are growing old as opposed to getting old, right? It's interesting if you look at the blue zone way of looking at life and the blue zone research and things. One of the things that's common in the blue zone, so these areas of the world where people live long, healthy lives, one of the common things is these people don't retire. They change jobs, they change roles, they change what they do, but they never stop doing. They never stop making this story. They never stop writing their story. It's an ongoing part of life. And so it's a potential, the positive potential of our aging, as opposed to this narrative that we said before of everything gets worse, we're declining. And a good, strong story is a key to facing the challenges of later life, because nobody's going to deny as we age, there's more challenges. I proved that last Wednesday night. One of my daughter-in-laws wanted to put a team into this thing that they have in Charlottetown, the Charlottetown Sport and Social Clubs, where you get a team together and every week you play different sports. And there's an old adage or an old question, you know, what's the single biggest cause of acute injury in old men? And that is old men thinking they're still young men. And last week it was soccer. I hate soccer. Right? So we face challenges as we age. But it's that good, strong story and that life living that allows us to help and face those challenges. And we see that in our caregiving as a potential a tool to use to improve our care. So, oops, sorry, I went the wrong way. So what about narrative care? What do we mean by narrative care? So key part of narrative care is that we listen respectively and attentively to and for a person's unique story. And I'll mention in a little while what we mean by that. And so the idea is that we have to take the time, we have to ask the questions, we have to take the interest in finding out these people's story. We have to ask questions and we have to listen to the answer. It's very easy for us, you know, I can speak as a physician, it's very easy for us to impart all our knowledge to people. But you need to listen to what their story is. You need to find out who they are. You need to find out what they need. Narrative care, it's a complementary care. It's a core part of care. It's not something that we do instead of medical science care. It's not something we do instead of a physical exam. It's something we do along with it. We find out and who this person is in front of us. What are their needs? Who are they? It's a core care, but it doesn't have to be costly. Now, people would argue, I was kind of discussing this last night with my son, and he said, yeah, but what about the people who say, yeah, there's two caregivers and 64 patients. I don't have time for that. Maybe that's time for administrators and government people and home care owners to reevaluate the model of how they provide care. Because getting to know the person, who they are, what their needs are, what their story is, that's the core to how we provide good care. And we don't need, now see, I'm given, as a geriatric practitioner, I am given loads of time. I often have had patients where families say, oh, nobody answered that question before. Nobody told me that before. My family doctor doesn't take this time. I said, well, whoa, your family doctor isn't given the time. I'm given the time, right? When I get an appointment booked with me, it's booked for 2 hours. There isn't a family doctor alive who's given 2 hours to do an appointment. So I recognize that, and I'm able in that way to take the time for this. Many caregivers who work in care homes or nursing homes or even home care going into the home, you know, you've got a schedule, you've got this much time. Even with those short times, it needs to become a priority for us to ask those questions, right? We make connections as humans. That's how we are. That's our nature. We're social beings. And making those connections allows you to get to know that person. And so that quality of that connection, even more so than the quantity of the time that we spend. The idea of this narrative environment. we live our lives in larger environments, and the work the writing that's done on narrative care talks about, you know, larger settings. You know, there's our culture, our society that puts certain necessary roles upon us. There are rules in our society we have to follow. And so that affects our story, that plays a role in developing our life story. But then there's also, you know, our history of where we worked or what we did for a living, and there are rules and roles and things in that area of life that co-author our story. And then there's our closer circle. There's our family, our friends, those who we interact with on a regular basis and more deeply. And then at the heart of it, there's our own personal life and story and interaction. And so those four general areas: society, our job or occupational, our friends and close family members, and then ourselves, our personal unique being, and those, all four of those play a role in developing our life story, making us who we are. And so each group has that narrative environment that contributes to us, and that's what we're listening for. So when we're talking to someone and finding out who they are, that's what we're listening for. We're listening for those factors and how they impacted on the person being who they are that's standing in front of you. You know, back about finding out about this information and the time we need. You know, I had a lady who I was asked to see one time. She had 3 daughters, 2 of her own, 1 adopted. She was living with the adopted daughter, and one of the other sisters was a little bit worried what was going to happen to the money and things like that, and was thinking, you know, maybe mom's, you know, maybe I need to take over looking after the money. So she convinced the family doctor to send a referral for her to see me for a capacity assessment for financial management. And this woman knew that. And when the secretary called to make the appointment, she said, well, I'll come, but I'm not going to tell him anything. And they came, she came into the office. She said, oh, just have a seat, he'll be right out to get you. Well, I'll go in there, but I'm not going to tell him anything. So I went out and got her, brought her into the office. I started with my usual, hi, I'm Dr. Stultz. I'm a geriatric doctor. That means I'm a specialist doctor for seniors. Your doctor sent me a note. She's been spreading rumors that you're a senior. Well, how old are you? I'm 88. Well, I guess it's not a rumor then, is it? So your doctor asked me to see you. How come? And she said, my daughter wants my money. So I thought, oh, good, she's going to talk to me. I said, oh, well, tell me about that. Nope. So we're a minute and a half into a 2-hour appointment. Nope. So I said, okay, where are you from? You wouldn't know. I said, try me. From a little place in New Brunswick called Waterside. Down near Cape and Rage or the other way? I said, right near Cape and Rage. I said, Sonny and Hazel Dixon, your neighbors? And her jaw hit the floor. And she said, how did you know that? I said, well, before I did this, I was a family doctor in Riverside, Albert. She said, well, I don't remember you. I said, well, I started there in 1993. She said, oh, I left in 91. I said, oh, where'd you go? She said, Salisbury. I said, oh, where'd you live in Salisbury? She said, Peter Street. I said, was Louis Pickett your neighbor? And she said, no, he was at the other end of the street. I said, yeah, down at the end of the street by the swimming pool. I said, his daughter Connie was the lifeguard there. She said, yeah. I said, yeah, she's married to my brother. I said, did you know them at all? She said, no, we weren't there very long. We moved. I said, where'd you move to? She said, Gunningsville. Guess where I grew up? I said, where'd you live in Gunningsville? She said, Blair Street. I said, interesting. Was Leroy Martin your neighbor? She said, no, I don't recognize that one. I said, what about Garland? Well, yeah, they were just across the street. I said, you know, I grew up on Wendell Street. That's the next street over from Blair. She said, oh, really? Did you go to that school? I said, yes. She said, well, my other daughter's married to a teacher. She said, he was the principal. I said, Dave Trenham. She said, yes, that's my son-in-law. I said, he was my grade 6 teacher. And I said, our class was his last class there. He moved to Claude D. Taylor School after that. She said, yes, he just retired. After that, she answered every one of my questions. I found out all about her money and all the stuff going on. And we had a lovely 2-hour appointment. But if you don't ask the question, you don't make the connection. I mean, this is PEI. What's the first thing you say? Who's your father? Where are you from? Right? I mean, that's how you do it. The other thing is, and I don't have any studies to prove this or not, but my impression is when people go into the doctor's office, they don't get a lot of time to talk. And so when someone's asking them about stuff that isn't related to their sore arm, just who they are or what's going on or where you're from, you know, my standard is, well, tell me about yourself. Where were you born and raised? And did you go to school when you were young? Well, how many grades did you go? Well, what'd you do after that? And usually I don't see anybody without a family member that knows them if I can help it. Usually it's the spouse. And so I'll look at them and say, well, where'd you run into that young lady? Who caught whose eye? Who did the chasing? You know, simple things like that. I think it helps relax people. I think it helps them open up a bit. There are a couple of people in 20 years that say, what do you want to know that for? Well, I just want to know who you are. What do you need to know that for? Well, it helps me to know you. I know what I'm doing if I know who you are. And so looking for these environments that people have grown up in, finding out about what home life was like, right? There's a lot of people in the current cohort of Islanders who had a very hard life. There's a lot of young women who were taken out of school after grade 3 or 4 because mom got sick and they had to look after the siblings. There's a lot of guys, 85-year-old fella from Vernon River. Did you go to school when you were young? Well, doctor, now you have to understand, me in school didn't see eye to eye. He said, I think I went for 2 years, but really about 1 because there was always something better to do. Right? Some kids had a lot of difficulty in their life. They had a hard time. The guys had to stay home and work. They needed the money, right? The girls had to help. They had to go out to somewhere else. They had to look after the younger kids. And if you don't ask that stuff, you don't know who these people are and what kind of impact those things have had on their life story and who they are. And then down the road, then how that impacts their behavior, how that impacts whether or not they want to take your advice, or why I should take this pill you're writing for me, or why are you taking that pill away that my family doctor gave me? Why do I have to see this other person? Why do people have to come in and help me at home? I don't want people in my house. You know, there's all kinds of these things, and to understand these people and what their story is and who they are helps you to be able to work with them to give them the care they need. Boy, that went fast. So narrative foreclosure, I want to speak about that, so I'll try to do that quickly. This is something that happens a lot. The life is over, the life the life is not over, but the story is. We as caregivers, as health professionals, foreclose narratively on the person. This is what we were talking about when I was talking about we pathologize them. It's a bunch of diseases and difficulties, diagnoses. We foreclose on their story. And if you work in a nursing home, you've seen this, right? If you work in a hospital, you've seen this, right? How many times have you heard the stroke in bed 4? Right? We can't be saying stuff like that, right? These are people. They have a story, and we don't want to narratively foreclose them. Or as you see there, de-story them. Say that 5 times fast and you get destroyed, right? And our goal is to re-story them. Say that 5 times fast and you get restored. Isn't that what we do as healthcare people? We restore people. And then we want to change that narrative from nursing home to nurturing home and re-story those people. Bring back their story, bring them back to living their lives. I was allowed to use this picture without permission because it's my dad. This is someone who was at high risk of being narratively foreclosed. My dad had Parkinson's, and during this picture, he was in the early stages of dementia that went with Parkinson's. This picture is in the airport of the Deer Lake, or the parking lot of the Deer Lake Airport, Newfoundland, last summer. My niece got married, and my father and mother weren't going to go because it's just too hard. And there were some in the family who pushed that they not go because it's just too hard, and it's too hard on mom. But what they forgot, they knew his story, but what they forgot was that his story was to be involved. He wants to be involved. He wants to be a part of stuff. That's his thing. And so, I guess earning my wings as golden boy, we made sure he got there. And when he got home afterwards, he said to me, the first words out of his mouth the next time I saw him was, "Thank you so much for getting me there." The other story about him being the story actually happened about 4 months before that. My mother's brother died, and we were coming over to go to the wake and to the funeral. And when I got there to Riverview from PEI, my mother said, "He's not very happy." And I said, "Why not?" Because others in the family said, "Oh, you can't go to the wake. It's too much for you. You're frail, you have Parkinson's." So I went in to see him and I said, "You're an adult. What do you want to do?" "I want to go." "Let's go." So we went. Right? So his diagnosis of Parkinson's and frailty put him at very high risk of being narratively foreclosed because he was looked at as that illness rather than as that person whose most important thing was to be part of stuff. Good, strong listening. We want to listen to and for the backstory. We need to explore our own stories too. And this comes back to this comment about maybe governments need to look at changing their model of care. We do need boots on the ground. We need people to do the job. It needs to be, we need to have that time, and caregivers need to be able to take that time, not only to find out about what the residents or the person has as a story and who they are, but also to reflect on their own stories. And there's actually research in the psychology world that shows there's a significant improvement in morale and job satisfaction, and perhaps a reduction in turnover if we're given the time for that. And this is this little remembrance of the medical sciences versus, or maybe in addition to, the medical arts. And you know, we need incredibly brilliant people who are doing that scientific research. We need people like Dr. Vitali, who's able to tell us, you know, here's how this all works, and this is all what we're doing. But we also need to combine that with the art of medicine, which is this idea of narrative care. So my story, very quickly, I guess I got less than a minute. I work with some wonderful people, Although they don't listen because I told them they could not come to this talk, they could go to the other one. And these are four of our nurse practitioners. I don't have a picture of our physicians, so bad, we get the nurse practitioners. But they all are excellent at learning the story. And my story is I get to work with these people who teach me stuff all the time. And I get to learn from them as well as sometimes help them with their work. That's my car. I tend to be the last one out of the parking lot most days. I also have pictures of my car and Dr. Carmichael's car, which I sent to her and said, we must be doing something wrong. Now, for those of you who know me, I will have to confess there are perhaps a few minutes in the day where there's some non-work conversation, which might contribute to that. But I put this up to say part of my story is I was taught by my father that you work until the work's done, right? You work hard, you do a good job. But in spite of that, I'm not adverse to having a little fun. This is my secretary, Rachel's van. Rachel and her husband are ardent Boston Red Sox fans. So of course, which team would be the anathema to Boston Red Sox? New York Yankees. I can't imagine why Rachel would write that on the back of her van. Although I guess her husband wondered how to get me my license removed when I saw that. This is my dog Pepper. And Rachel even was nice enough when I took her to work. Right? Rachel's story is she loves dogs, even if they're not golden retrievers. My point in these are, if I'm in your care home and I'm demented and I'm giving you trouble, I'm stuck on something and I won't change it, it's because my idea is I got to get stuff done. If you have a dog coming into your home, and if you don't, you need to, I want to be part of it. Make sure I'm there, right? That's my story. This is my yard. There's a garden. But what else do you see there? It's green. This is my wife and I a couple of weeks ago on the top of Mount Richardson in Gaspé. Outside, right? What you see there is that I want to be where it's green. So if I need to move to a nursing home, don't you dare put me one in the middle of a city where there's nothing but concrete. I want to be able to go outside. If you're working with me that day, put me in a wheelchair and take me outside, right? That's my story. If I'm giving you trouble, take me outside. I'll be good, right? Because that's what I like. By the way, gardening in homes, raised gardens, things like that. I keep pushing for this stuff. You need to do that stuff. PEI is a rural province. A lot of people garden. It's a wonderful way to give people a functional activity, things to do, purpose, right? It reduces your need of drugs. This is my driveway on any given Sunday. Those are not all my cars. Those are my kids' cars and mine. This is our table. What do you notice? There's more than 2 plates there. And that's my family, of whom I am extremely proud. The message, I want to be with people, right? If I'm in a nursing home, if I'm in a care home, do not leave me in my room by myself. I don't care if I'm not doing anything. Put me out where people are. That's where I want to be. That's what's going to make me easier to care for and more happy. And this is the biggest part of my life. I would say I am a Christian. This is the most important part of my life. And so if you're coming into my home to give me care, if I'm in a nursing home, if I'm in a community care home, if I'm distressed, if I'm troubled, if I'm activated, if there's a problem, if you have that same worldview, then feel free to pray with me or read me scripture or discuss these things with me, because I'm going to respond to that. One of the things I've found in my practice over the last 26 years is that although we have short-term memory loss with dementia, the long-term memory works really well in a lot of people. Those are areas that you can tap into to help with treating anxiety, treating agitation, treating overactivated. And in my case, this is one of the things that you will find will be the most effective. When I get into your home with my dementia. So very quickly, we all have a story. That story is who we are. You need to think about your own story. You need to make an effort to learn the stories of the seniors with whom you work. And then we need to use that knowledge to serve our frail seniors better and with greater personal satisfaction than we might have thought possible than ever before.
That, I'm probably not alone in the room to say that that was delightful. Really appreciated that presentation. Thank you, Dr. Stultz. I always have too much to say, and there's a lot of questions and thoughts that I have about that, but I'm going to actually leave it to the room. We have time for 2 questions.
Yeah, I mean, the home, one of the things I would encourage anyone who does home visits, always look at the pictures. Look at the pictures on the wall, ask who that is. You know, it opens such a, I mean, there's the potential for very painful things. That could be the son that committed suicide. But ask, who are these people? It's extremely helpful. Just to make that last quote for those online, work with someone with dementia, meet them where they are, not where you think they should be. Yeah, there was a care home when I worked in Moncton. It was very close to that, and they had what I thought was a very good approach to dementia. But the one thing that I'll mention about that place was all the food was cooked. It was a house. It wasn't a great big building. They had 50 residents, but they were in 5 houses, individual houses, like you grew up in. And all the food for that house was cooked in the kitchen, just like it is at your house. And that's another thing about my story. If I'm going to be somewhere where there's a kitchen for cooking food, I want to be close to that so I can smell it when it's cooking, especially if they're making turkey dinner. Just in case, because the memories that brings back, the peace, the comfort, and that was what this company did, and this group of homes did, was all the food was cooked on site in the kitchen. They all were in the dining room because, again, this is the Atlantic Canada, right? You don't sit in the living room unless you have company. You sit in the kitchen. Spend most of your time there. So the food was cooked there. You walk through the front door, you could smell it, just like at home. And I would definitely agree with you. A facility like that is what we should be pushing for. Thank you.
You know, we at the Alzheimer Society, we hear from families about all the good news and all the bad news in their experiences with the healthcare system. And one of the things that's pretty obvious is that for the most part, everyone's trying to do their best with what they know how to do. Do we need more education for healthcare providers? Absolutely. We need that. We need to support them with the skills and the techniques. But we also need to, and Dr. Stultz pointed this out really well, we need to have a system of care that prioritizes person-centered care in how long people are going to have, in the ratios of staff. You know, it's not just having knowledgeable staff, it's giving them the space to do this kind of important work, to be person-centered, to listen to the stories. It's one of the things with us that I'm pretty happy about at the Alzheimer Society. You know, sometimes when we're doing individual and family counseling, it's 15-minute, hi, how you doing? Things are good, not much has changed, okay, yeah. You don't need anything? 15 minutes, we're off the phone. And then we call back in 6 months, and maybe that call is an hour, maybe it's 2 hours, or maybe it's 3, or maybe we're going to the home, maybe they're coming to us. But we let the person set the time. So we are able to, and we do take the time for those things. And I wish that every healthcare provider had the time. So I'd love to see that happen.
All right, so I'm honored to introduce our next speakers of the day, my colleagues Shelley King and Maria MacLean, who will be discussing a positive approach in dementia care. Shelley King is the support service coordinator for East Prince and West Queens. As a licensed practical nurse with over 15 years of experience, most of her career has been dedicated to working with individuals living with dementia in various settings. Shelley is passionate about making a positive impact on the lives of those living with dementia and their caregivers. Maria MacLean is our support service coordinator for Kings County. Maria holds a Bachelor of Arts in Psychology from the University of Prince Edward Island and a graduate degree in Mental Health and Addictions from Dalhousie University. She's passionate about providing older adult population and developing ways to improve aging and quality of life through education and support. Please join me in welcoming Shelley and Maria.
So welcome, and thank you so much for choosing this session on building skills for resilience using positive approach to care with my coworker, Maria, and myself. I just want to let everyone know that all of the slides today will be emailed to everyone, so you don't need to worry about remembering everything that's on the screen because you'll have an opportunity to have that emailed to you. We have a packed agenda with a lot to cover in 45 minutes. So we're going to do our best to stay on time with everything. Over the next 45 minutes, we're going to look at resilience and what that means as a caregiver. Here we are. Steps to positive approach to care. Steps to positive physical approach. An introduction to the GEMS stages. What hand under hand is, including some practice with you all at the end. And then we'll have some time for a small amount of time for questions and discussions. So Maria is going to get us started off.
Hi, everyone. Can everybody hear me okay? Wonderful. So I'm going to be talking a little bit about resilience. Resilience is the ability to remain healthy during extreme stress. It's not something we are born with, but rather we develop it over time due to a combination of our environment and genes. I would also like to bring your attention to the image on the screen. As you can see, this tree is growing under adverse conditions, and it is growing in a place that is dry and desert-like, where high winds buffer it constantly. It has been shaped by its experiences, certainly just as you are each shaped by the journey with dementia that you are living with. However, with the right circumstances, you can continue to be healthy and well, despite the difficulties that you may face. This tree's roots run deep enough to get water, and the branches are strong enough to still hold the leaves and catch the sunlight that it needs. Soon we will talk about things that can help you as caregivers be more resilient. High resilience leads to positive outcomes in life, which can be seen in our relationships and improved physical and mental well-being. However, there's also low resilience, which can occur through the course of development and the lifespan if an individual is frequently exposed to traumatic, toxic experiences, and these experiences can outweigh the positive experiences in a person's life. When an individual has low resilience, they are more at risk for negative lifestyle outcomes such as diseases like heart disease, mood disorders such as depression, and poor lifestyle habits such as addiction. Toxic stress can shape the brain's architecture during childhood based on the intensity and duration of the stress exposure. And a lack of supportive caregivers can lead to no buffering against toxic stress. There are many reasons caregivers need resilience, and here are just a few. Processing the news of a diagnosis of a family member can be difficult. Often caregivers express grief and ambiguous loss, anger, denial, and sadness. Adjusting to new roles and routines at home in life can also be challenging for caregivers. Navigating and accessing services and the healthcare and community care system, and donating many hours of providing care to someone who depends on you, ensuring their care, safety, and well-being. Undergoing complexity caused by concurrent conditions such as mental health or addiction issues or cancer. Those all require management as well as a diagnosis of dementia. Adjusting to progressing symptoms as well, such as memory loss, behavioral and communication changes, and continuing to mitigate and navigate the other stressors that we face in everyday life. There are different degrees of stress. Each degree of stress has its own symptoms. I'm sure each of you in this room has likely experienced the increase in heart rate and intense focus associated with positive stress. Tolerable stress is temporary and mitigated by positive influences or relationships in our life. And toxic stress is an intense and prolonged activation of our stress response systems and occurs without any buffering from our positive support relationships. There are multiple types of stress responses, and not all stress responses are bad. In fact, some are healthy. Positive stress is a healthy stress and can be seen through deadlines such as assignments. Positive caregiver support can utilize this stress response to cultivate the mind to further develop resilience. Tolerable stress can be caused from a natural disaster, such as a hurricane, like the one we had last year, or the loss of a loved one. Initially, these concepts are negative. However, they can promote strength and resilience if the individual has the positive supports in place. However, toxic stress has negative effects on individuals, and it occurs when an individual has no caregiver support. Some causes of toxic stress can be abuse, neglect, parental addiction, self-addiction, or chaotic environments. Children exposed to toxic stress are at a higher risk for negative lifestyle outcomes, such as addiction, mood disorders, and diseases. However, individuals at any stage in life are at risk of negative outcomes due to a toxic stress exposure. Thank you, everybody. So if you would like to share some of the thoughts that you had at your table, please raise your hand and we can do so. For time's sake, we'll probably only do a few. Yeah, thank you for sharing that. Just to share it with the rest of the room, if anyone could not hear, you shared that the positive stress was support and good relationships, and some negative stress would be challenges with facing some responsive behaviors, such as compulsive actions and stuff like that. And I'm sure everybody in the room can relate to some of those things. Thank you for sharing. That's great. So just to share again, so that everyone in the room could hear, the back table discussed how we can create positive stress through physical activities, building relationships, and those other sorts of things. And that's a great way to look at things, is to look at what we can do to build positive stress, especially if we're lacking in it. Thank you for sharing that. So online, that they mentioned that a negative stress can be the difficulty when a family member no longer recognizes you and having to cope as a caregiver with the sadness of that, which I'm sure is something that we can relate to as well. Thank you so much for sharing that. Now we're going to move on, but if anyone would like to discuss this later, me and Shelley will be available for those talks. Okay, so there are many ways to build resilience, but today we want to focus on 3 key areas: education and information, knowing about the dementia progression and commonly occurred issues and how to mitigate them helps these situations be less stressful. Caregivers are more prepared to deal with the situations as they arise and feel confident to handle them. We hear a lot the phrase, "I wish I had known about the Alzheimer Society sooner." And that is because having access to information and education has made a real difference in people's lives. Planning ahead reduces the negative impacts of change and allows you to have a guideline in the event of sudden unexpected issues, such as planning for when a person living with dementia can no longer drive. Planning for how the individual will be cared for if the primary caregiver has to travel away or have surgery or unexpectedly ends up in the hospital. And those are just a few examples that we should think about and plan ahead for. Creating a network of social support is very important. Having meaningful connections with others, not just to share the caregiving load, but to be there as friends, and having people who understand your experience and knowledgeable people to be a sounding board or have a source of support. This is essential and extremely supportive of resilience. No one should have to go through this journey alone, and it makes a real difference to have a circle of support be there along the way. Additionally, it is also important for caregivers to create a positive outlook. This will benefit yourself as well as the person with dementia. It's important to reframe our negative experiences. We cannot change the past. However, we can learn from them and seek out education and support to improve current and future experiences. And it's important to find meaning in your caregiving role. Holding a sense of purpose is associated with resilience, and finding positive meanings and values improves our overall well-being. And if we can keep our well-being well, then we can also be a better support for the person that we're caring for. We won't take time to do this now, but later think about these questions in relation to your caregiving situation. We realize that you may not be able to gain all the skills you need here today. Dementia is very complex and everyone's situation is unique. But we do encourage you to seek out the tools and resources that can support you, whether it's planning, education, a network of understanding others, like one of your support groups, or just taking time to focus on self-care and creating a positive outlook. Again, before I wrap up, this is a simple example that demonstrates the impact of resilience and the influences that shapes outcomes. On the left side are all of the accumulated toxic stresses that can lead to negative outcomes and are the factors that contribute to low resilience, such as negative childhood experiences or genetic predispositions. On the right are positive supports like responsive, supportive relationships that you may have had in childhood, positive life experiences and learning, supportive relationships, and your knowledge and skills. We want to continually support resilience by tipping the scales towards positive outcomes for best physical and mental health. Today, we are going to put some new tools in your toolbox and add some new knowledge to your library. And we're going to add some boxes to the positive side of your resiliency scale. I would love for you all to feel like you could check off all 3 of these goals today. We have covered our first goal for today, which was to dive into the concepts around resilience and different forms of stress. We know what resilience is and how stress can affect us, and that there are things we can do to build resilience as caregivers so that you can stay healthy and well, even when caregiving becomes difficult. Which relates to goal number 2. We are going to explore some new ideas and skills to help us in caring. At the Alzheimer Society, we have many different education sessions that are free, and I encourage you all to watch our First Link Learning Series offerings as we get to dive very deeply into topics with those. But today we will be sharing some tools and techniques from Teepa Snow's positive approach to care. Before I turn things over to Shelley again, meaningful and supportive relationships are so essential on this journey. And I encourage you today, when you are surrounded by others living in a similar journey, to exchange numbers or social media contacts, have conversations, and make connections with Alzheimer Society staff and other healthcare providers who are present. Now I'm going to hand it over to my colleague Shelley, who is going to be discussing the positive approach to care. Thank you.
All right, so positive approach to care, what is it and how is it connecting to building resilience? So how many of you in the room have heard of positive approach to care before? Anybody? Okay, so I would say about almost half the room, maybe a little over a quarter of the room. So a lady by the name of Teepa Snow, who is an OT and a clinical specialist in geriatrics, developed positive approach to care. It aims to help care. Oh, hold on, I need to remember to do 2 things. There we are. So it aims to help care partners understand brain changes resulting from dementia and learn ways to approach that accommodate for those changes using a series of simple techniques. They're based on understanding the areas of the brain that are no longer working and making use of the parts of the brain that are still active, so that you can protect and grow your relationship through helping engage the person with dementia to participate in activity rather than doing it for them. Experience less resistance and experience less stress using the techniques we will be covering today. Positive physical approach, or PPA, is one of those techniques. It is a dynamic assessment of the other person's willingness, comfort, and ability to engage and interact. PPA is also a set of recommendations for how you physically approach and interact based on your assessment. Developed based on the knowledge that the person living with dementia experiences their environment differently than the person with a healthy brain. For instance, and as you'll see later, a person living with a form of dementia see their environment with a decreased peripheral vision. It is important to ensure that the person sees you before getting into their personal space. Otherwise, you could frighten them without meaning to. I'd like to introduce to you a concept called the GEM stages. Most of you are probably familiar with hearing the terms early, middle, or late stages of dementia. These stages are generally associated with accumulating losses as the disease progresses. Teepa Snow introduces a new way to look at the progression called the GEM stages of dementia care. The GEMs have a focus on the abilities the person living with dementia still has rather than looking at the losses. There are 6 GEM stages, and I'll take a brief moment here to describe each of them. A sapphire is a brain that is aging normally, flexible, organized, and is still able to work with all the other GEMs. People in a sapphire state are the ideal care partners for someone living with dementia, as they possess the adaptability to go with the flow and appropriately interact with the GEM state of the person in their care. No, when stressed, even a healthy brain can slip out of the sapphire state. When that happens, the best thing you can do is take a deep breath and a break if possible to help get yourself back into that calm, collected state. People in the diamond state are still clear and sharp, but become increasingly rigid. They tend to have a lot of facets to them, but are noticeably inflexible and are able to cut you or hurt you. Diamonds don't do well with change, but are still very much able to shine. They are who they were, but they are different. This can make it difficult to care for partners, to acknowledge that the person is really living with dementia, as they still know what they're doing, but appear increasingly stubborn. The emerald. So unlike the diamond, people living in the emerald state are no longer clear and sharp. This is usually the state at which people begin to struggle and get identified as having something going on. Emeralds are on the go. They might get lost in time or space, and their words aren't always as clear and sharp as they used to be. An emerald is flawed but unaware, thinking that everything is fine, so they may cast blame on someone else. In this state, care partners are likely to notice mistakes. Instead of pointing out the flaw, care partners will likely have much greater success with learning how to go with the flow. People living in an amber state tend to get caught in the moment of time. Many ambers are all about sensations and what something feels like. They are therefore more curious than cautious and lack safety awareness. An amber is all about seeking things they like, but may strongly respond to things they don't like. So in this state, at which care partners often struggle to not turn into a diamond themselves, as the person's behavior is so inconsistent to what it used to be. A ruby. In this state of dementia, fine motor skills in a person's eyes, fingers, mouth, and feet begin to fade. A ruby might therefore have trouble figuring things out visually and struggle with speech production, as well as chewing and swallowing at times. While fine motor skills get lost, a ruby can still do larger gross movements like clapping their hands or holding on to things. In this state, a person's strength remains fairly unchanged, so they might firmly hold on to you or items without knowing how to let go. It's easy for care partners to get stressed and go to the diamond state. So it is particularly important to step back, take a deep breath so you can get oxygen to your brain and try and let go of what you can so you can become a sapphire again. Similar to an oyster shell, which tend to be ugly on the outside but can hold treasured gems on the inside, care partners can find a pearl in this last state of dementia if they know just where and how to look. In this state, the brain has changed, so the person's reflexes are turned on nonstop. Body systems begin to slow down and gross motor skills are lost. The person becomes trapped, but with the right care, the shell relaxes just enough to produce the amazing pearl that's still in there. In this state, care partners tend to spend too much time and energy on preserving the shell, but miss the gems that are still residing inside. The question for all of us, can we see what's precious and unique? By seeing the person living with dementia as a valuable gem instead of an early, middle, or late stage, you're offering them the right care and setting. We're giving them an opportunity to shine. Caring for the person living with dementia is not easy. I don't need to tell you that. but with the right skills and tools, the journey can be significantly more rewarding. So positive approach to care offers variety of methods to empower care providers, including the positive physical approach. PPA is a dynamic assessment of the other person's willingness, comfort, and ability to engage and interact. Developed based on the knowledge that a person living with dementia experiences their environment differently than a person with a healthy brain. So here on this slide, the steps to a positive physical approach are laid out. We are going to get an opportunity to practice this. And for everyone in the room, there is a handout on your table that we've provided a print copy of this for you. Step 1 is to stop moving and pause about 6 feet out, knock or make a sound to get the person's attention before moving any closer. Greet the person. Step 2, greet the person. Bring a flat and open palm near your face. Step 3, move slowly, offer your hand if establishing hand under hand, which we will cover. Step 4, take a supportive stance, a dominant side, and turn to about 45 degrees so you're not taking up their entire field of vision. Step 5, get low and match at eye level. Don't be in a domineering stance above them. And step 6 is offer hand under hand as needed, which we will cover. Marie and I are going to demonstrate this for you, and then in a few minutes, you're going to have a chance to practice the positive physical approach. So even though it's stepped out and it sounds like a lot, if it becomes common practice, it just sort of flows together and you don't think about the steps. So if I were going to be approaching Maria, I would stop, make a noise. I have to get myself on camera. Yeah. Hi, Maria. Hi. I would offer a hand, and most often someone naturally just reciprocates the handshake. I would come down to her level. So I'll do that one more time. To get her attention, I would make a noise. Hi, Maria. Hi. We've made connection so I can go in closer to her personal space to not frighten her. All right, so now that we've shown you PPA, or positive physical approach, the next step, once you've gone in to reach in for the hand, is called hand under hand. So hand under hand is an evidence-based, research-proven technique developed by dementia expert Teepa Snow. It utilizes the remaining muscle memory of a person living with dementia to offer comfort and initiate activity. It also enables care partners to better assist in activities with daily living, such as eating, drinking, or personal care. Compared to the commonly used direct hand-over-hand approaches, hand under hand elicits the least amount of restrictive behaviors while giving the person living with dementia a greater sense of participation in their daily care. Why is hand under hand important? It can help engagement with activities of daily living, also known as ADLs, which is a term used to describe fundamental skills required to independently care for oneself, which is things like eating, bathing, drinking. Hand under hand helps initiate movement to help trigger them to complete the task. It supports them without taking over completely and connects the individual to meaning and purpose in everyday tasks. It is important to know the person's dominant side that you will be making the connection with, because they will prefer for you to be on their dominant side. Hand under hand helps preserve abilities and support the brain muscles. The old saying is true: use it or lose it. So remembering that we need to do things with the person and not to the person. So I just went over and demonstrated, for those that are online that couldn't see that it's quite common that if you go in and don't even say any words, for someone to reciprocate a handshake without even verbally asking. So now we're going to complete hand under hand. So after completing the steps to positive physical approach, as shown earlier, and we'll show you again, you go in for a handshake and they will almost always reciprocate. So thank you for doing that. Link your thumbs like in the photo, and Marie and I will also demo this for you. Turn your hands so that your hand is on the bottom and theirs is on the top. Support their hand with strength fingers, so your pinky and your ring, but leave your skill fingers, your middle index and thumb, free. Maria and I will also demo this for you. And then you're all going to get a few minutes to practice this together, and we'll go around the room and help those that are here in person. So we're just going to go back over to the computer and demo that. So the positive physical approach, again, is making that connection. So make a noise of some kind while I'm 6 feet out, getting her attention. Hi, Maria. Hi. So when I go in and we go to have a handshake, our thumbs are linked, and we'll walk around the room and show you, but her hand is on top. So she has the control to let go when she wants to. So we'll do that again. So when we go in for the handshake, our thumbs link like this, and she's on top.
Okay, so I'm just going to quickly tie this back to resilience before we close out. And unfortunately, due to the lack of time, we won't have the option for questions, but me and Shelley will be around afterwards. So please feel free to approach us and ask us any questions that you might have or any discussions. Or you can give us a call too at the Alzheimer Society. Okay, so to tie it back to resilience, learn skills for when dementia progresses and you need to provide more support to your person. These skills help provide less confusion and increase confidence and help you know what to do. You have learned the best practices that will help to avoid triggers for a person with dementia, and that could lead to stressful situations for both you and the person living with dementia. You have connected with others in this room and online who are knowledgeable and supportive. And please know that we are here for you through the Alzheimer Society if you ever would like to talk or require support. Thank you all for your attention.
This has been an honor to be asked to speak to you. When I walked in, I said, oh my, what did I say yes to? But I'm here, my family could not be here, but they're very much here in spirit. And I call them my Alzheimer's family. Dave, John, and Louise are here, and I know that they're supporting me from where they are, that's for sure. And as they said in the intro, I'm a sister to Vincent's mom, and I'm his aunt, of course. And I want to thank Laura for stretching me a little bit to do this. And I said, you know, everything about the story is not going to be here today, but to sit down and write the story with my sister, and she's great at taking notes. She had notes up the yin yang for 4 years. Anyway, so it worked out really, really well. And it was a great healing for her just to sit down, see where we are now and where we're going to be going in the next little while. And this story is really hindsight, of course, because we're here now, but it's looking back at what happened before and what it meant. In 2010, Vincent went on a marathon. And I'm not techie, and all I had to do was press a button. Anybody could do that. He decided with the friends at work, I'm going on a marathon. And when he was on the marathon, he felt a little bit of, he was getting winded, but of course he wasn't in shape. And he also was asthmatic. So after he went on the marathon, he went to the doctor and found out that he had cancer. He had a tumor in his chest. And after his treatment with chemo, his ex-wife said, wife at that time, she said there was a change. Something was different happening with Vincent. He became very self-centered. That's how she described it. And at that time, Vincent cannot remember the house he lived in. And he remodeled at that time when we talked to him. Does not remember living in the house that they were in at all at that time. So we wonder, did maybe the Alzheimer's start then? And he was only in his 40s. On 2015, Vincent left his wife and 3 children for a relationship with a much younger woman. Now that can happen to anybody, but it was very out of character for him. He didn't seem to be thinking rationally or doing things that were socially acceptable. He lost his job and that relationship ended. He then went to live with his mom. He had no job, was not looking for a job. He was making poor choices. His mom was a very hard worker. He was lazing around. And you know how that'd get under her mom's skin. And she said something about it. He was stealing. He was lying. He had no bills paid for. He was not accepting any job offers. And he wasn't helping me with my computer. That was the top. Because he was a computer whiz. Anyways, so we started really looking, what is going on here? Is he going through a mental health crisis? Is he depressed or what? Then it came to a head when he was caught stealing gas and was imprisoned. His mom, of course, is a very great advocate, pushed that the lawyer and the doctor asked the judge to have an assessment done, and the judge totally agreed. He had a brain scan, and they suspected the cancer could be back in his brain. The doctor said, I want you to go see a geriatrician. But Alzheimer's was not even in the cards of what could be wrong. But when that's what came out, that he had Alzheimer's, that really pretty well explained everything that he was doing up to that point. When my father was 80 years old, he suffered a stroke. It was a hard journey, but we expect that of an older man. But a young man like Vincent with Alzheimer's, that blew us away. Our lives are usually ordered that a son will be taking care of his 78-year-old mother, not his AFib, high blood pressure mom taking care of him. And she is one of those warriors, I'm sure there's some here. If she doesn't have something to worry about, she'll find something to worry about. But once a mom, always a mom. When he was born, she made that commitment to him. And around when all this happened, this is his children at that time. And when he had cancer, the little one there, she was a little bit older than that. That's what kept him going, had that hope that he was going to get better. He wanted to get better for her. So this is Vincent at the nursing home now. I said, Vin, I want to take a picture of you. I'm going to give a talk. Didn't tell him too much about it, but he said, okay. And this is his natural. And he's always been a very loving, caring person. And that has not changed. So which is good. Anyways, but his big thing at the nursing home is that computer. But you know, it's interesting. I was up the other day and the mouse, the battery's dying on it. He didn't get that. He didn't get that the battery was dying in the mouse. He just said it was kind of hard to use. So anyways, we'll have to get that fixed. Or it'll be like Dr. Stultz. He's not going to be having a good day. To this day, Vincent does not think there is anything wrong with him. And maybe that's a good thing. He seems to be happy as a clam. He says, Auntie, I asked him the other day, I said, what do you think about living here? Because he's been there now a couple of months. He said, I just love it. I just love it. And the big concern was that he wouldn't stay. There was so much stress for him to go in, but he adapted a lot better than especially his mom. So after the moving adjustment, he has been great. And the biggest challenge, though, is his personal hygiene. And when I talk to other people with Alzheimer's, that seems to be the case too. His rationale is that if I haven't been sweating, I don't need a bath. And he's not. We are blessed that he's adjusting so well. And as long as he has those tabbies, he goes through tabbies all the time on the computer, same ones all the time. Same games. He knows everything that's going to happen next. So, but that's his job. He considers that his job for the day. And he'll be on there for quite a while. Anyways, and of course, I think that comes out of him being a computer whiz. He was great at that. This is his children now. Vincent has 2 grown children, 3 grown children, I should say. And his son just got married last weekend. And he has a teenage daughter. Before the diagnosis of Alzheimer's, this family carried a lot of hurt from what their father said or did, because he was in the Alzheimer's stage. So now they're in the process of healing their relationship. He has no knowledge of whatever happened before. He names them all every day, and that's one of the expressions that he says all the time: I love you to the moon and back. His daughter's advice, the nurse that's there, she said, is to get help, get a diagnosis as soon as you notice something has definitely changed. His friends, his longtime friends, he had lots of friends in the community. He wasn't living in the community for quite some time. But with his friends, he'd go golfing with them. And he'd cheat. Well, you know, avid golfers, and you cheat golfing, that's not going to go over real well. But he didn't know that that's what he was doing. And when he'd golf, he'd go off to the other hole. They'd all be at the same hole. And so, and after he was diagnosed, they said we could see this happening, but they didn't know what it was. They just thought he was being a real jerk. And that's polite words. Friends in the community. I was looking at that, and before, somebody saw him crawling out of a dumpster one day up by the rink. And of course, in a small community, that went around Georgetown just like that. Anyways, but when they heard about his diagnosis, it all came together, and they were looking out for him. And that's what's the positive part of living in a small community. Another part of the story is Vincent's siblings. We just don't go through this world by ourselves, do we? His sister is especially close to him because they were born just a couple of years apart. And then 10 years later, my sister thought she'd have 2 more. So they remember, though, the brother that was their rock when their father left. And now their challenge is to be there for him, despite his needs and his idiosyncrasies. They wonder, could this happen to them in a few years' time? Their first cousin has it at a young age. His sister helped his mom a lot with the financial and legal matters. And to have power of attorney and all those things, it could only be obtained by the signature of someone deemed competent. And we were very fortunate that Vincent was able to get under that wire, barely. And they need to be able to understand what they're signing. These are the 3 sisters. Very different, I'll tell you that. Anyways, one of the things, my sister Bernadette, who was sick, she couldn't be here, and she would have loved to have been here. She said her advice is, as soon as you notice changes, something like the granddaughter, start acting to find out the why. You know, she said, you love your loved one dearly, and you don't want to put him anywhere else but with you. But I wasn't being fair to my son. I couldn't give him what he needed. Not what he wanted, but what he needed. She found it very hard dealing with all the support system and all the different people, but she was surrounded by people who cared and listened to her story. My sister needs the greatest support as she feels badly about taking Vincent to task about getting a job when he in no way could work at one. He was with her 24/7, so she really misses him and all his obsessive compulsive ways. And it took her time for her to let even home care come into the home. And for her to let him go to nursing care was really hard. They wouldn't take care of him like she would. But that's okay, because he's okay. For now, she can go have a quality visit with him so often as she can before things progress to the next level where he might not know her. She's beginning to enjoy her freedom again and her privacy. And as it was talked about here about mental health, that's where she was on a road to. She was on a road to very big mental health issues. She is so thankful for the support of the fine doctors involved with Alzheimer's, along with lots of the workers, especially Alzheimer's, accessibility, the coach program. She, and she's one of those people, you could ask her for the world and she'd give it to you, but she'd never ask you. She especially felt supported and tried to support the young dementia support group. That was such a blessing to her. And my advice is we don't go through this journey by ourselves. We have to go through it with other people who are going through what we are going through. Everybody's story is different, but we go to that support group every month. We started on Zoom, and now that we're trying to go in person, it's so much better. And just to listen to the story, going back to that again, you need to, the listening, for people to hear your story and for you to hear their story is so important on this journey. Big advice that they gave too in the support group was do not wait until a crisis happens to make a plan and carry out the plan. Because when you're in crisis, that's not a good time to be making decisions. And usually in the system that we live in, if you're waiting till you wait for your crisis, then months are going to pass before anything happens. She had to be able to trust people in this group. And that's not my sister. She doesn't open up really well, but it's amazing. The first time I said to her, I said, Bern, there's a support group for Alzheimer's. She said, oh yeah. And I said, well, you know what? I'm going, because I need to know how I can support you and Vincent. So I said, we're going to be on the computer at my place if you want to come. I just left it with her. Because for her to make a decision, it's not, yeah, I'm coming. Could be 2 weeks later, she'll say, yeah, I thought about that. Anyways, she said, do I have to say anything? That's her big thing. Do I have to say? I said, no, you just have to sit there. I said, don't worry. Well, guess what? Even the first night, that changed. She was touched, very touched. So it's a burden shared is half the burden. Get whatever support you need. Be it family, friends, church group, whomever is there that is willing to support you. And now we're going to sing. That's one gift I have. I can sing. Well, I might not be able to. I'm getting pretty dry right now. Some of you, now the age group that's here, I can't imagine anybody not knowing Lean on Me. Right. All of us know it? Good. All you know it, all you are going to sing it. Doesn't matter what voice you give back. Okay, so this is Bill Withers. And I said, well, you know, put some music. They said, well, sometimes the sound doesn't. I said, fine, put the words up. That's all we need. Sometimes in our lives, we all have pain. We all have sorrow. But if we are wise, we know that there's always tomorrow. Lean on me when you're not strong. I'll be your friend. I'll help you carry on, for it won't be long till I'm gonna need somebody to lean on. You just call on me, brother, when you need a hand. We all need somebody to lean on. I just might have a problem that you'll understand. We all need somebody to lean on. Call me if you need a friend. Call me if you need a friend. Call me. Call me.
Thank you so much for sharing your experience with us. I think the most important voice in the room is always the voice of lived experience, and it's an honor to be able to hear your story today and your family's story. We're going to move into our research panel at this time. We're going to take a trip across Canada. We're going to start in BC, and each presenter, I would ask if you could keep your presentation to around 9 to 10 minutes maximum, so that we can have some time for questions. Please join me in welcoming Dr. Michael Adachi. Dr. Adachi is an associate professor of the School of Engineering Science at Simon Fraser University, where he is leading a team developing new electronic sensors for the detection of fluid biomarkers of Alzheimer's disease. We're just going to hear a very quick 10 minutes about the research that he's doing to make some of these tests even quicker.
First of all, I'd like to thank the Alzheimer Society of Prince Edward Island for this invitation to give this talk, and especially to Laura. My name is Michael Adachi. I'm an associate professor out on the West Coast for about 4 hours earlier in the day. We're working on some new biomarker sensors. So we're trying to, I guess, make it easier to get tested for these biomarkers. And so representing a team of researchers, my collaborators are Dr. Karen Kavanagh from physics at SFU, and also Miriam Rosen from kinesiology at SFU. So just a really short introduction. About 700,000 people in Canada are living with dementia, and Alzheimer's disease is the most common form of dementia. The researchers have found that there's changes in the brain that begin over a decade, sometimes like 2 decades earlier, before the clinical symptoms are noticed. And recently, 2 disease-modifying drugs have been approved by the FDA in the United States, and they're specifically for treating early Alzheimer's disease and mild cognitive impairment. So it's quite important to, I guess, detect or get diagnosed at an early stage. And then currently doctors use a number of different techniques to diagnose Alzheimer's disease. They might take a medical history, a neurological or physical exam, do brain imaging, and more or less commonly, they might do biomarker testing by taking cerebral spinal fluid from the spine, where the concentrations of these biomarkers are high. And then in some cases, they'll do blood tests or urine tests to rule out any other disorders. And biomarkers are useful for a number of reasons. There was already the plenary talk that discussed biomarkers in more details, but very briefly, biomarkers can be used for diagnosis, determine if someone might be at risk of developing disease. Could also help determine what type of dementia one might have, and also monitor the effectiveness of some of the new treatments that are becoming available. Also, biomarkers play a really important role during drug development. So the 2 recent treatments that became available, they were using biomarker concentrations to determine the effectiveness of the drugs, and that helped streamline the FDA approvals. And recent studies have shown that blood biomarkers have high prediction accuracy for Alzheimer's disease Alzheimer's disease diagnosis. On this slide, we just list some of the different biomarkers that people are studying. Amyloid beta and tau are the most common ones. They're actually related to the hallmarks of Alzheimer's disease. Like amyloid beta can form plaques, and tau can lead to these tangles in the brain. And then there are other ones as well that have gained quite a bit of interest as well. There's one called GFAP, and that's kind of indicating some destruction of nearby neurons, neurofilament light, which is released by axons that are injured. And then there's some other proteins that will indicate inflammation, or there might be a genetic risk factor. So the two that we've been working with are so far is GFAP and also neurofilament TNF alpha, and we're also looking at neurofilament light as well. And just to give a quick background, there are a number of methods to detect these proteins already, normally based off of immunoassays, the most common of which is a system called ELISA. However, fluid biomarkers in the blood have very low concentrations. So normally you need a very sensitive method to detect them in the blood or other biofluids. And a very common one is called single molecule array. Samoa, there's two of these systems at UBC. And then there's another method called mass spectroscopy. And then a commercial system called the chemiluminescent enzyme immunoassay. So these are very sensitive methods that you can actually reach the concentrations needed or detection at concentrations needed to detect these biomarkers in blood. However, there are a number of drawbacks to the existing methods. Normally, the equipment and operation is very expensive, so all the samples have to be sent to a centralized lab, and it's quite time consuming. It could take a week or more to get your test results. In the US, actually, these tests are available, but they're normally come with a fairly high cost, so somewhere between $500 to $1,200 for one blood test. So what we're doing is we're trying to find a more accessible or a lower cost, simpler way to detect these biomarkers, and I guess we could conceptually see this test done as maybe as a blood prick test. So we do a blood prick. We really only need a few microliters of fluid to do this test. And then after taking a blood prick, there'd be some kind of blood preparation to separate the red blood cells, white blood cells from the rest of the fluid. So you put the fluid onto the sensor, and then there'd be some kind of electronic readout on the computer. This slide kind of shows what the fabricated sensor looks like. It's a very small rectangular chip, and then we'd put it into an electronic reader, and there'd be some kind of USB-C connection or wireless potentially as well to read out the electrical signal onto an electronic device. And a lot of the, I guess, specificity, meaning we want to detect one particular biomarker in a sea of, let's say, in blood, there's like over 20,000 different proteins. We need some kind of biorecognition molecule. We've been working with two. One is aptamer, a DNA aptamer that it has a sequence that specifically binds to a protein. But we've also been working more recently with antibodies. So the idea is we have the sensor that's shown in the middle here, and then on top of it we'll have a linker molecule which connects to the biorecognition molecule. And then on top of that, we introduce the protein or biomarker that we're interested in detecting. So in this case, we started off with TNF alpha, which is an inflammatory cytokine or inflammatory biomarker. And when it comes to the surface of the sensor, to interact with the aptamer, that brings charges to the surface of the sensor, which is down here, and that could be read out electronically. So this kind of gives us an overview of some of what the electronic readout looks like. And so what we've been looking at is something called rectification ratio, which is just the current flow at two different voltages, -1 and +1 volts. And what we notice is that electrical signal has a strong function or strongly related to the concentration of the proteins that we're introducing. So what we found quite encouraging is that we can detect down to at least 10 femtomolar. Femtomolar is 10 to the power minus 15 molar, so it's quite low, and it's lower. Importantly, it's lower than the concentrations of these proteins found in healthy blood, and then the range was actually quite large too, so we can detect up to 100 nanomolar. So that was I guess some of the work that we've published, and one of the I guess important factors to consider is specificity. Like, will we be able to detect these proteins if there are other proteins in the fluid? So we did some tests. First of all, we checked if we could detect these proteins if we don't have the biorecognition molecules, and we confirmed that, okay, if we don't have the biorecognition molecules, we don't have any output, sensor output, which is what we wanted. We wanted to show, okay, what we're detecting is actually the protein that we're targeting. Then we also tested a couple other proteins. One is called IL-6, their C-reactive protein, and they actually showed a little bit of a signal, especially the C-reactive protein. More recently, we've been looking at replacing the aptamer with antibody, and that gave us much better results, and we were able to push these bars a lot lower and mostly just detect the protein of interest. So some of the milestones I would say that we've achieved is detection of two biomarkers, GFAP and TNF-alpha at femtomolar concentrations, and our next steps include actually using human biofluids like cerebrospinal fluid and blood, and also upscale the sensor device fabrication process. I'd like to acknowledge our team of graduate students and collaborators and funders for their support with this work. Thank you very much.
Thank you so much, Dr. We are going to save questions for the end. If you have questions about the new technology that they're looking at that is more sensitive in looking at biomarkers, we'll have some questions maybe at the end. We'll have about 10 minutes. Are you okay to stay with us, Dr. Adachi?
Yes,
Wonderful.
absolutely.
Thank you so much.
Thanks.
I'd like to now welcome Dr. Arlene Astell. She is a psychologist with 30 years of experience working with people living with dementia in research and clinical settings. She is she's the director of the Dementia Aging Technology Engagement Data Lab, which promotes positive aging through creative applications of digital resources and psychosocial interventions. Today, she will discuss what is self-cueing and why is it important to cue dementia. Hello, Dr. Astell, welcome.
Hi, thank you so much for having me. Okay,
Absolutely.
shall I just dive in?
Yeah.
Perfect, thank you so much. Okay, so I'm very briefly going to introduce you to this topic. And this is a new project which is funded by the Alzheimer Society of Canada through their proof of concept scheme. And part of the definition for those projects is that they are high risk, they're a bit blue skies, they're a bit sort of new ideas. So it's not guaranteed that they will work necessarily, but it's worth investigating. So that's just to explain. So the background to this, and I'm sure I'm preaching, I'm not telling you anything you don't know, is but people who are living with dementia, often at the transition in their loss of independence and needing more assistance comes from when they start to struggle with finishing, getting through their everyday activities. And that can be in the home or outside the home. Lunch and a cup of tea and so on. And he found these 4 errors. So basically omitting something, leaving something out, getting interrupted and then getting stuck, repeating things, so not keep remembering that they've already done something, or difficulty finding items like maybe a knife or a plate or the tea bags or whatever it is. Now, what can we do about that? Well, what I'd like you to do now is for you to think about an activity you have done today, perhaps when you were getting ready since you got up this morning. Maybe you made a hot drink, maybe you made some breakfast, maybe you put some laundry on, you made your bed, You chose what clothes to wear. You selected maybe some outdoor garments, depending on the weather. And all of those require cognition. So thinking, planning, evaluating what's happening. If you start something like a hot drink, if you think it actually has a lot of steps in it. So you maybe get a kettle and you fill it up, and then you switch it on, you get a mug or a cup, you get your tea or your coffee, you might have milk, you might have sugar. So those are all components, and our cognitive abilities, so our planning and monitoring, initiating and tracking, are all working when we do these things. And mostly these things go without incident. But if we look at something like the laundry, or if you use a microwave, if you think about the last time you bought a new one, or you had to get a new one, there's a phase where we have to learn all those steps, like what program to use, how to use the controls, for instance. And when we do that, we go through a learning phase. And part of what we do is cueing ourselves. We learn those steps. And so self-cueing really refers to the processes we learn or we develop to help ourselves get through and complete tasks or achieve different goals. So mostly we don't think about these things because we get through them fine. We become practiced and rehearsed and so on. But we know that when people develop cognitive impairment, those things can become challenging. So this is where this study comes in, because what we're interested in is learning, first of all, how people cue themselves through tasks when they're just doing it without any difficulties. So we want to know, what are those successful strategies? And people, as I say, might not be conscious of them. They might just do it automatically. But we also want to know what happens when people get stuck. Can they get themselves back on track? And this is where, and I'm sure there's many people in the room beside me who've done this thing where you make yourself, maybe you put the kettle on and you go and do something else, or you make a hot drink and then you forget to drink it, or you put something in the microwave and then you come back an hour later and it's still there. You know, we all have these everyday lapses, but we can get ourselves back on track. We can overcome those. So what happens when people get stuck, and what happens when people with dementia get stuck? Can they cue themselves back on track? And the idea is that by understanding this better, what happens when people are carrying out these everyday activities, this could provide, help us make a future support, whether through technology or through some other means, to help people get back on track so they can complete their everyday tasks for longer. Because we know that the bits, like the physical bits, like pouring a kettle, spreading bread, putting on clothes. Obviously, there's some challenges that come with different types of clothing, but you know, a lot of the physical bits can be done. It's the planning and the thinking and the tracking that tend to be the most problematic. So we're using some interesting methods, and we've been doing some of this work already with just student volunteers, just to get a sense of what these activities involve. We have 3 activities. We have making a bed, making a hot drink, and folding laundry. And I know I can't hear your answers and I can't do a show of hands, but if you had asked me beforehand which was going to be the most variable, I think I would have said making a hot drink, because it's got a lot of steps. But actually, that's the most consistent task that people do in the same order and so on. Folding laundry, oh my goodness, there's as many different ways to do that as there are people who are doing it. So we've been trying to get a sense of what these tasks involved and where are those all sort of pinch points where people might go off track. So what we're doing now is this multi-data collection, and we have several things. We have a video camera, 2 video cameras positioned, and I should say at the moment this is in a lab that's created for research. It's called the Home Lab. So we have video cameras. We also have eye tracking glasses. So they look like normal spectacles, but they have a little camera built in. So you can see where people are looking, and it calibrates to their pupils. So you can actually see exactly what they're looking at. We have a wearable, like a watch, that measures some of the physiological things, including steps, but also heart rate. And we also have a person, old school, who sits there making any notes. This is a 3-part study. So we have the first part where people come into the home lab and they do those activities like you just saw the students doing. And the idea behind that is to try to capture that range of what's within the normal range for a group of different people. So we have people who will come in who don't have cognitive impairment and people who do have cognitive impairment. We're then taking this kit, hopefully, if people agree, to people's homes, where they're in a familiar environment and they'll have much more things to cue them in their environment, like everything's in the same place, or they know where, they know where things are. And so they have much more supports, we believe. And then we will use that data we collect to develop and test some cueing strategies that we're going to try to work with people with cognitive impairment to use. Now, there is some background to this, but the studies that have been done before have been done with different groups. So some of the research has been done with people who've had a stroke and have aphasia. And so this sort of self-cueing approach has been used to help them with relearning words. There's also been research done with children, perhaps you're not surprised, to help them achieve goals. And it teaches them strategies to cue themselves through the steps to achieve a goal. And interestingly, from the domain of sports psychology, there is training professional tennis players to develop their own cues, their self-cueing, to improve their tennis. So we're also looking at that sort of previous research to help us understand what techniques might work for people living with dementia. Because you might be sitting in the audience going, yeah, but if you're going to get them to do something else, that might be more of a cognitive load than just doing the activity. So we're very mindful of not adding additional things onto people when they're already sort of having to put a lot of effort into completing things. So this is just an example from our data collection. So this was to show you that on the left-hand side is the 2 video cameras. So we have them positioned, one to see the whole person and one to see them actually doing the activity. And then the one on the right with the red circles is the eye tracking. And that's absolutely fascinating, the data we've already collected, because you can, what we've noted is people look ahead. They look ahead to what's going to be part of the next step. And that seems to be how they are automatically cueing themselves. And it's really fascinating because people don't seem aware of it, but we only learned that from doing the using eye tracking. So it's a fascinating tool. Anyway, so that's really what we're doing. If you're interested, if you'd like to be involved, you can contact us. And I'm really happy to explain a bit more about the project if there's time. Thank you so much.
So you can't hear the applause in the room, Dr. Astell, but there's about 208 people here that are watching you today. And
thank you.
So thank you so much for your presentation. If you're able to stick with us for a little bit, we'll have some questions at the end.
Perfect. Thank you. Love to.
I'd now like to welcome Dr. Lili Liu. She's a professor in the School of Public Health Sciences and Dean of Health at the University of Waterloo. She maintains an externally funded research program that focuses on acceptance and adoption of technologies by older adults, their care partners, and healthcare professionals. Dr. Liu's current research program examines the application of technologies and other innovations to mitigate the risk of going missing among persons living with dementia. And Dr. Liu, am I pronouncing your name correctly?
Yeah, you're doing
Great.
fine.
Thank you, and welcome here today. Thank you so much for your presentation. You'll have about 10 minutes and we'll take questions at the end.
Thank you, Jaime. Hello, everyone. Thank you for the invitation to talk about our project that we just completed and funded by Public Safety Canada on the understanding and management of risks of going missing among persons living with dementia. I want to begin by acknowledging my collaborator, who's a co-PI on this initiative, this funding, and that's Dr. Antonio Miguel Cruz, who is located at the University of Alberta, in the numerous, too many to name here, but the numerous postdoctoral fellows, grad students, undergrad students, and research assistants and volunteers that are based across various provinces. I will be putting up the website again, but for those of you that want to jot it down, the link here, and I think we can share the slide deck as well, Jaime. If you're interested, you can visit this website to access all of the material as well that I'll be talking about. So the purpose of this initiative that we just completed this summer was a 3-year funding that we got from the Government of Canada, was to work across 7 provinces. That includes 2 Indigenous communities. The communities were located in Manitoba, that's with Peguis First Nation, and with Ganawake in Quebec. Our endeavor was to address 4 initiatives. One was to examine data from police, search and rescue, from Medical Alert, and InterEye, which is international. In this case, it would be only Canadian data from home care. That was the understanding of dementia, of this particular situation of risks of going missing. And then we developed 3 sort of products. So the other 3 initiatives relate to creation of dementia-friendly resources for first responders, development of a safety-focused digital toolkit for all members of the community, whether they're care partners, persons living with dementia, or first responders, and then a best practice guide for return discussions, which I will discuss later. So to begin with, we, probably all of you who have ever visited, which would be all of you, an Alzheimer Society website will commonly see the statistic that 3 in 5 or 60% of persons who have a dementia will experience going missing or getting lost. That statistic, to this day, we believe came from the US, but it's not very helpful. It doesn't describe repeat incidents. It doesn't tell us what the resources are, and actually doesn't tell us where that data comes from. So what we decided to do was to get a better understanding of what is the actual situation. So what you see here is a slide that describes the sources of data that we collected in this 3-year project. And you'll see we access data provided to us by Medical Alert. These were all slightly different years as well, captured, but we can talk about that later. So Medical Alert, and you'll see the total number of incidents of, we call them critical wandering. In other words, these were wandering incidents that resulted in a person going missing as opposed to getting lost. They go missing, they're not where they're supposed to be, and a call has been put in. As well as the prevalence, those who ever wandered. And so you'll see those, the statistic is much higher, the prevalence among those who subscribe to Medical Alert, so nearly 30%. And then the average across 6 police services, as well as British Columbia Search and Rescue, average was about 10, but it ranged from 2.4 to as high as 34%. And then last, you see the data that we collected from InterEye, well over almost 1.6 million data points of individuals in home care. And there, it's 3%. So that gives us a better idea. And then what can we do? How can our understanding be actually improved by having statistics? So first of all, we know now the prevalence of missing data is high, but it's not like 60%. That 4 in 10 wander, get lost at least once, and 2 in 10 actually do so repeatedly. And this is according to just the data that we have. It's incomplete. It doesn't include all the provinces and all the other sources. We know, of course, and this is just verifies what we assume, is that those with Alzheimer's and dementia and who are older demonstrate a higher risk. Those with repeat missing incidents are high, and that those, are low, and that those who go repeatedly missing range from 2 to 11 times among some people. So some of the highlights are that the lost time is about 4.5 hours, according to police data, and according to search and rescue, 21.5 hours. And that's possibly because it takes a little bit more time to dispatch search and rescue. Often police would engage them. The distance between last seen and found is just under 10 kilometers, according to police data, and under 4 kilometers, according to search and rescue. That among the police data, 25% of the population are found less than 500 meters from the original location, and 50% are found within 1.6 kilometers. And this varies again with the search and rescue data. 25% are found within 600 meters and 50% within 2 kilometers. The prevalence of dead on arrival or injuries is actually low, but of course, for all of you that are in the audience, 1 is too many. It really does create distress, and imagine the cases or the individuals that are never found, which is turning out to be more common. And this, by the way, is just data from 3 of the sources, doesn't include the home care data. We have more information, and we've published on some of this for those of you that are interested. So you can, again, refer back to the slide deck. I think one of the highlights that I will point to is that, in fact, there are silos when it comes to data collection, and that although in our own research, we're gaining a better understanding of this particular situation, this issue of going missing and the risks associated, we still don't know as much as we should. And a lot of that relates to missing data on missing incidents, and also the inconsistency with the way data is collected across the country and across different sources. And now what I'd like to talk about are some of the resources that we have developed to address the other focus of our funding of this project, and that is the management of risks of going missing. So what we did was we partnered with various Alzheimer societies, with persons living with dementia, care partners, health and social care providers, search and rescue groups, fire departments, paramedics, and many others to come up with resources to help first responders. This all initiated with our understanding that, in fact, individuals, first responders such as police officers, actually get no training. I know the ones in Ontario possibly get 1 hour from the Alzheimer Society of Ontario, and so it's very limited. So we went ahead and co-created 9 training videos. They range between 2 to 3 minutes. They're free, they're online. They are available English, French, and 2 Indigenous languages, and they are now being dispersed across Canadian Police Knowledge Network. There's a website for that as well. The target for these resources is those who are first responders, but anyone can find them useful. And you'll see here the image of the 9 videos, and they range from just very basic aging and dementia, what is it, all the way to how do you prevent missing incidents. There are specific in our data and also in other research that we have become familiar with, of course, this concept of missing behavior, and so, or lost behavior, so that it's really important for first responders to understand that the search and rescue strategies and techniques that you would use to find someone or locate someone who is living with dementia would be different from other populations. So we try to highlight that. And of course, there are 2 that are focused on Indigenous communities. This is a sample of a video. I'm not going to play it, but you can see it was trying to play. So I'm just going to go on for to honor time. The second resource that I want to introduce you to is that we just completed is called Dementia Safety Toolkit. Again, co-developed. It's a toolkit that, again, is available on the website. It's in English and French, and there's a hard copy as well. You can print it off, and it's free of charge. And it goes all the way from introduction to strategies, resources. Each chapter is, there are case scenarios woven through this toolkit. And we hope that this will be useful for those that are locating resources to share with others. The return discussions is the 3rd resource that we have provided. This is a concept that originated from the United Kingdom. It doesn't exist in Canada. And so we decided to work again with our partners to develop a best practice guide on return discussions. We know that if we do this, once a person is located and returned home, that it could prevent future missing incidents. And that was one of the priorities of this funding, is to identify strategies for prevention. And that's the website for the return discussion guide. I think that's it for my time. We're just over 10 minutes, so I'm happy to answer any questions from the audience later. Thank you.
Thank you so much, Dr. Liu. And these are wonderful resources. I hope that we will be sending out the links to the shared resources as well. And we do, as an Alzheimer Society, have a connection here on the island with Ground Search and Rescue, as well as with the local police academy. And these resources are being shared with our connections locally also. So definitely a very important issue, and a lot of great information is found in those kits. So we will leave some time at the end today for questions with you, Dr. Liu. Finally, please welcome our very own Kristen Sherman. She holds a Master's of Arts in Counseling Psychology. She is a registered counseling therapist and a Canadian certified counselor. In addition to supporting clients at ASPEI, Kristen supports individuals and couples in private practice in Charlottetown. Today, she is looking at how counseling therapy can help family caregivers and discuss a new counseling therapy program that is in development. Please join me in welcoming her today.
Okay, hello everyone. I am going to start off this little presentation with a quick grounding exercise that I like to do with clients. So I'm hoping that you're willing to participate in this with me. It's also sort of selfishly for me because my heart rate is absolutely through the roof right now. So great. So if I could invite you all to ensure that you're feeling comfortable in your seat, or if you're standing in a comfortable position. If you need to shuffle a little bit to get more comfortable, please do whatever you need to do. If it feels okay doing so, please close your eyes or just cast your gaze down to the table or your lap or your feet, whatever feels most comfortable for you. So we'll start by checking in a little bit with our emotions. How are you feeling right now? Any feeling is okay. Just sit with that feeling. Now shift your focus to the sensation of your feet on the floor or the support of the chair beneath you. I like to picture myself as a tree with deep, strong roots. Check your jaw. If it's tense, gently move it around or massage it. Now bring your attention to your shoulders. Raise them up to your ears and lower them back down, creating some space in between your shoulders and your ears, just really stretching it out. You can do a few slow circles also to help relax. Now, some of us hold tension in our stomach, so try to just let your stomach be, let it loose. You don't need to suck in right now. Okay. And with your eyes still closed or your gaze cast down, I will invite you to focus on your breath. So if you're comfortable, I'm going to count us through a few breaths, then let you do a couple rounds on your own. So at the bottom of your exhale, we'll inhale for 2, 3, 4. Exhale, 2, 3, 4. Inhale, 2, 3, 4. Exhale, 2, 3, 4, and continue with 2 more breaths on your own as it's comfortable. Whenever you're ready, please open your eyes and bring your attention back to the room. I hope that was as helpful for you as it was for me. So what is counseling therapy? So according to ChatGPT, counseling therapy is a professional supportive process where individuals work with a trained therapist to explore and address emotional, mental, or psychological challenges. It involves talking through issues, developing coping strategies, and promoting personal growth and well-being. Now, I do agree with pretty much everything that is said here, but therapists also do work with groups and families and couples as well. So if you ever experience any of the following feelings or emotions: loneliness, fear, guilt, stress, anger, resentment, depression, shame, uncertainty, frustration, grief, anxiety, or exhaustion. And these are some familiar coping mechanisms that you use. So over or under eating, avoidance, so really pushing your emotions down and not paying attention to them, trying to ignore them. Overworking, repression, procrastination, self-criticism. So speaking to yourself in a way that isn't very kind, like I should be able to do this, I'm not good enough. Aggression, substance use, isolation. Then therapy may be beneficial for you to help build resilience by developing healthier coping mechanisms and more acceptance of what is going on in your life. Now, there are some common misconceptions about therapy. So we'll go through a few of them right now. So therapy is only for people with serious mental health issues. Therapy is for anyone who is dealing with challenges, seeking personal growth or better coping strategies, or looking for support through life transitions. Some people would say talking to friends is the same as going to therapy. And while I would highly recommend talking to your friends about your struggles, therapists will be there with an unbiased point of view and professional guidance to help you. Therapy is a quick fix. So something that one of my colleagues always says to her clients is that therapy is not a drive-through service. So as much as I wish that I had a magic wand and I could help everyone cure them, so they wake up the next day and they're totally fine, that's not the case. There is a lot of work that needs to be put into it. Therapy is only for people who can't handle their problems. So it's very courageous to seek therapy, and it's for anyone who is looking to improve their mental health, well-being, or relationships. And finally, therapists just tell you what to do. So therapists don't always just give direct advice. They offer tools and insights to help you find your own solutions and coping strategies that will work best for you. So what is the evidence? So I'm just going to provide some quick rapid fire facts from different studies that show how counseling therapy can benefit caregivers, including some of the findings based on our colleagues at the Alzheimer Society of New Brunswick's counseling therapy program. So in 2020, there were about 7.8 million family or friend caregivers in Canada. 1/3 of senior caregivers of people living with dementia provide over 30 hours per week of care. So it really is a full-time job. And up to 75% of caregivers experience depression or anxiety. So the Alzheimer Society of New Brunswick launched a therapy program in 2021, and they used acceptance and commitment therapy, which Dr. Strong was talking about a little bit in her presentation this morning. And they use acceptance and commitment therapy, or ACT, as their primary modality. And we'll talk about that a little bit later as well. So 69 caregivers attended therapy in the first year of the program, most of who were over 50 years old, and they were a spouse of the person living with dementia. A study was later done with 30 participants and is currently awaiting peer review. However, I'll share some of the findings that they've outlined. So randomized participants received 6 to 8 sessions for 45 to 60 minutes per session every 2 to 3 weeks for 16 to 24 weeks. And the participants were able to choose 3 different methods. So they could do video, chat, text, or phone call sessions. Most participants reported being very satisfied, and 33% were mostly satisfied with ACT telecounseling. In addition, 75% of participants indicated they would definitely recommend ACT to a friend. So ACT is acceptance and commitment therapy, if I didn't say that. And some participant feedback included improvement in mental and physical health, increased empathy, and positive impacts on the person living with dementia. Some participants also reported missing the in-person connection, which is a great segue into ASPEI's therapy program, Thrive in Care, that we're currently developing. So in the spring, we received grant funding from the PEI Alliance for Mental Wellbeing to launch a caregiver therapy program. And this program will have 4 components, including individual therapy, group therapy, skills-based education, and social activities. Potential participants will be required to complete a screener called the Caregiver Wellbeing Index and 2 assessments, including the Caregiver Reaction Scale and the Rugged Resilience Measure. So these measures will be utilized throughout the client's participation in the program to measure the changes over time. In order to be eligible for our caregiver therapy program, you must be a First Link client. So that means you must be connected with the Alzheimer Society already, and you likely receive follow-up calls every 6 months or so from our support service coordinators. You must be 18 years of age or older. You must be a family member or friend caring for a person living with dementia, and you must reside in PEI. We'll also be offering virtual opportunities for sessions if need be. And then we'll have in-person sessions in Charlottetown and Summerside, and if there's more demand for it, up west and down east as well. And if there's a caregiver who wants to participate, but they can't attend in person or do virtual calls, we can chat and figure something out. So the therapeutic modality used will be acceptance and commitment therapy. Studies have shown its value in increasing resiliency and decreasing symptoms such as anxiety and depression. ACT focuses on helping the individual accept thoughts and feelings rather than repressing or avoiding them. It helps them commit to actions that are in line with their values. So think about if you're living in a way that is in line with the things that are important to you, and if you're behaving in a way that aligns with the person that you want to be. And it focuses on living fully in the present moment, just as we were doing with the mindful exercise at the beginning of this presentation. Finally, we will be soft launching the program on Tuesday, October 15th, just after Thanksgiving. So if you would like to learn more about our program, or if you're interested in going on the waitlist for the program, please either chat with your support services coordinator. You can email me or our general office, aka Bronwyn, at society@alzpei.ca. Thank you.
Wonderful. So I just want to take this opportunity as we move into a break to once again thank our panelists for presenting and sharing some of the research that's happening across Canada. So I'm very pleased to welcome and introduce Natasha Jacobs. Natasha's grandfather was diagnosed with dementia at the age of 62, and she was an essential advocate for her family during the stage of his life. Natasha has since gone to spend more than 10 years working with those who live with dementia, as well as their care partners. After her studies in gerontology, Natasha became a transition worker and a family counselor, providing support from diagnosis through to admission into long-term care and beyond. Natasha lives in Cobourg, Ontario, with her husband Jermaine and their children Jordan and Isaiah. She is also the manager of strategic partnerships at the Alzheimer Society of Canada, where she coordinates and works with the National Advisory Group of people with lived experience of dementia. Please join me in welcoming her today.
Good afternoon. Good afternoon, everyone. Can you see me? Oh, I'm I think a little higher than I thought I was going to be, so that's great. I know, have you ever heard of body dysmorphia? I have like height dysmorphia. I think I'm like 6', I'm really like 5'2". Awesome, thank you so much. So as we are in the final presentation, my brain is also feeling a little bit mushy, and I'm also kind of an introvert, so please bear with me as I go through my notes. It is such an honor to be here today. Thank you to ASPEI, to Jaime, for this opportunity to speak to you about a topic that is very, very close to my heart, caring across cultures, inclusive and compassionate patient care. I would say Jaime hinted to it a little earlier, that the reason it is so special to me is that I lived through my grandfather's diagnosis as a young girl. And my family had a really hard time with his diagnosis, and at times really refused to talk about it. So I found myself being the only one willing to discuss it at about 10 and 11 years old. So here's me and my grandpa. His name is Linus. And yes, that's me at about 1 year old. I know that Jaime said I've been in the business for 10 years, but I think it's more like 20. And it really resonated earlier when one of the presenters was talking about really getting into people's story. My grandfather's story is that he was a mechanic for all appliances in Guyana. and he immigrated to Canada, I want to say in the 60s, with my father and 3 of his siblings and my grandmother. When they came to Canada, they moved to Scarborough, Ontario. And then eventually we all to Cobourg, Ontario. But while each family moved to Cobourg, Ontario, we moved in with them as our homes were being built. So every single one of us moved on the same street, and we all moved into their home for a bit of a transition. But when it was our turn to move into their house, which we were the last family to move in, he was starting to show signs of dementia. So as mentioned, he was about 62. He would be sitting in the room with us watching TV rather than with the adults having conversation in the other room. When we were banished from the adult conversation, kind of seemed like he was too. He'd come home. And he would do really silly things with us, stick his teeth out, come back in, kind of like make jokes with us. And unfortunately, all I really knew of him was dementia. And all I really knew of him were those sort of silly, in my mind, behaviors. One of the things that I started to do was ask my grandmother real serious questions at 9 years old. Why is he behaving that way? Why is he talking like that when everybody else is serious? Why is he being silly? And often I was met with, don't worry about that. You're too young to talk about that. We don't need to talk about that. It's gonna be okay. He's fine. That's Grandpa's issue. And pretty soon after that, I realized that Grandpa's issue was not something our family discussed. We just dealt with it. So fast forward a little bit, we used to sleep over at my grandmother's house to help her bathe my grandfather. We used to sleep over to help her cook for him. And my entire family just rallied around my grandmother to make sure that my grandfather was taken care of. We never asked for help when help was like at a timely manner. Even when I would advocate for help, we weren't to talk about it. No one was coming in to help. My grandmother could do it. My grandmother was probably 80 pounds soaking wet. So it became kind of dangerous when he started to wander in the evenings. And they had a very steep set of stairs. So we would sleep over to make sure that when he got up at night, we could walk him to the washroom. And keeping in mind, I'm probably 14 at this point, and I'm sleeping over, walking my grandfather in the middle of the night, just so that we didn't have care come into her home and really understand what was going on. Eventually, my grandfather had a stroke and was admitted into long-term care. Before all of this, my grandmother still would not really admit that he had dementia. But now that he had a stroke and it was physical, she was able to admit it because it was something physical, nothing mentally was wrong with him, but it must have been the stroke. Must have been the stroke all along. Maybe he had the TIA earlier that made it behave this way, but it wasn't dementia, right? And so it was only until he was in long-term care that we started to talk about it. So I began this journey to help families navigate the dementia space openly, safely, and without bias. I saw my grandmother shy away from help outside of our family, and I watched as she would cook his meals and walk them to the long-term care home just to make sure that he had cultural dishes that he loved. I watched as she took on far too much in order to not ask for too much. I have worked in long-term care, day programs as a family counselor specializing in dementia-related subjects. So I've seen this happen time and time again with different cultural groups. And before we delve into those cultural aspects, let's briefly just discuss dementia itself. As we talked about earlier, dementia is not a single disease, but a term that encompasses various cognitive impairments that interfere with daily life. It affects memory, thinking, and behavior. There are, of course, different types of dementia, and the progression of dementia can be challenging, not only to those diagnosed, but to their caregivers and family members. The Alzheimer Society of Canada undertook putting together the landmark study. It is a micro simulation project, and it projects the number of people who will develop dementia over the next 30 years in Canada. This is a graph from that study. And while about 1.6 while about 1.6% of the Canadian population in 2020 had dementia, this number is expected to increase to 3.6 by 2050. Over this 30-year period, over 6.3 million individuals will develop dementia. And by 2050, the number of people living with dementia will almost triple, and over 1.7 million Canadians be living with dementia. Canada is considered one of the most multicultural countries in the world. And in the 2016 Canadian census, over 250 ethnic origins were recorded as part of the Canadian demographic landscape. This diversity is now widely considered a fundamental Canadian value. It is largely a result of several waves of immigration over the last 50 years, which my family was a part of. With an aging population in Canada, we are now witnessing a rapidly growing number of older adults from a wide range of ethnic and racial backgrounds. With age as the strongest risk, this diversity in older Canadians is also reflected within the populations of people living with dementia in Canada. Over the next 30 years, we can expect even further changes to the ethnic and racial makeup of people that are living with dementia in Canada. So consequently, care services for people living with dementia need to be designed to meet the diverse needs of these populations. Canada's National Dementia Strategy emphasizes the need for increased understanding and expanded data of health-related issues in ethnic and cultural minority communities in order to assist efforts in dementia risk reduction. So this really made me think of the conversation that we were having earlier with Dr. Stultz, I believe his name is, and he was talking about really talking to individuals to understand their story. And it really kind of tied in with this conversation in that though people have stories of what they once did in their previous life and what their family makeup is and those parts of their story. Am I not in there? Sorry. There we go. Also, their culture is a really big part of people's lives. And I think that as people are giving care and you get to know somebody individually, and understand their cultural beliefs, it can help diminish some negative behaviors. It can help people feel a little more comfortable. Just hold on, I'll send it. No problem. In care. So sometimes there's resistance to care when folks feel uncomfortable, obviously. What is cultural competency? Cultural competency is compatible behaviors, attitudes, and policies incorporated into a system, agency, or profession that facilitates effective understanding in cross situations. So a person's or group's culture refers to the patterns of behaviors that have become integrated into their daily life and worldview, such as language, thought patterns, customs, beliefs, values, and institutions associated with ethnic, racial, religious, and social groups. So to be considered competent, an individual, group, or organization must have the ability to function with efficiency within those contexts of behaviors and the needs of your patient or their communities. You know, I often get the question, how can we do that within our line of work? I worked in many long-term care homes. So one of the long-term care homes that I worked in was specifically for Italian Canadians or Italians. I had to take Italian lessons. So part of my shift, at the last half hour of my shift, I would go to Italian lessons and learn basic words that would accompany me in care for those people. And a lot of folks would say, wow, like we don't have time for that. We're PSW, we have to get through our day. We only have so many clients. It's systemic. It needs to be added to the values of your workplace. This, as much as getting to know somebody's behaviors because of whatever reasons, as much as getting to know how to bathe somebody or how to feed somebody, getting to know someone's cultural preferences or cultural background is also very, very important and can really assist in behaviors. So as part of the landmark study, I had the honor of conducting a few interviews, and this gentleman, one of the quotes that he had is, "When you eat your country's food, it's very sustaining." I knew an Inuit who would need that food, and that's why I really fought for them to have it. For the culturally appropriate room, so he was a part of putting together a cultural appropriate room. A manager and I went to an Inuit art shop in Ottawa, Street, and we bought Inuit drums so the elders could hear Inuit drums and dancing. So pretty simple remedy. If those folks there would like to come in and join, or anyone else, it was something that they could do, and he was part of putting that together. So the remedy can begin with such simple steps, such as including language awareness into staff training schedules, like I was talking about. You could learn just simple words that each of your client may know, and that might help in the conversation. The gentleman earlier also talked about how he made connections with his clients. So again, I've heard it all throughout while I've been here. PEI feels like a province that is also a small town somehow, right? And so all of a sudden, while I've been sitting just even at lunch, I've heard people say, like, and where are you from? And where did you go to school? What are you taking? And trying to find connections. Do you know so-and-so and this street? It's the same in these situations, to try and find a connect, even if you visited where they've been from, or if you knew somebody who spoke their languages, these are the connections that you can make. You can think about a time when you felt out of place or not in your comfort zone. And to some of these patients, they are living in that discomfort each day, and at times unable to express it effectively, and ultimately leading to sometimes negative outcomes. Indigenous understandings of age-related dementia. There are also people that now live longer. Obviously, we know the history in the Indigenous community, and many of their elders did not make it to a long life. So now all these elders who are now living longer are starting to have age-related dementias. There are some evidence that suggests that these dementias have only recently become more common. In some of these cultures, the elders are quite revered and their stories and wisdom are valued. This respect can lead to a more holistic approach to care, emphasizing community involvement and familial support. As people live longer, they are more likely to experience dementia, just as Indigenous communities in Canada are different. Indigenous peoples in their communities and cultures, different understanding of dementia, memory loss, and forgetfulness. Some of these understandings may be different from those held by doctors, nurses, or support workers. Some descriptions of dementia that are commonly held are that it's normal, or that it is a natural part of aging. It's a part of the circle of life, or coming full circle. Dementia may also be described as having a second childhood, or a time where one is closer to the creator. And this is Kurt. Kurt is from Trinidad, and we had the great honor of getting to know Kurt and his wife. And some of the struggles that Kurt had was that he's from Trinidad, and his wife has told us that she thinks race has always been a factor in his journey of living in this country. He found that there was always racism towards him. He didn't quite fit the status quo, especially in Vancouver, where since the destruction of Hogan's Alley, which was a predominantly Black neighborhood, he always stood out. And he had an accent, so people would always ask him to repeat what he was saying. Fear, shame, and stigma associated with mental illness and dementia are barriers to help seeking in the Black community, as well as factors that contribute to Black populations accessing services in later stages of cognitive impairment. One of the things that Kurt experienced was that he was quite young. I think he was in his late 50s when he started to notice changes. And when he went to the doctor kept pushing his wife to say that he was aggressive. He was not in any way, shape, or form, but the doctor kept asking questions like that. So almost leading the conversation that way. And in the end, when she got back her report of what she had talked about, somehow it was in the report that he was quite aggressive towards her. He then, the course of action was mental institution. And he lived in that institution for 3 years on very heavy medication to keep him subdued from his aggression. She fought very hard to say that that was not her story, but it is a very dark story for them, a very hurtful story. And in the end, he did get a diagnosis of early onset dementia. He is home, he is off medication and thriving. But such denial is frequently influenced by societal prejudices surrounding dementia. The stigma can be exacerbated by feelings of fear and sadness for those who are. Food, faith, and fellowship are really big parts of some Black Canadian experiences. So this should be considered when creating activity schedules or care plans and menus. One thing that we noticed when my family was going through my grandfather's journey was in the long-term care facility that he was at, there wasn't a place that could hold all 20 of us. And all 20 of us wanted to go every Sunday and see him and have a meal with him. He couldn't come home easily, so we ended up having to sort of break up that visit. But one of the other things was my grandmother wanted lots of people on his care plan. And that it's not set up for that, set up to have a conversation with just her, or like maybe just her and my dad, when I was more of an advocate. But because I was a little bit younger, they didn't want to speak to me. Just lots of the things that we take for granted in that process that would have helped us greatly. Older Chinese adults prioritize happiness as the most important aspect of healthy aging. Healthy aging for them involves experiencing positive emotions, pursuing an active lifestyle, and maintaining sound health, strong social networks, and financial independence. Perceptions of dementia vary within the Chinese community, and some believe that memory problems are associated with dementia are, again, a normal part of aging process, and they may refrain from seeking any medical assistance. For others, dementia is interpreted through a supernatural lens and is considered a mental illness, and mental illness is highly stigmatized in the Chinese community. I don't know this word, I tried it on the plane. Confucianism advocates for a filial piety, which emphasizes that children should obey, respect, and devote themselves to their aging parents by providing care. So this also is a cultural obligation to provide the care for older adults, and their duty traditionally falls to the eldest son, but is increasingly being assumed by female children in North America. So, what does it take? What does it take to function with effective cultural competency within the healthcare system? Effective communication with all patients, regardless of native language, through access to professional language services. Define values and principles that facilitate working cross-culturally through demonstrated behaviors, attitudes, and structures, as well as policies for all those served. And the ability to value diversity, conduct self-analysis and assessment, manage dynamics of diversity, acquire and integrate cultural knowledge, and accommodate the cultural context and diversity of the community that is being served. Here is a pilot program that is being done in Toronto. And this, as you can see, is a nurse practitioner or those who are doing some intake, and they are utilizing Zoom conversation for translation services. There is a service called Translation 911. It basically does the same. You can call them with a lot of languages. I couldn't tell you exactly how many, but we have used it before over the phone, but you can also have video conferences. I would suggest doing this even in just intake so that you can understand what your client may need and some language words that you could speak to them to comfort them in cases of upset. Addressing the language barrier is crucial in accurately diagnosing and treating individuals with dementia, as effective communication is key to understanding their symptoms and needs. Understanding and respecting different cultural perspectives on dementia can enhance the quality of care provided, fostering trust and cooperation between caregivers and patients. Thank you so much.
So thank you so much, Natasha. One of these days, they're gonna make a mic stand that doesn't float down. And maybe it'll go on Dragon's Den, I don't know. I'll hold this one. So we'd love to take some questions for you, Natasha. We know that, you know, more and more, we're seeing individuals from different cultural backgrounds, even here in PEI, who are going to be living with dementia. They're going to be cared for within our system. They're going to be in our healthcare system. They already are. And it's going to be important for us to have these types of sensitivities and have strategies to be able to connect, to maintain the relationship. If they revert to their language of origin, wouldn't it be wonderful to be able to support them there, where they're still potentially quite fluent. So I really enjoyed this presentation and the suggestions, and I'm happy to take questions or comments from the crowd if you would like. I think Hannah's got the mic there, and we're happy to take some online as well. There's always an opportunity to ask us questions, and we can relay them to Natasha later as well, even if you don't have them right now. So again, I just want to thank you so much, Natasha.
Excited to introduce our next speaker, Carol Reed. Carol is a retired nurse who is certified in geriatric nursing and has an impressive 38 years of clinical practice. Much of her career has been dedicated to long-term care and palliative care. In addition to her professional experience, Carol brings a deeply personal perspective to caregiving. Carol's mother was diagnosed with vascular dementia at the age of 88, and after living with vascular dementia for 7 years, she passed away in March 2018. More recently, in July 2020, Carol's life partner was diagnosed with frontal lobe dementia and Alzheimer's. Carol cared for him at home before he was moved into a long-term care facility. Her personal experience has given her remarkable insight, and she has a passion for supporting families navigating a similar journey. Carol recently shared her expertise on anticipatory grief in a podcast produced by the When You Die organization, where she offered practical advice and a compassionate voice. As Carol so wisely reminds us, remember, the person living with dementia is not giving you a hard time. The person living with dementia is having a hard time. It is my great pleasure to welcome Carol Reed to share her knowledge and experience with us today. Please join me in welcoming Carol.
Thank you for the lovely welcome, and welcome everybody. I hope you enjoyed the day. The conference, it had lots of interesting topics and stuff. I learned a lot of things from my mother, and one of the most valuable lessons I learned was being prepared, because you never know what is in the future for you. So when she was in her mid-70s, she sat me down and she said, Carol, I have a plan, and I want to share it with you because you're the most important player in this whole scenario. And she came out with this binder full of information from healthcare directive to power of attorney. She had an updated will. She had all her banking information and her investments, everything all in one little binder. And she said, should anything happen to me, I want you to take care of this. And here it is, all for you. So it alleviated a lot of stress and anxiety that a person goes through, because a lot of people don't have that advanced care planning. And this was recommended to her by her family physician. So it was a wonderful to have that all in place. So back about 5 years ago, I did a palliative care presentation, and in it for a seniors group, and in it I had a section on advanced care planning. So I think it's a very important subject, and I think it's important that we all do that, have a plan. So I'll get started here. So this was a really good quote by Dr. Ira Byock, and it says, I have a healthcare directive, not because I have serious illness, but because I have family. So imagine that without warning, you're in a serious car crash. You're in a hospital in an intensive care unit. You're no longer able to communicate with anyone. Your heartbeat and breathing, it can only be continued with artificial life support. Despite the best medical treatment, your physicians believe it is unlikely you will return to your previous quality of life. You have a progressive chronic illness. your healthcare team has told you that you may lose your ability to swallow and breathe on your own. Both scary scenarios. Sorry. So why talk about advanced care planning? Our population is aging. While Canadians are living longer, 100% of us will die. It's true. We don't like to think about it, but it is fact. Most Canadians die of chronic illness, and they live with these illnesses for many years before death. Healthcare decisions can be complex and may be easier to think about ahead of time. Maybe, it definitely is. Good to have a plan. 8 out of 10 Canadians have never heard of advanced care planning, which is scary. Now, these were statistics from about 5 years ago. So hopefully it's improved somewhat since then. Advanced care planning can ease the burden on loved ones as they have a better sense of what decisions you would make in a specific situation. So my mother had clearly stated what she wanted, as does my life partner. He's clearly stated what he wants to the best of his ability. He wanted made, but he was already deemed incompetent when he had the assessment done, which is very unfortunate because now he's living the life he didn't want to live. But he's well looked after, and we're very pleased for that. If you have expressed your wishes in advance, you're much more likely to have your wishes known and followed. You may not agree with what your loved one wishes for, but it's not about you, it's about them. Your family members will have less stress and anxiety because they know your wishes, and that's so true. You'll be more satisfied with your care, as will your family and substitute decision makers or proxies. You'll have better quality of life and death. You will have a better chance of care and death at the location of your choice. If it's possible, lots of people would choose to die at home. And that, isn't always possible due to the level of care they have, but we try to make everything happen as best we can. You may hope that you will be able to communicate until the very end, but in most cases, it doesn't occur that way. So you may hope, and not everybody will die with chronic illness, or in the most cases they do. Who needs an advanced care plan? Everyone. You never know when you may face an unexpected event or illness and will be unable to make your wishes known. Important words: healthcare directive, substitute decision maker, and proxy. The healthcare directive is a legally binding document in which you write your instructions about the kind of care and treatment you would accept, or refuse if you were unable to communicate this for yourself. It's your voice. And you also name the persons known as proxy who will make the decisions for you. It'll be a family member, any other loved one, your best friend. It would be somebody that you trust will make things happen the way you wish. Substitute decision maker is a person who makes care and treatment decisions on your behalf if and when you become incapable of making these decisions for yourself in the absence of a written healthcare directive. So we covered here. The proxies: if the person has a healthcare directive, you choose who your proxy will be and your substitute decision maker. But if something happens to you and you don't have one, then there's a hierarchy of people who would be in line to speak on your behalf. So it's the guardian, the spouse, and it goes down the line, depending if you didn't have a spouse or you didn't have any sons or daughters, they would assume the responsibility for making your decision. So it's easier to write it down and have your own wishes known. Proxy is the person or persons appointed, and it's always recommended that you have a second proxy chosen on your healthcare directive as well, because should the first proxy be incompetent or unable to complete the task, There is a website, government PEI website, Consent to Treatment and Healthcare Directives Act, and it explains all the details on the act for that. Your proxy must be at least 16 years of age or older, capable, knowledgeable about your situation, and must have a recent contact with you and is someone you trust to make decisions. The difference between a substitute decision maker and a proxy: in PEI, every person automatically has the substitute decision maker. So as listed up before, like it would go through that hierarchy list. But it'll be the person who makes the decisions for you if you lose the capacity to make these decisions. But if you have a signed healthcare directive, it's your own personal document. You should keep an original copy in a safe place. Your proxy should have a copy as well as your doctor. So they often recommend, there's a lot of seniors who live alone and they do have some healthcare issues, and they recommend like putting it in your freezer. And then if you have to call the ambulance, they come out and they know, like if you're on the call list for assistance or through home care, whatever, they know that that healthcare directive is in the freezer. You let them know, make everybody aware. Take a copy when you travel. If you're admitted to a hospital or long-term care, it is considered a legally binding document and may be written without assistance of a lawyer. Must be dated and signed by you. Your proxies also need to sign and date, and of course they need to be aware that they're your proxy. That is always helpful. And they do have advanced care planning wallet cards, so they're always good to carry with your healthcare PEI health card. And if you update, so it is recommended that you update it on an annual basis, make sure it's still everything you want and still all your wishes. Your will, your power of attorney, and your healthcare directive. Most lawyers now will, if you're updating your will, they will do a healthcare directive, and when you do your power of attorney all at the same time. So good to have all those in place. So this is just about the legislation that I told you about. It's on the government of PEI, and you just put in about the Act, Care and Consent for Treatment Act. Is power of attorney the same as the proxy? No. Power of attorney on PEI can make financial decisions only. For example, your banking, pardon me. And but the power of attorney and the substitute decision maker can be the same person if that's what you have documented. And so for my mother and for Jim, I'm the power of attorney, was power of attorney and the substitute decision maker. And we had a backup plan. There's always a second person on there. Advanced care planning means having a discussion with family and friends and your healthcare team. Is it awkward? Maybe. Important? Definitely. I think it's becoming less and less awkward as time goes by, but it's definitely a difficult conversation, but much needed. So 5 steps to advanced care planning. You think about what is right for you. You learn about information relevant to your current health. Decide who you will speak on your behalf. Talk with your substitute decision maker, your loved ones, and your healthcare providers. Record your values and wishes. Review and revise, as I mentioned, annually. And of course, if there's any life changes like births, deaths, marriages, transitions, or moves, they all have to be reviewed. Your important information has to be reviewed. Any changes in your health status, you may change your mind. It's your responsibility to destroy any copies of old healthcare directives. And these are the Health PEI websites for advanced care planning. So they have a website that you can print off. And this is what my partner did. Healthcare directive, and they have it, you can print it right off, It comes with instructions on how to fill it out and all the things you need. So when Jim went for to have his medical assistance and dying assessment, he had a healthcare directive. So the doctor took a look at it and she said, that's perfect, because he had everything written in detail, like what he did not want if he was unable to get made. So I was very thankful for that. Sometimes it's very hard to, especially when they live in long-term care, because there are things they do need. They need their vaccinations and they need their flu vaccination, because it's not only for them, it's protecting all the other people and the staff and stuff. So even though if he could talk, he would, I don't want anything. I don't want blood work. I don't want urine specimens. I don't want anything, but it's not always easy to carry that out. So we do the best we can. We have to draw the line somewhere, and there's that gray area. So these are all the websites, but they are all on the government sites, healthpei.ca, and you just Google in everything that you want, what you're looking for: advanced care directive, the act, power of attorney. But like I said, the last time we had our will updated, I had to do it after Jim got sick, and we had to change everything. So the lawyer just automatically came with the healthcare directive. That's kind of a standardized form, and you just tick off the boxes what you need, and of course the power of attorney and stuff. So what I did was the same thing as my mother. I have this little folder, and it's got labels. It's everything that, should anything happen to me, I have no children. So I have a couple of nieces who will make sure my healthcare directive is adhered to. And I have all my banking information, any investments, my deed and property taxes, maritime electric, any cable and internet bill, cell phone, car and apartment insurance, my MasterCard, pension statement information, health insurance, medication list, medication history, all my contacts, password, birth certificate, social insurance number, passport, and power of attorney and will. And I keep it all. I took everything out of it, but this is just for teaching purposes, but just in case I lost something while I was here. And my niece knows where it is. I keep it in a strong box in my house. So if there was ever an emergency and I had to go, that strong box is ready to grab from its secret place, and out I go. So it's very, very important, because it's kind of scary when you have to make all those decisions and take care of everything all by yourself. My brother's wife died in 2020, and she had a will and she had a power of attorney, and I assisted my brother in executing her will and stuff. But we could not find a password. She had bank accounts we didn't know about, and we are still today, 4 years later, working to settle that estate. So it doesn't make for an easy road ahead. And that's everything. Thank you all.
Thank you so much, Carol, for that insightful and informative presentation. Your expertise and passion on the topic have truly made an impact, and I know everyone in the audience has gained valuable knowledge from your talk. We appreciate the time and effort you put into sharing your experience with us today, and your contribution to this conference has helped shed light on important issues related to legal affairs and healthcare directives, and we're grateful for your thoughtful approach. On behalf of everyone here, thank you again for being part of this event and for your continued dedication. We're going to hold questions just until the end of the panel, and if time permits. So I'm excited to introduce the next speakers of the day, two outstanding professionals who will guide us through a very important topic, the transition to long-term care. Hannah is a registered social worker with a Bachelor's of Arts from the University of Prince Edward Island and a Bachelor's of Social Work from Lakehead University. Since 2019, Hannah has practicing social work, starting her career in child and family services, and she has been with home care since 2021 in the role of a long-term care coordinator. Hannah lives in Central PEI and is married and is a proud mother to a beautiful daughter with another baby on the way. Outside of work, she enjoys spending time with family, including her golden doodle and friends. Tammy holds a Bachelor of Science from Mount Allison University and a Bachelor's of Social Work from St. Thomas University. Tammy is a registered social worker with over 2 decades of experience working in Western PEI. Her career spans a variety of settings, including community, primary care, and acute care. For more than 15 years, Tammy has focused on home care and currently serves as a long-term care coordinator. She lives in Western PEI, is married, and is a devoted mother to 2 wonderful daughters. Both Hannah and Tammy bring a wealth of knowledge and experience to today's discussion, and we're fortunate to have them here to share their insights. Please join me in welcoming Hannah and Tammy.
All right, so hi everyone. So my name's Hannah, and Tammy's just going to sit over there until it's her time to chat. So as introduced, we are 2 of the we work out of Prince County, and we're 2 of the long-term care coordinators out of 6 across the province. So just to start off, to talk about the different care facility options in PEI, as sometimes people have questions between the difference between community care and long-term care. So the 2 main are community care and long-term care. So it's where a person chooses to live depending on their personal needs and care requirements. So to kind of break that down a bit more, so with community care facilities, that's where an individual requires light care, assistance with meals, bathing, medication, laundry, general basic support for everyday living. Admission to community care is managed by each individual facility. So for long-term care, when an individual requires a higher level of care with nursing supervision, and admission to long-term care is managed through the provincial home care program. So what care facilities exist in PEI? So there are more than 50 care facilities in PEI. Presently, there's 36 community care facilities, 9 public long-term care homes, and 10 private nursing homes that have met the inspection standards and have been granted the operating license. These facilities are distributed tip to tip from Tignish to Surrey so that islanders can receive the care close to their family and friends. So what is long-term care? So long-term care provides specialized nursing and personal care services to individuals who can no longer live on their own with family or home care support. These services are provided while respecting each resident's dignity and personal choices. So services are provided in both public and private long-term care nursing homes that include 24-hour nursing care, the room and board, personal care, and medical services. So how do I know if I need to go to a long-term care home? So everyone's situation is different. Some people enter long-term care because they may be requiring more care than what home care can provide. Family members can no longer meet their care needs, or their healthcare needs have increased, requiring additional services such as daily nursing care. Is there an age requirement for entry into long-term care home? So you're eligible to move into a nursing home if you are 65 years age or older and have been assessed as needing nursing level of care. If you're under 65 years of age, you may be considered for eligibility if you have been assessed as needing nursing level of care and no other reasonable alternatives exist. So a lot of people wonder, how do you apply for long-term care? So applying for long-term care would be through Health PEI, the provincial home care is responsible for managing all the admissions to long-term care homes in PEI. So if you or your family are needing long-term care, you should contact your local home care office. A coordinator will speak with you about your situation. Your care needs will be evaluated through a standardized health assessment for review. The assessment will be used to determine if you need nursing care to continue to meet your basic daily healthcare requirements. So once you've been assessed as needing nursing care, you may be eligible for admission. If you're a resident of PEI, you have a valid PEI health card, have Canadian citizenship or a landed immigrant, so a non-Canadian who has established residency in Canada or who holds the visa entitling the permanent residency in Canada, or you're present in PEI for 6 months or more. So note, an individual who does not meet the above criteria could also apply for admission to long-term care home and request consideration for admission on an exceptional status basis from the Director of Long-Term Care. So if you meet the eligibility criteria for long-term care, you'll be assigned a home care coordinator, and that home care coordinator will arrange for a long-term care admissions application form to be signed with you. Your care coordinator will work with you and your family to develop a care plan to help support you and your family while you wait at home for long-term care placement. If you do not meet the eligibility criteria for long-term care, you may still be assigned a home care coordinator who will work with you and your family to provide other options for support at home. So are there other services that can be offered to me? So with home care, we can provide assessment for other services that may provide support to you and your family while you're still at home. There are many services that you may be able to access through home care. So just to list some of them, we have our home support service that would assist with personal cares or in-home respite. We have facility-based respite that would be in like a nursing home setting. We have our home care nursing services. We have our palliative care program. We have rehab services with occupational therapy, physiotherapy, rehab assistant. We have respiratory therapy, a pharmacy, dietitian, adult day program, social work, mobile integrated health, the caregiver benefit program, the self-managed care program, medications assistance program, and the incontinence program. So lots of different things that we can do at home care to support you. And also not listed there is our coach program that works with geriatrics. So we have lots that we can offer. So in addition to provincial home care programs and services, there are many other services that can help provide family support if they're choosing to stay at home. So there are many different resources, and this is just naming a few. So we have like Lifeline, Life Alert, Living Well Companion, different security kind of setups, cameras, alarms, if you feel that's needed for your loved one. We have a private hire list for home care, for personal cares. So for housekeeping or errands, where the family is kind of responsible to review that list and pick who may be a good fit for their situation. There's Meals on Wheels, Real Meals, the Seniors Independence Program, Seniors at Home Renovation Program, Senior Safe at Home Program, the Veterans Independence Program. We have the Alzheimer Society, as we know we're here today. They offer many great supports. Just to name a few would be the Caregiver Support Group and Volunteer Companion Program. There's the Transfer Service for Pat and the Elephant, Transportation West, Wheelchair Accessible Taxi Services Companies. We have senior mental health team supports, grocery deliveries from local stores to your door. There's the Senior Navigator, and then there's the 211 number that you can call, and they will kind of give you information within your own community, what kind of services you can access. So that may be good to reach out to. And I'll pass it over to Tammy.
All right. And so just to reintroduce myself, I'm Tammy Dean. I work mainly out of Prince County with Hannah, and I'm just going to continue with our presentation here, just mainly in the question and answer format that we've set up. We often get asked, can I choose where I want to live? And the answer is yes. You can choose where you want to live as long as it's able to meet your specific care needs. Your home care coordinator will discuss long-term care options with you and your family. And you may request to be on the list for up to 3 different facilities. And that's part of the application form or your list of facilities of choice. Your choices are given equal priority when we offer you a chance to move into like a nursing home. So it is important that you choose only those homes you wish to move into. So once you provide us with your list of facilities, your name will be placed on the wait list according to the date you are approved for long-term care. And I'm not sure how to go. Thank you. So we get asked, what should I keep in mind when selecting a home? So it's important that you put your name only on the wait list for homes where you are sure you want to live. And I'm stressing that because we often get applications with facilities listed where people they're just going to put through some names on a list. They haven't really thought about making solid choices. So you and your family members should consider visiting some homes when making selections. When choosing a long-term care home, keep the following points in mind. Is the location of the home convenient for friends and family to visit, as we're sure you want to have company and visitors? Does the home offer activities and services you enjoy? And does the home offer the type of accommodation you prefer at a price you can afford? And we do suggest that you contact the long-term care home before you go to see if they would provide a tour. It's just a courtesy to the homes. Probably our most frequently asked question, besides how do I get on the list, is how long are the wait lists? So wait times can vary from several weeks to several months or longer and depend on the number of people on the wait list and how quickly a suitable vacancy becomes available. So if you live at home and your situation worsens while you're on the wait list, because sometimes it takes a while to get an offer, we would ask that you contact your home care coordinator, because your care coordinator may be able to arrange for other services, such as additional home care or respite care, for example. We get asked, how is a long-term care wait list managed? So the coordinators, which is us, we follow a long-term care bed management policy to determine admissions to long-term care facilities. In general, you wait by the date you are approved for long-term care. However, there are times when individuals may be assigned priority. Examples of this include when we have hospitals in overcapacity, someone may be in crisis in the community, veterans, francophone, first available bed transfers, and interfacility transfers. How long will I have to wait for a long-term care admission if I want to live in the same home as my family member? When you meet with your home care coordinator, a determination will be made whether you require long-term care and if your care needs can be met in the same facility as your family member. Efforts are made to place close family members who both require nursing level of care in the same facility as soon as possible. We get asked about it in hospital because we do have people that end up in hospital and end up waiting for long-term care in hospital. And we do make every effort to place you in your home of your choice. However, when a suitable bed is not available in your chosen home, you will be asked to move to the first available bed. And when a suitable bed becomes available in one of your selected homes, you will have the option to transfer there. If you decline the offer to move to a nursing home, when you're in hospital, the hospital may discharge you. So we're going to talk about paying for long-term care because that's an often question we hear a lot. And do I have to pay? So long-term care costs are shared by you, the resident, and the provincial government. You pay your accommodation cost and personal expenses, and Health PEI pays your healthcare cost. The Department of Health and Wellness sets standard accommodation charges annually. Those who can pay the standard accommodation charge are not required to complete a financial assessment. They just pay the bill. Those who cannot pay the standard accommodation charge can apply to have their rate reduced through an income-based financial assessment. So the daily cost for accommodation in public long-term care homes and for subsidized residents in private homes is $114.67 per day. Other rates may apply in private homes, depending on the type of room you request and ability to pay. So if you have a net annual income of less than $43,500, you may qualify for a government subsidy to help pay for your accommodation in the nursing home. Private nursing homes have various rates for their accommodation charges, unless a resident has qualified for a government accommodation subsidy. So how do I apply for a subsidy? So if you'd like to apply for a government subsidy, your home care long-term care coordinator will send a copy of your long-term care application form. So when you actually complete your application form, there's a section on there that would ask if you would like to apply for a subsidy, if you'd like to include your spouse's income in the subsidy. So if you check that, and if you can give consent to your coordinator, we forward the application, a copy of it with your request to subsidy to the long-term care subsidization program. And when they receive it, they assign a worker, a financial worker, and they'll work with you to determine if you're eligible for assistance. So at the time of signing the application, we often provide families with the number, and the number's on the screen for the long-term care subsidization program, a toll-free number, 1-888-365-5313. We get asked sometimes, can I be forced to move into a long-term care facility? Could I say no? So you cannot be forced to go into a long-term care facility against your will, as long as you're mentally competent. It's a choice you make, like where you live. If you're mentally competent, you cannot be forced to undergo an assessment against your wishes. If you've been declared mentally incompetent by your health practitioner, then the proxy you've named in your healthcare directive will make decisions for you. If you've not named a proxy, the health practitioner will name a substitute decision maker for you from the list provided in the Consent to Treatment and Healthcare Directives Act, as Carol had mentioned earlier. So if I'm managing at home with my supports in place, am I able to refuse a bed offer to long-term care when the offer is made? And how does this affect my waitlist status? So you do have the option to say no if you're not ready to accept the offer. You can discuss the reason with your home care coordinator. You may decide that you'd like to remove your name from the wait list, and that's okay. You can come off the list, or you may decide to leave your name on the wait list and wait for a future offer. Get asked about transfers. So if you're living in one facility and you'd like to move to another, if that happens, so you're a resident of one long-term care facility, decide to transfer to a different one, you contact the home care office about placing your name on what we call the long-term care transfer wait list. And a home care staff will contact you to discuss the facility of choice for your transfer. And what information is shared by my healthcare team with long-term care? So when you are offered and accepted a room in a nursing home, a long-term care admission package is prepared to be forwarded to the facility prior to your move-in date. This information and package includes a copy of your long-term care application, your most recent home care assessments. Your physician will complete a medical data form. We send along your updated medication list, any consults or specialist reports we have, your current care plan, and so on. This information is very helpful to ensure that your care needs are shared with the long-term care facility. And this helps provide a smooth transition from the community or hospital to your new home. And then we have a slide just saying how to contact us at home care. So we have offices across PEI, tip to tip, in one in every county, in Surrey and Montague, Charlottetown, Summerside, and O'Leary. And I know we're going to move into questions, but if you have something very specific to your own situation and you do have a care coordinator, we'd ask that you kind of redirect that back to the local office. But if you're new to home care and are interested in some of our services, please feel free to reach out. And that concludes our presentation on transitioning to long-term care. Thank you.
So thank you so much, Hannah and Tammy, for your presentation. Your insights on the transition to long-term care have been invaluable, and I'm sure everyone here has gained a deeper understanding on how to navigate this important stage. So we will open up for about 5 minutes for questions. And please, if you have questions, let us know who your questions are directed towards, whether it's Tammy or Hannah, or if you have questions for Carol. So for the folks online, I'm just going to repeat the question. The question in the room was, if somebody is in community care, but now they're needing additional care and they're needing to move to long-term care, what does that transition look like?
That's a good question. Thank you. So often we work very closely with our community care facilities, so we're well aware. So when they have made an assessment, they do their own assessments internally, and they will forward a request to home care to kind of look at whether they're appropriate for a further home care assessment and look at the needs for nursing care, level of care. And then that's when usually Hannah and I or our colleagues get involved, right, to look at the transition from community care to long-term care. In general, most community care facilities try to manage the care of the individual, the resident, until they can be bridged into long-term care, as long as it's safe to do so. So we try to bridge.
They try to avoid going to a hospital or going to a family member's home.
Right, yeah, we try to bridge that, that transition. So we're usually aware of those folks because the community care would bring it to home care to make us aware. Yeah.
So for our online folks, the question in the room was, when you're on the wait list for long-term care and you're given the option to have a bed and you decline, what happens then and how many times can you decline? And then what does that look like?
Oh, it's a loaded question. I guess what we would ask, and part of the presentation, is that you're having the conversations with your care coordinator at home care, so we kind of understand the reason for maybe the decline or why the family are not ready for it. Used to hear the old rule, 3 strikes you're out, you know, it's not really a thing that we abide by now. We like to know the circumstance. There are families that aren't ready to move, like they may be on the list and maybe they've got services in place at home and they're thriving, they're doing well. They may choose to drop to the bottom of the list. You know, they may want to stay on, but come down, you know, their date will drop. And they're okay with that because they're not ready. And we would rather be putting people into the nursing homes that are ready and needing that service. So we really have to look at the broad picture of the needs of those on the wait list and who's needing to go there first, right? Yeah, I would say that is how we work. We need to kind of understand our wait list people. So we do have discussions. We meet, each county has an admissions committee meeting. Sometimes we talk about the families that are struggling, and if we do know that someone's in crisis, we do look at that family and they may be entitled to a crisis admission by community crisis.
So the question in the room for my online folks is if a family member is living at home and they need more care, where do they go? Is that correct?
What's my next step?
What's my next step as a family member?
Yeah, so if your loved ones, if you feel that it's changing their care needs, then you would reach out to your local home care office. And whether you already have a coordinator, you would talk with them, kind of update what's been changing. But if you're new to home care, then you'd have to go through our intake process and do an assessment, and then we'd follow up from there.
One more question. So I'll take the one question in the back, and then unfortunately, because of time, we will have to close out. But any additional questions, you can always contact the home care office and they're happy to help. So for my online folks, the question in the room was just paying for long-term care. How do you do that if there is a spouse that's needing care, but a spouse still at home? What are the things that they kind of look at when they're considering what you would be paying for long-term care?
As you had mentioned, we don't do the financial assessments. We do refer all the financial questions to the long-term care subsidization program. There's a different assessment for community care versus long-term care. They do not look at assets. I know that. They're basically looking at your monthly income. So that's what's considered as the monthly income for long-term care. Yes, there was. Yes, yeah, there was a change. You're right. Yeah, so it's just looking at your monthly income for that assessment.
It's been a wonderful and full day here. It's been a joy to get to connect with you, to get to meet some of you and see some of you again. I hope you have enjoyed the day as well, and that you've learned things, in particular, that you learned things that are going to be of value to you in your life and in your work. That's really what this is all about, is creating something that's going to have value for you going forward. Please remember to take some time to fill out the evaluation that's on your table. There's a QR code if you just want to grab it and do it online instead. We do read these evaluations, we integrate your feedback, and it'll help us with next year's conference, which will be in September, not in January. Finally, I'd like to give again a big thank you to our title and courtyard room sponsor, Bayshore. I'd like to thank our gold sponsors, the Health PEI Provincial Home-Based Care Program. There's so many staff here today from these teams. There's multiple across the island. Thank you so much. The PEI hearing consultants, as well as ASPEI. We have a representative here from ASPEI today. Definitely appreciate the support, as well as the Winslow Room sponsor, Harding Medical. And I wanted to take a moment as well to thank Andrew's Retirement, Redefining Empowerment Retirement Living. They're an info booth sponsor. I believe there was some Andrews Stratford folks around, as well as Darren Folks of Folks Production. He has an info booth at the back where he's talking about some of the work that he is doing. That's just amazing, and it's really telling the stories, allowing the people with dementia to tell their stories as well as other seniors. So please check out his booth before you go today. Thank you again to Rod Royalty Inn and all of the staff for the hospitality, for the venue. And lastly, I just have to again thank the Parkdale Sherwood Lions Club. And they're not here today, but we're just so grateful for our space downtown. I always like to mention them. So thank you all again. Take good care of yourselves. Take good care of those who are dear to you as well. And we look forward to seeing you next year. So thank you so much for coming. Thank you to the team as well. And we'll be around here for a little bit if you have questions, and otherwise we'll see you next September.